exclusively on fetal medicine since 2014, and she is skilled in advanced fetal scans, interventional procedures like amniocentesis, chorionic villus sampling, intrauterine blood transfusion, fetal reduction, radiofrequency ablation in monochorionic diamniotic twins. A hearty welcome to you, ma'am.
Thank you. Shall I get started? All right. So, thank you to the organizers for giving me this opportunity to talk on screening for aneuploidies. I suspect that, like me, for many of you, this would be something that we learned after our postgraduate training. This was not an integral part of my training, and what it means is that it has left lots of gaps in our knowledge and our understanding of the topic. So I'll be talking about the essentials, and I'll be presenting to you my take on screening for aneuploidies. I confess that I haven't covered all aspects of it. Some things I've deliberately avoided, and if you have any doubts, maybe we can deal with it during the discussion time. Before we go on to screening per se, a quick brush up of the basics of genetics. Now, all our inherited traits are determined by genes that code for different proteins. So genes are nothing but a segment of DNA that codes for proteins. Now, all that DNA is not lying around free in our cells. Instead, it is compacted into chromatin, which is organized as chromosomes. And you find chromosomes. I need a pointer, please. Pointer. Okay, all that chromosomes is, yeah, thank you. Okay, so all the chromosomes are found in a nucleated cell. So it's in the nucleus of the cells. We have 23 pairs of chromosomes, 46 in total, each arranged in pairs. 1 to 22 are the autosomes, and the final one is a sex chromosome. If you have an X and one Y, you're a male. If you have two X's, it is a female genotype. This picture is called the karyotype. So karyotype is a study of the chromosomal number and arrangement. And as the name suggests, aneuploidy, so this is a euploid chromosome. Aneuploidy, as the name suggests, is there's wrong number of chromosomes in a cell. So our topic today is screening for this condition, where the number of chromosomes in a cell is wrong. We are not going to talk about single gene disorders, which are problems with genes or of the DNA. So that is not what is going to be covered. Say sickle cell disease or hemophilia, those are single gene disorders. So when there's a wrong number of chromosomes in a cell, it could be that there is a gain of a chromosome, or it could be a loss. We've all heard of trisomy 21, you've heard of Klinefelter syndrome. So these are examples of trisomy. Monosomy is loss of a chromosome, and the only monosomy that we need to know is Turner syndrome, XO. If you have an extra complete set of chromosomes, it's called a polyploidy, like a triploidy or a tetraploidy. We'll not be talking about this. So these are few examples. Shall we go through it? The first one, what do you think is wrong here? There is an abnormality. From 1 to 22, they're all 2 in number. But the final one, there's only one X chromosome, so it's Turner syndrome, monosomy X. This one here, they all seem to be 2. Here you have 3, 2X and 1Y, so it's Klinefelter, right? And then this one, easy to detect, trisomy 21. So if you want to diagnose these conditions, you need a picture like this. Okay? This is a definitive diagnosis. They're not very common, thankfully. The most common one is Down syndrome, and we'll be talking mostly about Down syndrome today. Some studies say 1 in 700, some say 1 in 800. And I've listed out the other common aneuploidies here. Trisomy 21, 18, 13, monosomy X, trisomy X, Klinefelter, and XYY. Some interesting facts about it. All monosomies are lethal except Turner syndrome. You will never find one copy of chromosome 2. These fetuses do not survive. Most autosomal trisomies are lethal, autosomal trisomies, but 21, 18, and 13 can be viable. That is why we screen for them. And 18 and 13 do not have a very long viable period. They rarely go past beyond infancy. But trisomy 21 has the longest life expectancy. Sex chromosomal aneuploidies are quite common. You need at least one copy of X. And if you have that, it is a viable pregnancy. Now, there's an association with maternal age, and that's because we have a diploid cell which has to, by the time the sperm and ovum are formed, it becomes haploid. That is, only 23 chromosomes are present in a sperm and in an ovum. So when they come together, you get a complete 46 chromosome. But sometimes the chromosomes which are supposed to separate during meiosis do not separate, and you end up having extra copy of chromosome in the ovum or in the sperm. So if this is fertilized by another sperm or ovum which contains the usual normal one set of chromosome, you get a trisomy, and the other cell can have a monosomy. So this is why there's an association with maternal age, because non-disjunction, the chromosomes don't separate as the maternal age advances. Though I have titled it as screening for aneuploidies, in effect I'll be talking about screening for Down syndrome, because it's almost equivalent to that. Why? We don't start screening for conditions randomly. There are, in fact, criteria which tells us, okay, this condition needs to be screened for. And this criteria is not set by me, it is set by the WHO. So some of the things that they talk about is the condition should be important. You should understand the disease. I'm not going to go through all this. You should understand what the disease is. You should know the cause. You should have a test which can be applied to a large population to screen them. And then you should have a diagnostic test which can be easily applied. And then you should have some sort of treatment or remedy for it. There's no point screening for conditions and ultimately you're not doing anything about it. So among all the aneuploidies, Down syndrome is the one which kind of fits most of these conditions. Why? Because I already mentioned it's the most common autosomal aneuploidy. And if before the era of prenatal testing, Down syndrome used to account for 1/4 of all cases of mental disability. Okay, now things are changing, of course. And I mentioned earlier that they have a long life expectancy, which means the burden of care is not short-lived. It's a long-term thing that the parents have to grapple with. Also, it can be missed on ultrasound. Most people think that ultrasound can pick up conditions like Down syndrome effectively, but that is not the truth. Whereas trisomy 18 and 13, most of them have features on ultrasound. So if I had to do a screening blood test just to detect trisomy 18 and 13, I would probably not opt for it because ultrasound works fine. But for trisomy 21, ultrasound doesn't work very well. So the topic is actually screening for Down syndrome, the essentials. I'd like to take you through a little bit of history about how this all happened to me because it will help us understand where we stand today. The condition was first described in 1866, and a century later, the first prenatal diagnosis of Down syndrome was made. It took about 100 years, but this was possible because of some advances, like they identified that the cause is trisomy 21. So if you take a condition like autism, you still are not able to find what exactly is causing autism. But for Down syndrome, you have a known cause. You know that it is because of trisomy 21. And then by then, they had started doing amniocentesis. And mind you, the first diagnosis of Down syndrome was made even before ultrasound came into the picture, okay? Way back in 1968. So amniocentesis is what they used to diagnose this condition, not your NIPT or combined test. They took some amniotic fluid and then centrifuged it. They got the cells. And we know that inside the cells you will have chromosomes. So they cultured it and they were able to look at the karyotype. Now, once this happened, Down syndrome became a potentially diagnosable antenatal condition. Until then, it was a problem of pediatricians. But now, this was a condition that could be potentially diagnosed. It can have an impact. But the problems were caused and the risk of miscarriage. So it cannot be offered to all. What they did know was that it was associated with advanced maternal age. And they said that they're going to start screening for women who are older than 35. They're going to offer amniocentesis. This was not a magical number. This is simply because at 35 years of age, the risk for Down syndrome is around 1 in 250. And they knew the risk of miscarriage associated with amniocentesis was 1 in 250. So obviously, there is no point screening for conditions which are rare. Say for a 20-year-old, where she has a risk of 1 in 1,100, you would not want to subject all these women to amniocentesis. You're going to cause more miscarriage than detecting Down syndrome. That is why this 35, the age 35 has come up. So it doesn't mean that women who are less than 35 will not have Down syndrome. In fact, that is one of the reasons why screening based on maternal age doesn't work. Because though Down syndrome is more common in women after 35, the younger population forms a larger cohort. And which means even if the percentage-wise Down syndrome is less in this cohort, by the sheer number, you will have more Down syndrome babies being born to women who are less than 35. So you have to look beyond maternal age. Amniocentesis could not be implemented. I borrowed this slide from Dr. Kypros Nikolaidis' talk, and in one slide he puts what has happened over the years. 1970s was the age of maternal age-based screening. Then in 1980s, a rapid proliferation of serum analytes and the association with the Down syndrome became established. Alpha-fetoprotein was already being used for neural tube screening. They looked at all the profile in Down syndrome babies, and they realized that AFP falls in Down syndrome. Then beta-HCG increases, unconjugated estradiol decreases, inhibin increases. So they put all this together, and triple test and quadruple test came. In the 1990s, you had NT, PAPE, and beta-HCG. And look, your detection rate went up from 30% here to the 1980s was 70%, and here 90%. This is where we stand now. Okay, so why took this time and effort to explain all these things to you? Is that sometimes we see only age-based screening being offered, which means that we are actually undoing all the good work that has happened over the decades. So age-based screening should not be done. It should be universal screening, and we need to make the most of the advances that have happened over the years. So all women needed to be screened. This was always known, but now all women can be screened. So from screening based on maternal age, we move to universal screening. Let's understand a little bit about screening tests. Screening tests are like how you go to your airport security. All of us have to go through security check. And then if they find something suspicious, they check our bags. Okay? But we know that this is not a perfect system because, 9/11 happened despite security checks. So sometimes you still miss Down syndrome cases, and sometimes you inconvenience a lot of people because last time Sushant and I took a travel, they were checking all our bags and baggages. Okay, so that was a false positive. They suspected that we were carrying something, whereas we weren't. So screening test is not perfect. No screening test is perfect, but some tests are better than the others. How do you determine if a test is better than the others? You look at the detection rate. Detection rate means how much of the actual affected fetuses you are able to pick up. You actually want this number to be high. You want to pick up as many as possible, but you don't want the unaffected to be picked up. You want this number to be low. So any test which has got a good detection rate for a low false positive rate works well. So it's like passing it all pregnancies through a sieve, and you want to pick up these red dots, which are Down syndrome babies. You don't want these many chunks there. Okay, you want to bring it down. So this is all that screening test does. It just tells you this is at high risk, and you need to do more tests if a patient is screen positive. One thing we should all know is there are recommendations that if we are using a test for aneuploidy screening, it should have a minimum detection rate of 75%. Tests which detect less than 75% of cases should not be used, and this is important, I think, from legal point of view. Generally, the false positive rate is fixed at 5%. And if you look at all the tests that are available, combined test, triple test, quadruple test, triple test never, worst performance is becoming obsolete. It's because it's got a very poor detection rate. So sometimes we still see triple tests being done. It's a second trimester screening test. We really need to move on to quadruple tests. So I'll be talking about the first trimester combined test, quadruple test. Ultrasound-based screening is, again, some people do it, but the detection rate is less than 75%, so not recommended. I'll not be talking about sequential and integrated tests or triple tests. If time permits, I'll talk a little bit about NIPT. So the first trimester screening is done between 11 weeks and 13 weeks, 6 days. CRL is between 45 and 84. The components are age, NT, PAPE, free beta HCG, and FHR. FHR is only used to distinguish between trisomy 13 and 18 because trisomy 13 has tachycardia. We've discussed age. So NT, we all know enough about NT, the sonolucent area behind fetal neck. So if you look at unaffected fetuses, they have this distribution of NT, and if trisomy 21, this is this distribution, which means NT tends to be higher. Okay, there's a shift to the right in fetuses with trisomy 21, but note that there's a lot of overlap also. NTs increase in about 65 to 70% of cases, and 10 years back, this is what I used to do. This was when I joined MATA. Most people would not want to do a combined test. It is possible to generate a risk with the FMF software. But let's look at some pitfalls. Okay, this is a case of increased NT. NT was 3.1, but this was not Down syndrome. This was a cardiac anomaly, outflow anomaly. So what it means is that increased NT is not equal to Down syndrome. It can be associated with a heterogeneous group of conditions, and we really need to take some time and effort to study the fetus in detail and also look at other possible explanations for increased NT. PAPE is a placental product. Low PAPE is associated with placental dysfunction. That is something we need to remember. So when you're doing a combined test, sometimes PAPE can be low. Down syndrome screening can be low risk, but it is important to know that if PAPA is less than 0.4 mom, we should be starting them on low dose aspirin and following them up for growth and preterm labor. So, PAPA, the sensitivity decreases when you use it in screening, it decreases with gestation age. The earlier you do screening, the better it is. Optimal sensitivity is between 8 to 9 weeks. Decreased levels are found in Down syndrome, trisomy 18-13, and in growth restriction. HCG levels increase in Down syndrome. Raised levels are in pregnancy affected by Down syndrome, but in trisomies 18 and 13, the levels decrease. So when you combine all these things, you get a report like this, okay, where you have taken the FHR, you have taken the NT, you've taken the free beta HCG and the PAPA. Quite often patients, doctors or colleagues send us reports saying, I've got this value of beta HCG 35, is it normal? I have no idea, because what we actually look at is moms, okay? You see the moms here, that is what we look at, not the absolute value. What are moms? For every gestation, there is a median, that is the midpoint of frequency distribution, okay? And once every lab knows it, at 11 weeks, this is the median. Then they take the patient's serum marker and they divide it by the median. So if the median is 100, patient serum marker is 200, then you divide 200 by 100, the median becomes 2. So everything is converted into multiples of median. And we talk in that language because it's easy to understand and to explain. So in trisomy 21, beta HCG moms are increased, PAPA moms decrease, okay? The lab needs a little bit more information because there are some factors like weight, race, method of conception, smoking, etc., which can influence these moms. And if you don't give the lab this information, your screening would be wrong, which is why they have the form, filling up the form can be quite tedious. This is an important slide. For euploid fetuses, we say that the free beta HCG mom is 1, PAPA mom is 1. In trisomy, beta HCG we know increases, it is 2, double. PAPA becomes half. Okay? So when we look at a report, let's look at this one again. NT is okay, age risk is okay, free beta HCG mom is 0.92, which means it is around 1. It is not increased. All right? And look at the PAPA. PAPA is not decreased, it's 1.2. In fact, PAPA is more than expected. Which is why when you combine all these things, the NT is in the patient's favor, the age is in the favor, the biochemical profile is in her favor, which is why you get a risk which is very low. This is all that combined screening does. It just takes multiple factors and see, does it fit with the profile of Down syndrome? And based on that, they give you a number. And they say that the risk is 1 in 20,000. It doesn't say that there is no Down syndrome. It only means you can be very unlucky and you can be that one patient among the 20,000 who's carrying a Down syndrome fetus. So here there's a high-risk report. Why is that happening? NT is okay, nasal bone is present, but you look at, HCG is increased, 1.89. It is close to 2, PAPA is decreased. Okay? So this again alters the risk and you get a risk of 1 in 159. So this becomes a high-risk report. It is better to screen at 11 weeks than to 13 weeks because in all this NT Eulusheri, beta HCG Eulusheri, PAPA Eulusheri, we are trying to see the difference from the euploid, the gap between the euploid fetuses and the trisomy 21 fetus, the maximum difference you detect when it is closer to 11 weeks than to 13 weeks, 6 days. So if you look at this detection rate that they mentioned, 92, that is at 11 weeks. By the time it reaches 13 weeks, it's close to 80% detection rate. So combined test detection rate that we say, the gestation age has an impact. It is better to screen them earlier, closer to 11 weeks than to do it at 13 weeks. But we don't want to call the patients too often, once to come for serum screening and then to do an NT scan, because we also look at the anatomy during NT scan. So we have a good compromise when we screen them in around 12 weeks. So that is what most of us follow. We call the patients at 12 weeks. Why should we add other markers? So this is a case where the NT is 1.72, which is normal for the CRL, but the nasal bone is unossified. So if I had just gone by NT-based screening, I probably would have called this normal. But I noticed that the nasal bone is unossified, and because it's our protocol to look at DV, here there is no reversed A wave, but the DV is kind of shifted. Okay? So I started looking at other markers, and finally I decided there is a high risk for Down syndrome. We did not do screening, we did CVS directly, and it was Down syndrome. Okay, so adding markers increases the detection rate. Sometimes your NT can be normal, but if you have other markers like ductus venosus or anossified nasal bone or tricuspid regurgitation, then it increases your detection rate. It can also bring down your false positive rate. Anossified nasal bone is something that we deal with very often. It is important to remember that 1 to 3% of euploid fetuses also, particularly in our Asian population, they can have an anossified nasal bone. The only association of anossified nasal bone is Down syndrome, and trisomy 18 and 13. Sorry, I mentioned this both as 18. You don't have to worry about other problems. But ductus venosus and tricuspid regurgitation, again, they can be found in euploid fetuses and in chromosomally abnormal fetuses, but they are also at increased risk for cardiac defects and fetal death. Okay? So when you see a DV abnormality or a tricuspid regurgitation, we have to look beyond Down syndrome. It's also important to remember that most of these fetuses will be normal. We can offer screening for twins. We just have to tell the lab whether it is dichorionic or monochorionic, and remember that the detection rate will not be as good as in singleton for dichorionic. The false positive rates also go up. But for monochorionic, actually, the combined test works well. When should we not do? I think this is also important. If you found a structural abnormality in a fetus, right at the beginning of the talk, I mentioned that all genetic problems are not aneuploidies. They're not just chromosomal problems. If you've seen a structural abnormality, you should not screen. There is an abnormality. Screening is applied to the normal population. Once you detect an abnormality, then you have to move to the diagnostic mode and not offer screening. Second thing is if NT is more than 3.5 or more than 99. This is an error, 99 centile for CRL. Again, it is too high. You screen them, it is going to come positive. So don't waste your time and patients' money on screening when the NT is above 3.5 or above the 99 centile. We don't offer screening for triplets and quadruplets because a lot of false positive detection rate is poor. Also, there are twins with one miscarriage where the measurable fetal pole is still present in the second sac. Let's take a look at this. 29-year-old primary gravida, 14 weeks, 4 days, NT of 4.7. Will we screen? NT is 4.7. No, it's about 3.5. We will not screen. Okay, let's look at the, can you see PAPA is 0.71, not in favor of Down syndrome. 3-beta SH is also low. So this doesn't really favor, but because NT is this high, we'll not go for screening. We'll do a direct testing. But the problem is this is how the NT was taken. This was done in UP, not in Kerala. Let me reassure you. This is the NT. What can we make of it? When I saw the patient, NT looked pretty fine. How do we talk to them? How do we counsel it? So the thing that I want to emphasize is do it once, but do it well. I'm borrowing this from Dr. Suresh, because if you don't do your NT scan properly, your detection rate, everything is kind of haywire. You really cannot rely on a combined test if the NT scan has not been done properly. Okay? Second trimester screening is not operator dependent, in the sense you don't need a very good person to do your NT, which is why it can be quite appealing to many, but we should remember that the detection rate is lower. So we only offer it if we have missed the bus somehow. We missed the 11 to 13 weeks window. Like in NT, the gestation age is important. You need to do it between 16 to 18 weeks. That is when you get the best detection rate. Triple test, I emphasize once again, it is considered obsolete. Okay? The detection rate, if done well, is 81% for a false positive rate of 5%. The components are AFP. We know that AFP decreases. Unlike in open neural tube defects. So sometimes you screen for Down syndrome, but they come back and saying it's high risk for open neural tube defect. In that case, we need to look at the spine and cranium. The thing about AFP is you need to have a very accurate estimation of gestation age, because gestation age to gestation age, the values differ a lot. So if you get that wrong, you can have false positive result. Unconjugated estradiol is a form of estrogen that is produced only during pregnancy because it's made by the placenta using fetal substrate. And the levels are reduced in Down syndrome and trisomy 18 and some other conditions. Again, accurate estimation of gestational age is important. Inhibin A was the last entry into this. The advantage is that it has an impact. The impact on gestational age on the levels between 15 to 18 weeks is less compared to AFP and unconjugated estradiol. So this is kind of a stabilizing thing. Okay, when you combine all these things together, you get a 81% detection rate. So how does it happen? In trisomy 21, alpha fetoprotein is around 0.75, HCG is around 2, unconjugated estradiol is around 0.72, and inhibin A is high. So HCG and inhibin goes up, AFP and unconjugated estradiol comes down. So if you get a high risk report like this, it's because AFP is 0.72, comes down, HCG has increased, inhibin has increased, unconjugated estriol has come down, which is why the risk is 1 in 127. I think it helps to understand the serum markers a little bit. Otherwise, we only go by this and we sometimes do not pay attention to other things like increased AFP. It's not just a marker for open neural tube defect, it's also a marker for FGR. So you need to follow up patients with increased AFP for growth also. Okay, so we've done a screening. What next? These are some of the cutoffs we use. If it is more than 1 in 250, we still use 1 in 250. We go for invasive testing. Okay, 85% cases of Down syndrome will be picked up in this 1 in 250 cutoff. Between 1 in 250 and 1 in 1000, we go for another test, which has got a better detection rate called NIPT, because 14% of Down syndrome babies can still be picked up if you use this protocol. Less than 1 in 1000, we say chances are very low, but routine follow-up is what we advise. But remember, 1% of Down syndrome babies can still come from this low-risk group. And this we really need to understand and convey to the patient that low risk doesn't mean no risk. Okay? I do not have the time to talk about the non-invasive prenatal testing. I'm sorry, I've run out of time. A quick thing I want to talk about is that it is not as good as karyotype. Okay, because see, karyotype looks at chromosomes and Down syndrome is actually a chromosomal problem. What NIPT does is when placental cells die or the cell disintegrates and you have fragmented bits of chromosomes, that is the DNA, floating in the mother's blood. So when you take the mother's blood, you'll find cell-free floating DNA. 90% of it is actually maternal, 10% will be fetal. And you have this idea that if there's an extra copy of chromosome 21, then it is likely that the contribution of DNA from chromosome 21 will also be high. You'll have more DNA from chromosome 21 than expected. That is all that they are doing. Okay, they are not looking at chromosomes directly, which is why NIPT, I feel, is still a screening test. Okay, though we call it NIPT, it should actually be called NIPS. It's still a screening test. It should be used judiciously. It's a very good screening test, but you should know when. Unfortunately, I do not have the time. It's an entirely different topic. So only a normal karyotype can rule out Down syndrome antenatally. And this is something we really need to understand. But I would like to end with this. Okay, this has to be patient's choice. I might have an opinion about whether a Down syndrome baby has a right to live, to be born. I might have an opinion for or against. But those are my personal choices. If a patient decides she wants to terminate, I think we should just let her terminate without judging her. But if she also says she doesn't want to terminate, she doesn't want to know about Down syndrome screening, it's perfectly fine. Okay? And so all that we can do is offer universal screening to patients, talk to them, but also take their consent. If they're not willing for screening, they're not willing for amniocentesis, if they want to go ahead with the Down syndrome pregnancies, our effort should be to support them in all the way that we can. Thank you so much.
Thank you, Dr. Anita, for the enlightening talk. Any doubts?
Anita, just some common scenarios that we face. When the patient comes for screening, sometimes they give history of spotting or mild bleeding PV. And sometimes when we do the scan, there will not be any obvious bleeding, but we see a subchorionic collection. Small subchorionic collections we see. So in that case, will you advise combined test or what is the take on?
Actually, spotting or subchorionic collection is not a contraindication for screening. I've checked with the lab often. What you need to let the lab know is that if there has been a bleeding, also if the patient has taken HCG injections, because sometimes to support the pregnancy injection, HCG is given. But it is not a contraindication, Sabila. I checked with 2 or 3 labs.
Okay. And another thing, you said vanishing twins window. And sometimes when we do the screening, we see an empty sac without a fetal pole. In that case,
yes, that is you can go ahead and do screening if it's an empty sac. Only if you see a measurable CRL, that means the fetal pole is still there, then you should not do screening.
Anita, one more thing. Suppose we offer universal screening. Suppose one of our patients has missed her screening period and comes to us for an anomaly scan, and you see a few soft markers.
Okay.
How do you go about?
Okay, that's another thing that I didn't touch upon because it's a different topic. I really felt I wouldn't have time. So soft markers during anomaly scans, echogenic intracardiac focus, hydronephrosis, echogenic bowel, unossified nasal bone, short FL, short HL, ARSA. These are all considered soft markers that can pop up during your anomaly scan. Now all these have likelihood ratios, okay? And you need to be aware that there are minor markers and major markers. So if a patient, in this case, patient has not been screened at all, so we'll have to go by her maternal age-related risk. What you know is her age, and based on that age, she has a risk. Then when you see these soft markers, you need a software where you use these soft markers to adjust that patient's risk. So if it's a 24-year-old lady with echogenic intracardiac focus, which is a minor marker, it's not going to make much of a difference. But suppose this 24-year-old lady has two minor soft markers, say echogenic intracardiac focus and hydronephrosis. Then you don't know. Then the risk increases. And if you want the exact risk, you need some software. But generally, my policy is if there are two soft markers, then you offer at least NIPT. Okay? And if there's a major marker like ARSA, unossified nasal bone, increased nuchal fold thickness, and which was the other one, the major marker? There were four. Ventriculomegaly. Okay. So these four, you should offer invasive. Minor markers like echogenic focus, echogenic bowel, short FLHL, pyelonephrosis, you can probably still talk to about quadruple test or NIPT. You can screen. But if it's a major marker, go ahead and do an invasive. I think that is a practical way of looking at it.
What about twin pregnancy? When do you offer karyotyping?
Karyotyping?
When you see the NTs?
Okay, so twins, we always see DCD or MC, monochorionic or dichorionic. In a dichorionic pregnancy, you have to treat it like a singleton. If the NTs increase, the other markers, you feel that this should not be screened, it should go directly for invasive testing. That is what we do, like in a singleton. Monochorionicity, the problem is sometimes increased NT or NT discordance could be a sign of TTTS, because ultimately it's all cardiac dysfunction and venous pressure and all that. So there we are at a little bit of loss. But monochorionic with increased NT and discordance, I still would start with combined test, okay, and wait for the results, and I would assess for TTTS. And if I feel it's more TTTS than chromosomal abnormalities, I would probably not offer karyotype right away. But if there is any doubt, do an invasive. Okay, if you're not sure, if you're confused, if you feel you're not able to make a call, do an invasive, because that's the only way you can rule out chromosomal abnormalities.
Any more doubts? Thank you, Anita.
Thank you so much.
Thank you, ma'am. Dear delegates, let's give a round of applause to our first speaker. Her insightful lecture has truly broadened our perspectives and set a high standard for the rest of the conference. As a token of appreciation, I request Dr. Naveen Pillai, Medical Superintendent, Dr. Cherian Institute of Medical Sciences, to hand over the memento to Dr. Anita Joseph. Thank you, sir. Thank you, ma'am. I request Dr. Anita Joseph to hand over the mementos to our dear moderators, Dr. Rekha Rachel Kuriakos and Dr. Sabilai. Thank you, ma'am. From the next talk onwards, we have 5 minutes for the doubt clearing session, for the discussion. So you have been provided papers. Please write your doubts on the paper, and a volunteer would come and collect your papers 5 minutes before the finish of the talk, so that the speaker can clear them then and there. Thank you.
A volunteer will also be around you, amongst you, for clearing doubts with a mic. So you can either use that or you can write your doubts and pass it on to us 5 minutes before the session ends. For the next topic, the topic will be intrapartum fetal monitoring. For this topic, I call upon Dr. Lisama George as a moderator. She is a senior consultant in Little Load Mission Hospital, Chengannur, and she's also a retired professor and former HOD of Government Medical College, Kottayam. And for the talk per se, I call upon Professor Dr. N.S. Sridevi as our speaker. She's a emeritus professor in the Department of OBG and is working with Pushpagiri Medical College Hospital for more than 8 years. Before joining Pushpagiri, she has a vast experience of more than 23 years in various government medical colleges of Kerala. She retired from government service as professor of OBG from Government Medical College, Kozhikode. She is a postgraduate teacher for MS OBG run by MCI. She has done MBBS, DO and MD from Government Medical College, Trivandrum. We welcome you, ma'am.
We also invite Dr. Sati MS, Professor, Department of Obstetrics and Gynecology, Government Medical College, Kottayam, to chair the session.
Yes, a very good morning to you all. I'm a little reluctant to talk after the vibrant talk by Madam on infertility and other things, not infertility, anomalies, and respected chairpersons, Dr. Lisyaba and Dr. Sati, and all the senior faculty members, my students, my colleagues, and other friends. The topic for today is intrapartum fetal monitoring. So here in intrapartum monitoring, fetal monitoring, what are our goals? One, to ensure that the mother and fetus tolerate labor well. Assessing the fetal response to labor, that is a challenge, a really challenged one. Half of the stillbirth and 1/4 of neonatal deaths result from complications during labor. Intrapartum fetal surveillance prevent adverse perinatal outcomes, not to 100%, but a high percentage can be. Improving the quality of care is the most important strategy for decreasing stillbirth, maternal and newborn deaths also. Aim of intrapartum fetal surveillance is to detect potential fetal harm due to decreased oxygenation during labor, timely detection, prompt and effective intervention can be introduced, hence reduction in perinatal morbidity and mortality can be achieved. Identify the abnormal fetal heart patterns due to brain injury and implement effective interventions to prevent brain injury, perinatal morbidity and mortality. Identify the chain of events leading to hypoxia and brain injury. The chain of events are hypoxic acidemia, metabolic acidosis, neonatal encephalopathy follows, and that results in a long-term sequelae. So prevention of brain injury is the most important part. It's all right. Another way. That is one disadvantage of being. Thank you. So what are the methods of intrapartum fetal monitoring or surveillance? One is intermittent auscultation, as we all do, using the Finard svetoscope, stethoscope, handheld Doppler devices. Second is cardiotocography or electronic fetal monitoring, CTG or EFM. could be intermittent one or can be used continuously. Then the next is a fetal blood sampling, which we do not use only occasionally, and fetal scalp pH and fetal lactate concentration. Next is a fetal electrocardiography and pulse oximetry. Intermittent auscultation, as all of you know, it is the one which we usually follow using the Pinard's fetoscope, stethoscope or handheld Doppler device. The heartbeats are counted. It has to be counted for 30 to 60 seconds, and in absence of maternal and fetal risk factors, intermittent auscultation also will do. Better assessed with handheld Doppler device, which has got an amplification of the sound. And it is advantage in obese women in presence of polyhydramnios or in case of actively moving fetus. Establishing the fetal heart by auscultation, we have to count it for at least 60 seconds between contraction, not during contraction. After the contraction is completely resolved, follow-up assessment for 30 to 60 seconds. Normal baseline heart rate should be 110 to 160 beats per minute. The frequency of auscultation, there are established protocols for that. During the first stage of labor, till full dilatation, every 15 to 30 minutes during active phase of labor, and auscultate from before the start of contraction to after the contraction is over, not during contraction. It helps in picking up any change in heart rate after the contraction, as oxygenation to fetus is decreased during contraction. Any abnormal change, it has to alert the obstetrician. Each auscultation should last at least for 1 minute for the first time. Any abnormality is there, continue the auscultation for at least 3 contractions. That is the recommendation. The fetal heart rate can change. It will not be always the same. There are accelerations, there can be decelerations, tachycardia, bradycardia. The accelerations are actually reassuring sign. Abruptly rising above the baseline for 15 to 16 seconds. The decelerations are abruptly dropping below the baseline for 15 to 60 seconds. Tachycardia means a heart rate is above 160 beats per minute, and for more than 10 minutes is significant. Bradycardia, fetal heart goes down. It is below 110 beats per minute, lasting for more than 10 minutes is bradycardia. No drop after the contraction means the fetus is a compensated one. During the second stage of labor, the fetal heart monitoring should be more frequent. It should be done every 5 minutes during second stage of labor. After every contraction, during the pushing phase of labor, you have to look for it after every contraction. The intermittent auscultation is baseline fetal heart rate. You have to find out, that is 110 to 160 beats per minute, which is normal. Acceleration means there is a rise in the fetal heart rate, more than 15 beats per minute above the baseline, and it lasts for about 15 to 60 seconds, which is a reassuring one. The decelerations are abrupt drop below baseline lasting for 50 to 60 seconds. Then tachycardia, that is, all of you know, the fetal heart rate goes above 160 beats per minute for more than 10 minutes. Bradycardia is fetal heart below 110 beats per minute, which is also lasting for more than 10 minutes. Is there any drawback for auscultation? We are more of doing auscultation rather than any machines. So drawbacks, it is difficult to auscultate in obese women or when there is polyhydramnios. It is impossible to differentiate between decelerations caused by cord compression and by placental insufficiency. Intermittent auscultation will not make out baseline variability, which can be seen on cardiotocography. Is it mandatory to use cardiography in all labor women? There are RCTs which is comparing cardiotocography with intermittent auscultation. There is a reduction, the reduction in perinatal mortality is not that significant in these cases. And there is also no reduction in cerebral palsy, decrease in the neonatal seizures, associated with increase in interventions. It is associated with increase in interventions like cesarean section and vaginal operative deliveries. There is no difference in long-term neurological outcome. Cardiotocography is useful in assessing fetal heart rate when auscultation picks up abnormalities or when there is meconium strain like that. In low-risk women, it is not useful to improve the perinatal outcome. WHO does not recommend for low-risk cases, that is cardiotocography, in healthy women in labor also. If the fetal heart abnormalities are recognized on intermittent auscultation, switch over to cardiotocography so that you can have a better evaluation. What are the indications for cardiotocography? The maternal indications are maternal medical disorders like hypertension, pre-gestational diabetes, a case of previous cesarean section, induced or augmented labor, when there is a presence of chorioamnionitis, in cases of antiphospholipid antibody syndrome, and when there is oligoamnios. The fetal indications are meconium strain, already meconium strained amniotic fluid, fetal growth restriction, multiple pregnancy, preterm labor, postpartum pregnancies, and previous case of intrapartum asphyxia or death. You all know that what are the equipments needed for cardiotocography, and it can be performed by external or internal cardiotocography. External cardiotocography, there is an external monitor which detects the fetal heart rate. External toco transducer which demonstrates the beginning and end of contraction. Shows a relationship between contraction and fetal heart accelerations or decelerations. Graphic tracing can provide permanent record of the fetal heart rate and uterine contractions. And this may be of use if there is a complication occurring which we can explain to the woman and the relatives. Internal cardiotocography, the fetal heart monitor and intrauterine pressure catheters are available. Can be used in active labor with difficulty in using external monitors in obese women, and it gives a more accurate monitoring, fetal heart rate monitoring. Interpretation of the fetal heart rate pattern. The terminologies used are, all of you are aware of these things. The baseline fetal heart rate mentioned is between 110 to 160 beats per minute in a segment of 2-minute duration. Tachycardia, that is when there is an increase in the fetal heart rate, the heart rate of 160 beats per minute for 10 minutes or more. Bradycardia is fetal heart below 110 beats per minute for 10 minutes or more. Baseline variability is fluctuations in baseline fetal heart rate, irregular in amplitude and frequency. Then there are some periodic changes, that is accelerations. There can be transient accelerations in the basal heart rate by rate more than 15, lasting for 15 seconds. Decelerations are decrease in the fetal heart rate more than 15 beats per minute below the baseline, lasting for 15 seconds. So here is a picture of a CTG with a baseline fetal heart rate 130 beats per minute and having a good baseline variability. Here it is accelerations. Fetal heart accelerations are shown that is shown with the arrows. These are the fetal heart accelerations which you can record it. The causes for fetal tachycardia and bradycardia. Tachycardia, as already mentioned, and all of you know, it is more than 160 beats per minute. The common causes are maternal fever, could be an infection, the chorioamnionitis, drugs like beta sympathomimetics, or a fetal compromise. Bradycardia, when the fetal heart rate is less than 110 per minute, the causes may be, it could be a head compression, fetal compromise, and there can be a chain of events leading to hypoxia and brain injury, which we may detect it later. The decelerations, as already know, there are 3 types: early deceleration, late decelerations, and variable deceleration. Early deceleration means there is a gradual drop in the fetal heart rate during uterine contraction. The cause is head compression. Late decelerations, gradual drop in uterine contractions. The nadir of deceleration coincides with the peak of contraction. There is no fetal hypoxia in such cases. Variable decelerations, it is of variable duration, intensity, and timing. Resemble letters like U, V, or W. May be seen even in a normal labor. Persistent, deep, and recurrent variable decelerations are indicative of fetal acidosis. Prolonged decelerations are ones which last for more than 2 minutes but less than 10 minutes. If it continues for more than 10 minutes, consider as bradycardia. Indicate prolonged it could be a prolonged cord compression, could be hypotension, or severe acute placental insufficiency. Then what is called the sinusoidal pattern, where the fetal heart rate is 120 to 160 beats per minute, variability is markedly decreased or even absent, no accelerations, oscillations are 5 to 15 beats per minute. Indicates fetal anemia, could be a fetal anemia, severe hypoxia or acidosis. So fetal heart where there is early decelerations, showing early decelerations in a tracing. The nadir of deceleration corresponds to peak of contraction. And here it is a late deceleration where the onset at peak of contraction. Variable decelerations, as mentioned earlier, varies with uterine contractions. And this is the typical sinusoidal pattern. The fetal heart rate patterns in second stage of labor, variable decelerations in every contraction, fetal head and cord are compressed, and that is the reason. It is difficult to interpret in a CTG also. Patterns suggestive of fetal hypoxia, decelerations to less than 70 beats per minute, loss of variability, and persistent baseline tachycardia or bradycardia. These are some of these patterns suggested. Then there is a 3-tier fetal heart rate interpretation system mentioned. Category 1, Category 2, and Category 3. Category 1, or it is a reassuring one, we don't have to worry about. Category 1 by ACOG or normal by RCOG is mentioned. Normal fetus, tolerates labor well, no fetal acidemia. The baseline heart rate will be as normal as 110 to 160 beats per minute. Absence of late or variable fetal heart rate decelerations. The variability is also normal 5 to 25 beats per minute. The fetal heart accelerations may be present or absent. Early deceleration may be present or absent. That is the Category 1. It is a reassuring one. We are not unhappy with this. So Category 1 tracing, showing the fetal heart rate, the contractions, and the lower phase. Category 2 tracing, intermediate fetal heart rate patterns, no clear indication of fetal well-being. It includes the following features. One is tachycardia, then bradycardia without absent variability, minimal or marked variability, absent variability without recurrent decelerations, prolonged decelerations lasting for more than 2 minutes but less than 10 minutes, recurrent variable or late decelerations with moderate variability. These are the features of category 2 tracing. Coming to category 3, non-reassuring tracings. It is totally non-reassuring. We become worried. Abnormal, there is increased risk of fetal hypoxemia, can lead to ischemic encephalopathy or possibly even cerebral palsy. The tracings, variable decelerations, bradycardia, these are the tracings you get. The tracing will show variable decelerations, bradycardia, recurrent late decelerations. And in category 2 and 3, if you detect such a tracing, we have to go for, if facility is available, we have to go for test for fetal acidemia. And fetal scalp stimulation test also could be done. And that can rule out hypoxia and acidemia. On vaginal examination, stroking the fetal scalp, fetal heart acceleration occurs equal to or more than 15 beats per minute above the baseline, and it may last for 15 seconds. And if so, that is a positive test rules out fetal acidemia, a very simple test you can do. Fetal blood sampling, if the pH is 7.2 or less, it indicates acidemia and requires immediate delivery. So the management of labor in category 1, category 2 and 3. Category 1 usually tolerate labor well, the fetus. CTG tracing reviewed every 30 minutes in the first stage of labor and every 15 minutes in the second stage of labor. Category 2 and 3, the tracings are suspicious and we get worried, and the aim is to manage delivery before acidemia sets in. That is, gives a better outcome. ARM, amnioinfusion, improved oxygenation and scalp stimulation, all these can improve the outcome of these cases. Interventions in category 2 and 3 tracings. Admission test, as we all do, CTG for 20 minutes. And even if there is decrease in uterine activity, it's better not to start oxytocin immediately. And if necessary, tocolytics like terbutaline can be given when there is hyperstimulation. Improve the uterine blood flow by changing the position of the woman to left lateral position. IV fluids, 500 to 1000 ml. Ringer lactate is the one which can be used. If indicated, you can go for amnioinfusion. Institute oxygen mask and assess the progress of labor. If indicated, stimulate the scalp for acceleration. So to conclude, in normal course of labor, uterine contractions cause decrease in the uterine blood flow with a decrease in oxygen delivery to the fetus. Admission CTG always in high risk cases. Normal course of labor, contractions cause decrease in the uteroplacental blood flow, decrease in oxygen delivery to the fetus. Fetus scalp stimulation is a very simple test for ruling out fetal acidemia, which we can very well do in these cases. Thank you all for the patient hearing.
Thank you, madam, for the enlightening talk. That was very interesting, even though it is a very common and we see all these problems in our day-to-day life. So any questions, any doubts, you can clear from our eminent madam. Please.
Any questions? Madam, it was a very elaborate talk. Actually, interpreting CTG is very important because, if there is a single deceleration, then there is actually now the Foxy has taken up initiative of reducing cesarean section by 4-pronged approach. One is by Robson. The next is one approach is by correct interpretation of CTG. That is, in cases of even if there is any single deceleration or early deceleration, there is a tendency for taking up for cesarean section. We can understand when in a small hospital, when the single-handed running single obstetrician hospital, then the circumstances will be like that. But it can be, more trial can be attempted in a larger hospital when there are more obstetricians, when there is in-house anesthetists and all. So correct interpretation of CTG is very important. So madam, you have given the correct management of category 1, 2 and 3. Thank you, madam.
And it is very difficult to interpret CTG at times. And we are in a dilemma, whether to go for a cesarean or to wait for a vaginal delivery. Always it happens.
Madam, so many questions are there for you. First one, how long can we wait for a patient in latent phase of labor with persistent variable deceleration with no alarming features?
Variable decelerations, there is no such recommendation how long to wait. No written document is there, as far as I know. Latent phase, you wait, monitor carefully, and look for any other, that is maternal factors, fetal factors, the maternal dehydrations, all those things have to be ruled out, and then manage weight. If you have proper facilities for monitoring the fetal heart rate, you can wait. That is my impression.
This is only a variable deceleration, persistent
variable deceleration only.
Okay. Then the next one is, can vibroacoustic stimulation be used as a reliable marker for ruling out fetal acidosis in centers fetal blood sampling is not available?
Vibroacoustic stimulation can be used when?
Can vibroacoustic
yes,
be used as a reliable marker for ruling out fetal acidosis where there is no facility for fetal blood sampling?
Yes, definitely you can use. Only thing is, can be used. If facility that is available, yes, acoustic stimulation can be used. Doesn't produce any harm.
Okay, ma'am. It can be used similar to fetal scalp stimulation.
Fetal scalp stimulation.
Madam has explains. Then
if it is available, yes, you can use. Otherwise, you go for a fetal scalp stimulation.
Madam, third question is, during TULAC, how to proceed further if CTG shows persistently reduced B2B variability with no acceleration or deceleration and is not responding to usual resuscitative measures? Only B2B variability is reduced, no acceleration or deceleration.
B2B variability is reduced. You have to consider both the maternal aspect and the fetal aspect. Dehydration, ketosis has to be corrected if it is there. That is very, very important. Then, still, if it is not picking up, wait for some more time. The liquor, it is clear or not. If it has already ruptured, yes. Otherwise, in a case of previous cesarean, we will not go and do an ARM, artificial rupture of membranes, if it has not progressed well. And if you are waiting for a vaginal delivery, good. If you have a proper monitoring facility, you can wait.
That is, madam, if there is no further deterioration, you can wait with further with close monitoring.
Close monitoring.
Okay, madam. Thank you. The next question is there any proven role for intraamniotic saline infusion in the setting of persistent variable deceleration? Amnio infusion in variable deceleration.
Variable decelerations. Amnio infusion, previously we used to do amnio infusions more frequently, but now it is not being followed. That is my
conflicting data, but madam, but practically it is found to be useful.
It is of use. It is of use, but especially when there is a reduction in the fluid oligoamnios.
Oligoamnios
Yes, that does good for the fetus also.
Madam,
and the obstetrician.
Next question is meconium stain liquor. In meconium stain liquor and fetal heart rate is normal, how long can we wait?
That depends. In a patient who is in labor, sometimes she may progress rapidly and deliver. Then you have to have a close monitoring. That is the most important thing. And the contractions. If the contractions are not adequate, you can accelerate uterine contraction using oxytocin. But you may think twice before starting oxytocin, because you may think that when you start oxytocin, again, further meconium may come or not. So you have to take a decision whereby you have to weigh between the two. Don't go and immediately do a cesarean section.
Okay, ma'am. Thank you, madam. I would like to add one more thing, that is role of ultrasound in intrapartum monitoring.
Very important.
Very important. That
very important.
We can add, if there is facility, we can add intrapartum ultrasound.
It's a very, very good facility nowadays where you can have an ultrasound in the labor room.
And in my opinion, every patient, other risk factors also to be considered, and the cervical dilatation, cervical factors, progress of labor to be.
Sure. Thank you, madam.
Thank you, madam. Thank you for the wonderful discussion also from the delegates.
Thank you, ma'am. A big thank you to Dr. Sridevi, ma'am, for sharing your expertise gathered from your vast experience with us. Your passion for the topic was brilliant, and it was a very engaging presentation. It kept us all captivated. Thank you for your brilliant contribution to our conference. Please, moderators, also please stay on stage. I call upon Dr. Soshama, Senior Consultant in OBG, to give away the memento to Dr. N.S. Sridevi, ma'am. I also request Professor Dr. N.S. Sridevi to give away the mementos to our moderators, Dr. Lissamma George and Dr. Sati. Thank you all. We also welcome the Vice Consul of Consulate General of UAE in Kerala, His Excellency Mr. Mohammed Musabe Salim Musabe Al Shamsi. He has joined us now, and we, the team of KMC Hospital, wholeheartedly welcome you to this knowledge feast.
Dr. in reproductive medicine from Christian Medical College, Vellore. We welcome you, sir.
Good morning, friends. Dr. Raju is no stranger to the August gathering. The topic which he is going to discuss has baffled the all of us who work in the field of assisted reproductive technique and reproductive medicine. We all know that this is a very difficult clinical situation where you always face. We are very well aware of molecular classifications and various criteria like post-dawn classifications and various regimes such as flare-up technique or inactivation follicles and growth factors in clonidine negative groups of patients, or even intravaginal injection of ovarian follicles with the PRPs. All these things, which various regimes have been discussed and tried, but so far we are still faced with a difficult situation. And as far as we are concerned, we feel a lot of elderly patients where we have to help them, but it is a very tough situation, and I am sure that Dr. Raju will enlighten all of us on that. Over to Raju.
Thank you, respected chairpersons. And first of all, I thank the management of KM Cherian Hospital and my friend and my colleague and my student, Dr. Sisija, for the invite. So, and once I came into this hospital, I'm actually overwhelmed with the response and the hospitality that's rendered. I'm totally impressed. Thank you. And I wish all the best for this conference, and the staggering audience itself is a answer to this success of this conference. So my topic is a very relevant topic nowadays. That's the poor ovarian responders. Because we know that infertility is a growing concern, and day by day a lot of infertility centers are coming up. Is that just meaning that so many infertility couples are moving around? So the most distressing situation we do come across is a poor response to ovarian stimulation when it matters to an IVF stimulation. So the problem of poor ovarian response is more than what we expect, because what we say as poor ovarian response just by looking at the follicles is actually the tip of the iceberg. Actually, we are discussing little more about the impaired oocyte quality, the problems with the reduced fertilization and the embryo development, and obviously a lot of other variables, the cycle cancellation, the economic burden, and obviously the psychological burden to the patient because of this poor response is a huge matter of concern. So there's an interesting article by Denis Sakas published in Human Reproduction, what the Mother Nature has told us about the concept of fertility. Because we all know that we are aiming for one simple thing, the live birth. So in order to achieve this live birth, the most important thing is obviously how healthy the embryo is. And in order to get this embryo, we have two variables. One is egg and one is sperm. And of this, 80% or 70 to 80%, the determinant is the oocyte quality. Means if the egg quality is bad, your ultimate aim of live birth may not happen for sure. So this is the exact situation a poor ovarian response matters. Because when we stimulate, we come up with a very abnormal or a bad shaping oocytes, ultimately leading up to a failure of the entire IVF cycle. So this is the Mother Earth told us. So when we think about an IVF treatment cycle, initially our aim is to get a follicle recruited. So suppose the patient is having, say, good antral count and we are stimulating. And ultimately we land up in oocytes with so much abnormality. This we able to pick up only after getting the oocyte and denuding it. So the so-called patients of unexplained infertility, that's nothing is happening, there's no concrete evidence to say that this is your problem. Ultimately, on day 0 of a collection, you will find up with the surprises. So when this surprises happens, definitely we will land up in not a great quality embryo development. So nowadays, we are aiming for an important aspect of development of a chromosomally normal day 5 embryo. So how much we are successful in creating this is the crux of the entire fertility treatment scenario nowadays. So we know that the new kid in the block, the new investigation, the anti-Mullerian hormone definitely leads us in a good way to plan it. So each and every lady should have on his radar that whether my AMH is in the safer ground or not, in order to have a baseline account that we are at a safe ground of not being a poor responder at a later stage. Because this is one investigation we can easily predict a poor responder to a limit. So I'll just put across a simple scenario of two Indian ladies. One lady is just 28-year-old with a low AMH with previous 2 episodes of poor responder. And another lady of around 42 with a better AMH with a previous poor responder. If these 2 ladies go in for an IVF cycle, who will conceive first? Any guesses? The younger or the older one? Obviously, the answer is the younger one, in spite of being a poor responder or in spite of being a low in resources. So, the number of oocyte collected and the number of pregnancies. On the y-axis, you can see the delivery rate or the embryo transfer, delivery rate. So, if you are able to collect at least 9 or 10 oocytes, for an younger girl, the chance of pregnancy is close to 30%, but for other lady, even though the oocyte numbers are good, the chance of pregnancy is less than 10%. So ultimately, it boils down to one single thing, the female age. Because we cannot supersede that biological clock for sure, whatever be your problems, whatever be your medication, whatever be your sciences. So the basic dictum is identify those subset of people at an younger age, treat them young, and get her motherhood as early as possible. So poor responders can be broadly divided into 2 things. One is the expected poor responders. Because of the obvious features like age, low AMH, we know that she's going to behave abnormally. But there is a subset of class is actually evolving, and unfortunately in a very rapid phase. That is so-called unexpected poor responder. That we see or we feel, or by the investigation, that the patient is stable and the AMH is good, AFC is good. But when we stimulate, we'll end up in a very bad quality numbers as well as quality. So when definite answers are not there, we'll put into receptors and genetics, all sort of thing. But definitely FSH receptor polymorphism is one of the common leading cause. But how we can overcome it is still an enigma. So I take the audience attention to this interesting concept of FORT, that is follicle output rate. Suppose we have a patient with a very good preantral follicles, and when we stimulate with a very good AMH, say there are around 10 odd follicles here, but ultimately we'll end up in hardly 4 or 5 dominant follicles. And another situation, we have only 5, but ultimately land up in 5 follicles, the optimum. So this unexpected level can happen in close to 30% of the patients we stimulate. That we feel that the patient is good in her AMH and AFC, but the patient responds in a better way. So this is called follicle output rate. Why this is happening, or what are interventions we can do to modify these things, is a very interesting concept, and that is the crux of my entire talk today. So before venturing into any topic in medicine, we should have a definition what it is. So till 2011, there is a lot of debates on what actually defines a poor responder. And you can see that there are 41 definitions, and based on these 41 definitions, without a concrete definition, we have 47 RCTs. So you can see how diverse or how immature were knowledge on this concept. So our society, the European society, has come up and addressed this issue. In 2011, we had a criteria called the Bologna criteria, which come up in the light to identify or to define what is poor ovarian responder. I'm not going into the details, but the science is an evolving thing. Later on, even though 2011 it has come up, 2014 itself, the challenges on or criticisms on Bologna criteria has come up, that it is not a homogeneous representation, and it is not taking into consideration of the many factors, considering only the age. The heterogeneity of the patients are not taken into consideration, and the clinical utility of this criteria is not of much valid. So with this pretext, the science is evolved and definitely moved to a better criteria to diagnose, which has got more clinical relevance. That is called the Poseidon strategy. This is a simple thing, patient-oriented strategies encompassing the individualized oocyte number. So the advantage or the beauty of this classification presented in 2014 is that it has got the qualitative and quantitative ovarian response in consideration, and the ultimate aim of getting one euploid embryo should be the end point. So how we can modify or rather group our ladies who are planning for IVF into 3 or 4 different groups, Poseidon 1, 2, and 4, 3 and 4, so that how we can judiciously use our ovulation regime to achieve the role of getting into a euploid blast. 2014 it has come, but later on science is evolving. There's a recent SWOT analysis has come on this aspect. So here also there is plus and minus. But the biggest plus is that it has got a better standardization for low prognosis patients, because age itself is not the only criteria to consider. The other considerations also come into play. And they have in the opportunities, there is something called an ART calculator predictor. That means a 40-year-old lady comes to you with an AMH of 1. So how many oocytes are required to produce one euploid blast? The answer comes to around 19 oocytes. And will you be able to produce 19 oocytes from a 40-year-old lady? Practically may not be possible. So this will give you a realistic indication for the lady that what we are going through or what we are going to face by doing the so-called infertility treatment. So the realistic expectation of the treatment can be addressed in a better way if you go for this Poseidon criteria. Then coming to my topic per se, what we can do. So we can do many things to overcome this. One, the pre-cycle planning. During the cycle, the initiation and during the stimulation protocol, during the laboratory phase, and obviously the panacea of all answers is the third-party reproduction. So what we can do in the pre-cycle? Because we know that the follicular genesis is not happening from the day of menstruation. It has got a pre-menstrual phase or the pre-conceptual phase. So it's a simple question to answer. Every lady has a normal menstrual cycle and only one follicles get dominated. What is the reason that the destined one becomes the dominant one? Because of the follicular level, androgens levels are more in those follicles. So the concept of increasing the androgen milieu in the follicle will increase the chance of a better FSH responsiveness so that the follicle recruitment can be better. So with that pretext, a lot of androgens has been pumped into the body to get a poor responder to a better responding lady. So the first and foremost is DHEA. And it has been used world over, even today, with great success. But how much is evidence to support this is a question of debate. Because it has, the concept is simple, it has got an androgenization of the follicles. So there is a meta-analysis come up which increasingly, significantly higher ongoing pregnancy published in 2011. But later on, the meta-analysis has got a problem because it has to analyze on the quality of evidence or the quality of the studies it has been analyzed. So if you look into the high quality trials were considered, the success is not that great. But if you're considering the moderate quality evidence is also incorporated, definitely it has got a positive value. And the disclaimer is that it is considered as not as a pharmaceutical agent, it is considered as a nutraceutical agent. So the problem is, noteworthy is that the oral DHEA formulation are dietary supplement and therefore not regulated by FDA or EMA and are exempt from pharmacological quality standards. Consequently, the true standardization of the formula cannot be guaranteed. This is a problem with even with the pharmacology industry as well as with nutraceutical. Say we say 75 milligram, it doesn't mean that it contains 75 milligram. Even in pharmacology, it has 15% plus or minus. So in nutraceutical industry, it can be even worse because there is no quality standardization for this. So whether this 75 milligram is sufficient or whether the 75 milligram is there in that molecule which we are giving, we never know. But definitely there are some studies to prove or substantiate that it has got some benefit because the concept is correct. Then the testosterone, putting the testosterone directly into the lady. So this also has got interesting 2 trials. In 2015, it has got an increase in the live birth rate. Then comes a very landmark trial called a T transporter trial, which published recent ESHRE in 2023. So the initial levels showing that it has got increase in the live birth rate with a confidence interval of 1.3 to 5.2 with moderate evidence. But when it comes to the high quality trials, still it is debatable. So in the last ASHRAE, this bubble has broken because the annual, European Society meeting is a usual center for publishing all these landmark trials. So the T transporter studies has come up. So what they do is that they give 5 grams of testosterone gel before the stimulation, maybe 2 to 3 months prior, and continue and do the pickup. So the answer is that this multi-center RCTs found no significant difference in the number of total mature fertilized oocyte by the pre-treatment administration of testosterone in likely poor responders. So that bubble is also burst in terms of poor responder with this T transporter analysis. Then another option we can calculate is called the cycle synchronization. That means before the stimulation, we give estrogen tablet from day 20 to day 2 of the cycle. So when we give estrogen before the cycle, this E2 will regulate the folliculogenesis so that a more synchronized follicle growth will happen so that the asynchronous development will be hampered. So we will get a better oocyte harvest so that a better quality and quantity of the oocyte. Here also the meta-analysis shows not of much use, but maybe some studies showing benefit in this also. Then for anything in modern medicine, the magical drug is antioxidants. Here also the same. But how much these antioxidants will help is actually a concern. So the logic is simple. Antioxidants like coenzyme Q, it has got a counteracting the physiological ovarian aging and restoring the mitochondrial function and augmenting the embryo cleavage and blastocyst generation. The studies to support and distribute is both there, but one recent study published in 2018 about this coenzyme Q per se. Coenzyme Q supplementation in COH improved the patient response to ovulation induction and decreased fetal aneuploidy in older patients. But whether it has achieved the statistical significance, no. So maybe with some more evidence, we may come with a better or a poorer answer for antioxidants in this subset of patients. So that of pre-cycle management to an end, I'll sum up in the later slides. The next option is during the cycle, what we can do. There is no single best protocol that can transform a low responder to a hyper responder. That is a simple, straightforward answer. Whatever you do, a poor responder will always be a poor responder. So there are different protocols has been analyzed, but look at the pregnancy outcome. It is not difference in the pregnancy rate, whatever be the protocol change you do. So what is the most common mode to manage the poor responder? Just simple one thing, increase the dose. Because that is what we do, starting from 225 to 300 or 300 to 600. But will it actually have any role? Because it's like beating the old horse. So it has been clear that these patients have a reduced ovarian reserve and the recruitable follicles are fewer to gonadotropins. So whatever be the stimulation, the remaining follicles will only grow. So if you just bombard them with a high dose, the only thing you do is financial droppage to that lady, nothing benefit to the oocyte quality and the numbers. So the maximum stimulation to be cut short. This is an interesting concept because we are aiming for the probability of the live birth. And what are the variables? Age is a variable, quality of the oocyte is a variable, and other non-epigenetic factors are the variables. And only thing which we are bombarding with the FSH is the number of follicles. So will that alone will categorically change the entire concept? No. So increasing the follicle stimulation drug dosage will increase the number of follicles, but the quality of the oocytes will be improved. Definitely the answer is no. So don't stimulate more than 300 IU. The standard dose is around 150 to 225 or to a maximum of 300. So there's an interesting trial called the Optimist trial. So it's actually compared the poor responders as well as the high responders. I'll take the poor responder data. It's published in 2017 with those patients with an AFC of less than 10. They randomized 2 patients with one arm with 225 to 450 IU per day and another arm with just 150. So obviously when the lower doses, the cancellation rates were significantly higher. The number of oocytes retrieved were also categorically less in low dose patients. But look at the pregnancy rate. It's equivocal. So by increasing the 450 or 600, we are not increasing the pregnancy rate. the final answer is the same. So why you want to bombard with high dose to the poor lady? So this question has to be answered in our day-to-day life. So mild stimulation should be the goal for the future. So the ESHRE guidelines also categorically says that it is unclear whether higher gonadotropin is recommended over 150 in poor responders, and that dose higher than 300 is not indicated at all. Then addition of luteinizing hormones is a big topic to cover, but as one important landmark trial called the ESPA trial published in 2017 is comparing the addition of recombinant LH in those poor ovarian responders categorized by the Bologna. Close to 1,000 people were randomized, and recombinant FSS plus LH versus recombinant LH FSS was compared, and we can see it is actually powered for the oocyte number, and the oocyte number is high. But when it's powered to the live birth rate, it is equivocal. So maybe in those subset of patients with advanced age, where the LH preponderance is low, where an expected poor response is expected, LH supplementation may have a role to play. Then double stimulation, that means stimulating at different phases of the menstrual cycle. Because there is something called wave theory of folliculogenesis. Because in one menstrual cycle itself, we have 2 or 3 waves of follicle recruitment. So capturing these different waves in the same cycle so that the maximum oocytes are harvested in the same cycle. This is called a dual stimulation or double stimulation. Has been tried, but unfortunately there is no RCT, but can be tried in those patients who are not keen for any advanced, third-party reproduction stage of treatment. Then the oocyte and the embryo accumulation. That means stimulate mildly, aspirate 1 or 2 oocytes or 3 oocytes, get into embryo. So the number of oocytes and the embryo can be accumulated so that at a later stage we can transfer and get the pregnancy. So that their own biological material can be used for future. That can also be tried. Then growth hormone. Sir has rightly pointed out the importance of growth hormone. It has come up in a big way about the usage of growth hormone in poor responders. There are very good trials favoring the outcome should be in a better rate in increasing the live birth rate and the CPR. But the quality of evidence is not that great, but definitely it has got a promising answer. Platelet-rich plasma, from baldness to testicular failure, you can use this. So the same is applicable here also. But will it has got any use? There is no RCT to prove. So answer is debatable. So the future is always promising because we have this follicle activation, so-called gamete repairing, and the stem cells is the new kid in the block. But definitely too premature to comment on any of this, but definitely encouraging results are there. So the best is yet to come for that. So to sum up my talk, ESHRE guidelines on poor responder is a Bible for reproductive medicine, the guidelines submitted by the ESHRE, like RCOG for obstetricians. Minimal stimulation with gonadotropins is recommended. Dosage more than 300 IU is not recommended. Modified natural cycle not recommended. Agonist versus antagonist protocol are equally recommended. Adding growth hormone, testosterone, DHA not recommended. Double stimulation poor responders only in research setting. PRP only in research setting. This is an optimum consideration. So to sum up my talk, pre-cycle, addition of androgens. The initial evidences were encouraging. In day-to-day practice, definitely we do try this. Follicle synchronization, in poor responders we tried, not encouraging, but those patients we are planning for an antagonist cycle, follicle synchronization definitely get a cohort of follicles. Antioxidants definitely may play a role, we use it regularly. During the stimulation, dose hike and all other things is actually is a misleading thing, should not be used. The maximum dose should be 300 IU. Role of LH for indicated patients, definitely yes. Minimal stimulation, definitely yes. Adjuvants, there's a lot of hiccups, so use judiciously. The laboratory perspective I have not covered, but ICSI for all is a highly debatable topic. PGD, day 3, day 5 transfers, early transfer versus sequential transfers, still debatable. IVM and oocyte accumulation, cori-cori. Trophectodon biopsy and pre-implantation genetic diagnosis for all, still debatable. And third-party reproduction, and everything fails, obviously give a wonderful answer. This is in a nutshell about the management of poor responders. So what we practice in our hospital, because we do speak evidence, but what we practically do also very important. And it is always to have a balance of these two. The 3 pillars that I follow in my practice with poor responders: counseling, give them the realistic expectations, and tell them the importance of perseverance, because that is the most important thing to follow. Pre-treatment with BHA, definitely I do try. Protocol, first line is always an antagonic protocol, but if it's a failed antag cycle, I try an agonic cycle. Starting dose is usually 225 to 300, never more than that, because there's no point in increasing the dose. And the drug, for a poor responder, I prefer LH containing drug like HMG. So, thank you for the patient listening.
Any questions from audience? Sir, I have a question. When to do the AMH level? If an infertile couple comes, when do you advise the AMH to be done?
This is not about poor responder, just a plain infertility patient comes. In my practice, I preferably, unless it's a PCO and ultrasound, I preferably do an AMH in my first visit itself. Why? Because whether it should be translated to the primary level physicians is a question of debate. But as a tertiary level physician, the patient will be coming to not as a first line consultant. So in those subset, if the scan showing a good antral follicle count, okay, justified. But if the antral follicle count is not that great, because that's the importance of doing scan by ourselves, then we are able to identify the follicles. If in doubt, definitely do an AMH and correlate clinically. So the bottom line is to find the so-called premature ovarian aging patients. So antral follicle count and AMH with these two in together can pick up close to 95% of this subset. So we can do a job.
Thank you, Dr. Raju. It's an extensive talk and within the shortest period possible, and various factors of influential factors and factors which sort of block the proper treatment of the poor responders are all discussed in detail. Various treatment modalities have been discussed, but at the end of the day, we know that we are left with nothing but just another big query on how to go ahead with. Thank you, Dr. Raju.
Any other questions from the crowd?
Any questions from the floor?
If there, you can raise your hand. We will hand over the mic. All right, thank you. I'm sure you all agree that our speaker delivered an outstanding talk. Their depth of knowledge and clear articulation made the complex subject matter accessible to everyone here. We are truly fortunate to have had such a brilliant mind enlightening us, sir. Thank you. I invite Dr. Sunil Agarwal to give away the memento to Dr. Raju. Thank you, sir. Moderators, please be on the stage. Thank you. Come on, crowd. Give them a big round of applause. Thank you. I request Dr. Raju to give away the memento to the moderators. Thank you, sir. Thank you all. A small announcement. Attention. We are pleased to announce that a black smartwatch has been found in our vicinity. If you have recently misplaced your watch, please contact us. Thank you.
Dear all, now we have an international talk by Dr. Sharmila Makhija, MD, MBA. She will take us through the Alice L. Walton School of Medicine and giving birth in America, Florida. Dr. Sharmila Makhija, MD MBA, is the founding dean and chief executive officer of Alice L. Walton School of Medicine. In her new role, she will work with health systems and institutional partners to enhance medical education and prepare students for their future healthcare roles in the community and country. She is an international expert on gynecological malignancies. Most recently, she served as the Department Chair of Obstetrics and Gynecology and Women's Health, Professor of Gynecologic Oncology, and the Shella and Moise Safra Endowed Chair at Albert Einstein College of Medicine and Montefiore Health System in New York. She has held faculty positions at the University of Pittsburgh, University of Alabama at Birmingham, Emory University, and the University of Louisville. At the University of Pittsburgh, she was named a Women's Reproductive Health Research Scholar. At Emory University, she was the Division Chief of Gynecologic Oncology and the Leach Endowed Chair in Obstetrics and Gynecology. She was also named a Georgia Cancer Coalition Distinguished Cancer Scholar. At the University of Louisville, she served as Department Chair of Obstetrics, Gynecology, and Women's Health. She's a tenured Professor of Gynecologic Oncology, Donald D. Baxter Endowed Chair in Obstetrics and Gynecology, and Chief Medical and Operations Officer for the Center for Women and Infants. She is presently a board member of Every Mother Counts, EMC, a non-profit founded by Christy Turlington Burns, focused on improving maternal health care worldwide. She is the Associate Editor-in-Chief of Journal of the American Association of Physicians of Indian Origin. Dr. Makhija has received numerous awards for her dedication to women's health, including the Albert Einstein College of Medicine Spirit of Achievement. She is also been named a Good Housekeeping Humanitarian Hero, A. Crane's New York Business Notable Healthcare Leader, and the American Association of Physicians of Indian Origin Healthcare Hero Honoree. This is indeed a proud moment to have you amidst us, dear Makhija ma'am. A hearty welcome to you, ma'am.
Slides, so I don't know if you're able. Are the slides being shown?
Ma'am, it's a technical glitch. I think they are sorting it out.
Okay. Is it easy for me to share?
Ma'am, I think you can share the slide.
You don't have them? Because I think yes.
We have a slide that is visible right now. Ma'am, did you share the slide?
Well, I gave the slides ahead of time. I'm not, and I thought they had those ready. Are those not ready? I can try to share slides.
Ma'am, they're working on it. Sorry for the delay, ma'am.
Oh, that's okay, no problem.
Yes, ma'am, the slide is visible. Ma'am, you may please start, ma'am.
Okay. Can it be changed to the slideshow? Can it be shown as a slideshow? Could you change that to a slideshow? On the bottom.
Ma'am, this is in the slideshow mode.
Okay. Okay. If you could go to the next slide, please. So where we are, so Alice Walton is part of the Walton family, and her father is who actually started Walmart many years ago, and she is the only daughter of Mr. Walton. And she has always worked in the world of the museums and finance, and because of her own health issues that she shares, very broadly with many people, of just going to the hospital and getting care, and that it was very disconnected. That was the reason why she felt compelled to start the medical school. And really that's been her vision and passion, is to focus on building a pipeline of physicians for the future that look not only at taking care of sick patients, but really trying to prevent sickness to begin with. So she's approached it in many different ways, and not just by looking at the medical school. She's, that's one part of what we call the triad. So for the medical school, we will be getting an MD granting program. We're very unusual because we do not have a university that we're attached to, and we don't have a medical system. However, we have applied for the Higher Learning Commission, as well as locally, and with the medical school accreditation body, which is called the LCME, for the degree granting capability. And we have passed all of them. Right now, for the LCME, we have received just this week, that's the reason why I had to stay behind, we were granted what we call the candidate status. So they will be coming to visit us in about 6 months to meet with everyone, review the program, so that we can start interviewing students next year to start in 2025. The building is actually being built as we speak and will be ready by that time. The other piece of this is that she wanted to create a new academic medical system partnership. And so we will be announcing in a few months our partnership with a major medical system in the country, as well as a local system, where we will create a partnership and apply what we call whole health principles to this new curriculum, as well as how we take care of patients. And then the third prong is we are calling the Heartland Whole Health Institute. And that is where it is a sister institution to the medical school, where we are partnering with the healthcare system. We are working very closely with policymakers to create better payment systems, as well as creating community partnerships locally. And this map shows you approximately where Arkansas is, and that's why it's called the Heartland, because it is really considered middle America. And we feel that many times the East or the West Coast really gets more of the influx of doctors and growth, but we are building a new section here in Middle America. If we can go to the next slide, please. No, the previous slide, please. It's not showing. Okay. Yeah, it's unfortunate because I had sent these pictures that show the campus of the Arts and Wellness campus that has her museum. She has a world-class museum that she built 10 years ago, as well as where the medical school will be. I'm going to see if I can try to share my own slides, because I'm afraid that none of the other pictures are going to show up. But on the campus, we will have the Whole Health Institute as well as the medical school. And with this medical school, we are looking at whole health principles, which aligns with, if we look at a lot of the work that's being done with what's called value-based care, that aligns very closely with looking at self-care, looking at how we address a patient's social and emotional well-being as a way to help them with their health. And so with the self-care piece, we are going to be offering one-on-one healthcare coaching for students as well as faculty. If we can see the next slide, and if the pictures, okay, that's great. So this is actually a rendering, which is the same as in my background. This is a rendering of the medical school. It is 4 stories high. This, as you can see on the very top, is a garden actually on the roof. And you can walk from the very base all the way to the top, where we will have amphitheaters as well as teaching centers outside. And it was very important that we be a part of nature, be a part of the community. This will be open to the community. There will be world-class art as well in the medical school. And part of the curriculum will be integrating the arts into the curriculum, which is, many medical schools may have 1 or 2 hours or courses that are very brief with looking at art. But we will be incorporating it fully intentionally to be able to help a physician learn how to improve their communication skills, their diagnostic skills, their ability to observe what is happening. And as you can see, we're very immersed into the nature piece. And there's been a lot of studies that have shown that being a part of the outside and nature contributes to better learning. So that's really where we are embracing that from all aspects. This will be 154,000 square feet, and it will be on 14 acres. The entire campus on the previous slide would have shown it's on 200 acres total of land, but this in particular will be 14 acres. Next slide, please. And this is a community pond that, again, will be open to the public, that will be accessible for the students to be able to relax. We will still be requiring them to be studying very hard. The core curriculum will still contain the foundational sciences and clinical skills in a state-of-the-art simulation center with all of the latest technologies with AI. But we feel still it's important to be able to go out in nature to help alleviate the stress and burnout that we see physicians are enduring in the U.S. Next slide, please. This is a slide of the interior. This will be the lobby. And again, a lot of the wood and the granite is used from the state of Arkansas to just be a part of the community. Next slide. And this is just a rendering of the student lounge to give you an idea of what that looks like. And next slide. So Alice often says this, that in the next decade, she wants to see improved health outcomes, lower cost, reduced provider burden, and patients activated as stewards of their own health. So that is really her vision that we are fulfilling at the medical school. We are in the middle of recruitment of faculty, and we have 35 faculty so far. We plan to have about 100 faculty, and we will likely recruit 48 students as the first class. And once we are fully accredited, we will likely double that number. So I just wanted to give you that brief overview of the medical school. If we can go to the next slide. So what I wanted to talk about today, and the reason I picked Florida, is this is really reflective of what is happening across the United States. We actually recently just did a film in Arkansas, but because that one is so new, I won't be able to show you the impact of just bringing this information to light and the impact that it's had in Florida. Next slide, please. So again, I'm a board member of Every Mother Counts. I actually chair the Impact Committee, which is the policy, advocacy, and grant-making committee. We help on a national level write the policies, work with policymakers and politicians to, what we learn from community work with many of our community health workers. We then take to policymakers to try to implement policy changes across the country. We also are very closely working with advocacy groups, and we do give grants to local community workers to help enhance the work they may need to do to the next level. Next slide. So really the objectives today are to show you the maternal mortality rate and the leading causes of death in Florida. What you may see in India, which we used to see, is the biggest cause was hemorrhage. What we see in the U.S. is actually shifting, and Florida is reflective of that shift, where we're seeing racial and ethnic disparities having a really big impact on maternal outcomes. And so because of that, with our organization, we actually have incorporated birth equity education and have tested it out into a medical school curriculum at University of Miami. And so I wanted to share that as well with you. Next slide. So this should be a video, and this is about a 15-minute video to show you the work that we've done. Are you able to play that video?
So it is Friday, July 25th, and it's about 2:30 in the afternoon. So a week from right now, I should be holding my daughter in my arms.
When you were talking about the bedpan and the collecting your clots, So you're going to use that to kind of estimate the blood loss. If you're in the pool, are you having them squat over a bedpan or anything to collect, or are you having the blood and the clots going into the pool? So when you start feeling those again, I want you to press and see, is it tightening up all over? Because then it might be a contraction. Could this be the head? Yeah, okay. Put your finger there. You know, sometimes though, each baby you need more support because everything's soft and it just kind of flops down there. Consider it like a belly band or a belt, and you know what? I would say have a quick look around the thrift shops. Don't spend a fortune because you can pick them up for $1. You know, people wear them and just give them away. What's the next step? Women of low income and women living in certain zip codes have a very hard time accessing the high-risk OB clinic. Now we're at a situation where we're taking patients and saying we'll do your care for free while we figure it out because you're pregnant and because your baby will be born.
They told me that my Medicaid didn't kick in yet.
Do we have it as... We have it as approved.
Oh,
so what happened? Did they switch you from the to an HMO maybe?
I don't know. I'm not sure yet.
That's just a shame. That's a shame. All right, my love. Did they tell you how much it was going to cost?
Like $50, I believe.
Yeah, so it's pretty high.
Yeah.
All right, let's get it sorted out now. I'll have Katrina make a prescription for you. And we'll go from there. All right, my love. Okay, you're good. Bring that passport.
I will.
Bring it. Okay, darling. Come on. So ask her to get that number written down. I want her to write it down for you before you go. But she's checking out at the front today, okay? All right. Thank you, sweetie. One of the things that happened in Florida was that Florida Medicaid for pregnant women is essentially no more. The women apply for the Medicaid, but they're immediately placed on a what they call MCO, which is Managed Care Organization, or HMO, and they have to stay under that company. They can't be independently under Medicaid. So now we have women under independent companies that are running these programs. Various groups pay the Medicaid rate to the providers, but there are very few providers. It's all a bit of a mess.
This is the mattress. That works for me. That works for you? Okay. I lived in South Carolina when I found out I was pregnant. Trying to find the doctor that I wanted to go to here. After knowing what my experiences were there, I was sad to have to leave. I was 6 to 6.5 months along when I moved back to Florida. It's a little difficult in this stage of pregnancy to still be applying for jobs and looking for jobs. So I had to apply for not only the Medicaid, but food stamps and cash assistance as well, because I need some way to pay for diapers or other things for my child. In order to get approved for that, they make you go through the workforce program. Honestly, nobody's going to hire a woman who's about to give birth in 2 weeks. As far as the support system goes, it's mainly my sister. She's like my rock. If it wasn't for my sister right now, I don't know what I would do. She got us a house, she pays our bills, she's the one who has a car, but now she has to get fixed. And she's been taking care of us the past couple months, so I can't do much yet.
So Naomi was having a planned C-section. Even in the middle of that, the insurance issues came up and were part of that experience for her, which is really sad because, you know, it's such an awful time to be wrangling, if you will, around these kinds of things. She also had problems filling her prescriptions.
I ended up not having care for about a month after getting back to Florida because you have to cancel the Medicaid in the state of South Carolina in order to apply for the insurance in Florida. And so you get that lapse in between. You've stopped one, but you're waiting to be approved for the other.
There's a complete lack of communication between the insurance companies, the managed care organizations, and the physicians. I was actually, and still am, the only birth center on the west side of Orlando.
This is my first 1 week visit. I was just here last week. My I wasn't sure if I was going to make it, but we wanted to make sure I established some sort of pair with her to be able to deliver at Winnie Palmer instead of Osceola County. What is that? Oh my gosh. It's not easy for mommy anymore, but. Oh, I think you did. Hold this. Stand up so I can check you. No, did you just fart? Yes. I'm sorry, I forgot to bring it back up. I'm like, a scatterbrain.
I opened up a birth center in Winter Garden because I knew that I needed to have a space and a home to offer an alternative where women can have more choice, more agency in their birth experiences, have a family-centered experience.
Periota should be, Periota's right there. Aha. Okay. How are you? Sort of. How are you? Yeah.
No, you know these babies, they keep coming out.
Oh, no.
And they don't care.
They don't
They're good and ready.
They'll come when they're ready.
And then back to back as well. They gang up on us. So.
How many babies did you have last night?
Two.
Two?
Yeah.
Are they boys or girls?
One is, no, actually two girls.
Two girls? Everybody's having girls.
You have the girl too, Rachel?
Finally.
Okay. Good.
I want you to get pregnant. Now I only like my girlfriend and okay.
When I found out I was first pregnant with my oldest son, I was excited. I was nervous though. I was only 17, so I was really scared.
Want to get in?
My plan for giving birth is that I want to do it naturally. I don't want to have a C-section. I just want to be able to know what it feels like to push out a baby. Because I feel like I got so close with my oldest baby that every woman should get to know what it feels like.
Well, I don't know why people won't hold your hair.
You want to check if it's done now? Yeah, that's hot. You want some pancakes? Yeah, I know. My dad currently has been in prison for both my other babies, but he'll come home in September. So he's really looking forward to being home for this one. My grandpa, of course, he's really supportive. If I need anything, all I have to do is call him.
I know they're not looking forward.
I wanted to do it here, but I can't.
You can't. That won't be right.
No, because I had 2 C-sections with the boys, and if something was to go wrong.
Yeah. It's probably better to be at the hospital.
Unfortunately.
Well, you know, I hope it works out. And everything's okay.
So this time I think we're going to be able to try to do it naturally.
You stop it.
No.
Good job. All right.
I had it in my head that once you have a C-section, you always have to have a C-section. But now that's not the case, so. One thing I fear the most is that she's not going to come out naturally and then I'm going to have a C-section because I don't want to do that again.
The last couple of visits with Rachel, we realized that there was more to the story than the lab work was showing us. We referred her to the hospital for review and for evaluation with the concerns that we had and with her log in hand.
Were you able to hear the video? Because I can't hear it too well. So if you're not able to hear, we can just pause it and I can continue.
Diabetic babies can actually be at risk for stillbirth. High blood sugar in a mother makes for a larger baby, makes for complications for the baby, and also complications for the mother. So it's very, very high risk. The medical approach to doing the test is start with a fasting sugar, drink 100 grams of glucose, and then test 1 hour after that drink, 2 hours after that drink, and 3 hours after that drink. What was frustrating for us was that the lab work reflected she actually passed, which just goes to show you how difficult it is really to assess a diabetic status in pregnancy. We knew there was a problem, but again, she had passed that 3-hour test. My dilemma is, as a midwife, that I don't like to work outside my scope, but I wanted to support Rachel. One of the things that I so admired about her was that she wanted to see and she wanted to understand what to do about it. Once we started talking about her capturing her blood sugars herself, taking her, the machine and doing the finger sticks, she was so willing.
I had to prick myself after I ate, every 30 minutes after I ate, or an hour after I ate something.
What we noticed as soon as she started doing the blood sugars and reporting them to us, that they had risen up quite high, especially after food. And that was the flashpoint. I got the phone call early one morning and she thought she was leaking her water, and because of the premature state that she was at 35 weeks, I was very concerned. I said, go on in to the hospital and let's make sure.
Could you kindly pause the video?
Given the circumstance.
Yes, thank you, because I couldn't hear the video too well and I wasn't sure if you're able to hear it, but this really was just to show you the type of patients that we take care of there, have a lot of other issues such as obesity and diabetes. And the main thing is that their access to insurance is such a problem that they don't go for prenatal care. So that is why when you look at the maternal mortality rate, there are a lot of different causes. So when we filmed this in 2015, the rate of maternal mortality was 21 out of every 100,000 live births. And then in 2020, which is the most recent data, because of the pandemic, they have not updated all of the data. It did actually drop down to 13 for the whole state of Florida. But in particular in Miami, which is in the southernmost part of the state, and you can go to the next slide. The highest rates are at the very bottom right. You can see in purple. The darker colors reflect the higher rates of maternal mortality, and that is where you will find more immigrant populations and more African Americans. So as we started to drill down and look at what are the causes, and you can go to the next slide, please. The leading causes of maternal deaths in Florida, it's not hemorrhage, it's not the ones that you think about. It's actually opioid use and substance use disorder. And so it was very important for us to know what the leading causes were in order to try to create better interventions. So and I bring that up because typically we all jump to the conclusion, and I was trained also as the number one cause was either hemorrhage or pregnancy-induced hypertension or preeclampsia. But if you really look at most of the states in the U.S., substance use disorder has become the top issue. If we can go to the next slide. And if we look at the timing of when these maternal deaths are, again, when we are trained to anticipate hemorrhage or issues during pregnancy or during the day of delivery. What we forget is that if you really look at the rate of deaths, at least in the U.S., the majority occur well after the woman has gone home after giving birth up to a year later. And because they lose insurance at 6 weeks after delivering, this is part of the problem, is they don't have insurance, so they're not going to go to the doctor if they're not feeling well. And so this became a big focus of how we address the interventions. If we can go to the next slide, please. So looking at the disparities, Black women in Florida are 2 times likely to die from a complication compared to a woman who is white. So they have their rate of death is twice as high. We also looked look closely at the other racial and ethnic disparities. The substance use disorder really affected the Hispanic, non-Hispanic whites, the American Indian, and Alaskan Natives. So again, looking at the population and the races that had these disorders or the outcomes that we were trying to intervene for, they were not the white women that were having this issue. And again, I list all of these down here with hemorrhage. It was really the non-Hispanics and the American Indian and Alaska Natives that were affected by hemorrhage. And as you can see, it goes down the list. And each state, it is not mandatory on a federal level, but each state actually has their own version of a maternal mortality review committee. And I noticed in Kerala, there's been a big push for the quality review. So it's very similar to that. And I think that's why you've had such success on addressing the maternal mortality rates. But in Florida, they felt that as many as 68% of all pregnancy-related deaths were potentially preventable. If we can go to the next slide. And this is actually just a graph reflecting all of this. So if you go to the very bottom, you can see in the lighter pink, that's for white women and their death rates, you know, almost pretty stable. And then the next level of shade is specifically in Miami of just the white women. And then as you go to the pink, more pink area, you see the all of Florida for the black women, and the highest rates in orange are for Miami black women. So you can see that that has really become a big focus of interventions to really counsel African American or black women on preventative care. Next slide, please. So as I mentioned before, insurance has become a big issue, and what, you know, the politics are always, you know, a reflection of the state. So in those states that tend to be a little bit more conservative, they are less likely to have Medicaid expansion for postpartum or for the poor. And Florida is one of the states that did have an extension of postpartum for 1 year after birth, but they did not expand it under the Affordable Care Act. So almost 400,000 people were not insured, and about a quarter of those women are those that are pregnant and to have delivery. So if they don't have any type of insurance or Medicaid, federal insurance, they are not going for prenatal care. And so that has become actually one of the biggest problems. Next slide, please. So we sought out, and I know we're probably running a little bit behind. So, and these are all the slides that you can have to see that the curriculum that we have incorporated with the University of Miami was a 4-part curriculum. This one looked at birth equity education, and it really just looked at using these outcomes, identifying racial disparities, just really acknowledging that there was a difference in the data that I just showed you. Many hospitals and many providers don't even know there's a difference in outcome, and they're treating each racial background and ethnicity the same, and it really needs to be focused in their particular race. Next slide, please. So again, the session 1 looked at disparities and maternal health outcomes, and because we've done such a different series for different states in the U.S., we focused on one of our earlier films in New Mexico that really does look at the role of midwives. In the U.S., there is a little pushback from many physicians to include midwives or doula care in the care of a patient. But this really highlighted that because there's such a lack of access especially in the rural areas of America, that the role of midwives is very important to have. Next slide, please. Session 2 looked at the drivers of health disparities, and so our film with Giving Birth in America in New York looked at the doula support. And so doulas, I've actually had to learn this because I'm an oncologist, but I had a department that we took care of very high-risk OB patients. I was not familiar, frankly, with doulas. And doulas are really non-medical, but they are the support team for the patient in order to be able to help them through the process. And we show that there was actually benefit with the use of doulas because, at least in the U.S., there is what we call structural racism, where, again, it's not intentional, but a lot of the interventions are really based off of studies done on white women and not necessarily looking at the different ethnicities. Next slide, please.
Ma'am, sorry for the interruption. We have exceeded the time limit by 10 minutes, and if we could wind up in another 2 to 3 minutes, it would be great.
Yes, I'm almost done. So the session 3 is looking at the strategies to address the disparities. And again, the Giving Birth in America in California highlighted the importance of using a diverse workforce. The next slide. And then looking in Louisiana and the interprofessional discussions, because even if we did have midwives and physicians working in certain areas, they weren't necessarily communicating well with each other. So this set up the communication plans for how to go forward. Next slide. So the feedback from this, and this is actually about to be published, looked at the fact that this was very beneficial in the curriculum, and that the students actually wanted to be more of the facilitators. Next slide. So we have now expanded this curriculum as being mandatory at University of Miami, and other medical schools in Florida have actually pursued this curriculum. I presented this information to Florida International University, and they are going to be incorporating this as well as into their curriculum. So, next slide. So even though the overall maternity rates have declined in Florida, they still have some counties that are increasing. And so there is policy work being done in Florida, as well as piloting this curriculum elsewhere. I wanted to bring up, before I end, that during the discussion yesterday, there was some talk about, are there some protocols and platforms for understanding how to manage OB hemorrhage? When I looked at the data, it looks like in India, the rate of maternal mortality is about 103 per 100,000 live births, and most of those are due to hemorrhage. In Kerala, it's 30 out of 100,000 live births, which are also focused, the majority are hemorrhage. In the U.S., it's 33 out of 100,000 live births, and those are predominantly due to inequities and, like I mentioned, the substance use disorder. I will send you along a link because I do have slides, but I know we've run out of time, that have a toolkit that you can easily get onto, that have beautifully laid out hemorrhage protocols, very distinctly based on, are you ready? Do you have carts ready? How to recognize, how to respond, and how to, more importantly, report the data, which I see that in Kerala, you've really done far better than the rest of the country with starting to address how you report. So I will send that along for that website for you to be able to access. That's far more detailed than I could probably have shared in 20 minutes. And so I will send that along because I think that will be most helpful for, it helps all of us when we're addressing the hemorrhage protocols. So with that, next slide, just wanted to end and say thank you very much for this honor, and I'm sorry I went over the time. Thank you so much.
Let's give a round of applause to Dr. Makhija. Her talk offered fresh perspectives and valuable insights, all thanks to her expertise and engaging delivery. It was truly enlightening, ma'am. Thank you for your excellent contribution. Thank you for your valuable time and patience. Hoping that you would visit our hospital the next time you travel to India. Thank you, ma'am.
Yes, absolutely. Thank you.
For the next we have an oration on antenatal antibiotics, the good, the bad, and the ugly. For this, I call upon to chair the session Dr. Sajid Hashim, Head and Senior Consultant in Pediatrics and Neonatology, Dr. K.M. Cherian Institute of Medical Sciences, and Dr. Arun Thomas, Consultant Neonatologist, Dr. K.M. Cherian Institute of Medical Sciences. I also call upon Professor Dr. Ranjan Kumar Pejawar, Chief Neonatologist, People Tree at Meenakshi Hospitals, Bangalore, to deliver the oration. He is a former professor of neonatology in KIMS, Bangalore, and former chief of pediatrics at St. Philomena's Hospital, Bangalore. He is a widely traveled person, having worked in England, South Africa, Germany, and Middle East. He has more than 100 presentations to his credit, more than 100 scientific papers as well. He is the editor-in-chief of the indexed international journal Perinatology, and he has more than 38 years of teaching experience and has participated in more than 30 major research projects. I welcome you, sir.
Thank you. Good morning. I have great pleasure and I feel honored to be here at the perinatal update meeting at K.M. Cherian Institute of Medical Sciences. At the outset, I would like to thank Dr. Sajad, Dr. Arun, and the whole team for inviting me to deliver this oration. I feel very at home in Kerala because my hometown is Mangalapuram, Mangalore, and the geography and the practices and the people are almost the same. I feel here more at home than in Bangalore. I bring greetings from Bangalore, of course. It was a garden city. I don't know whether it still is. But we have an advantage there. If we are late for meetings or if we are late while going home, we just have to say traffic jam. And everybody will accept it. But however, one thing I can say is it is the Silicon Valley of India. If you throw a stone at random in Bangalore, there is 1 in 3 chance that it will fall on a software engineer. So that is what Bangalore is. So now coming to the topic, antenatal antibiotics, the good, the bad, and the ugly. Many of you who are, my generation or, the elders will remember this great movie called The Good, the Bad, and the Ugly. This is Clint Eastwood, the good. This is Leon Cliff, not so good, bad. And this is Eli Wallach, who is the ugly. This was a very, very famous, iconic movie during those days. And, we are all great fans of that. Why I gave the title is, the antenatal antibiotics is the same. It is good when used properly. It does a lot of good to the mother and the baby. It has got the bad aspects and it has got the very, very ugly aspects too. Antibiotics, as you know, is one of the most important medical innovations. It saves lives when used appropriately. But inappropriate use leads to potentially untreatable resistant infections and long-term health problems in the children even when they are going through adolescence and adulthood. A recent assessment predicted that if there is no restriction, global antibiotic use will increase threefold by 2030, which is very dangerous. Unless we all work together to reduce antibiotic overuse, we could be assigning our future generations to a world of antibiotic resistance and chronic ill health. Now coming to the pregnancy, it is estimated that more than 60% of the women are given some type of antibiotic during the antenatal period or intrapartum. It is, used too much and sometimes too early in pregnancy, or too early for the indication to be there for the use. We all have underappreciated long-term adverse effects of early antibiotic exposure. Now let's go to some of the aspects of this talk. Chorioamnionitis. Both clinical and subclinical chorioamnionitis, we know, are much more common in preterm than term deliveries. Chorioamnionitis may account for 50% of premature births before 30 weeks of gestation. Now this chorioamnionitis can be with ruptured membranes. The laboratory and clinical data have shown a link between the ruptured membranes, spontaneous preterm labor, and increase in infections leading to preterm delivery. So, in this case, it may be logical that antibiotics might have a positive role in the treatment of preterm labor. So this falls under the category of good. However, the same does not apply to preterm labor with intact membranes. Recent Cochrane review, including 14 studies looking at nearly 8,000 pregnancies with preterm labor and intact membranes, showed that there is no significant difference in perinatal or infant mortality, in preterm births, or any other clinically important short-term outcomes for the infant. So this was a randomized trial, so which clearly shows that in intact membranes, there is not a place for routine use of antibiotics. If you look at the number needed to treat to benefit, it is 34. But same antibiotics causing adverse drug reaction happens when the number is 17. So there is 2 times chance of drugs causing problems than drugs causing benefit to mothers if used when membranes are intact. The next issue is the cesarean section. As you all know, cesarean section, the rate is rising in most of the parts of our country and even internationally, and there are various reasons for it, valid or not so valid. Let's not go into that. But the routine administration of antibiotics during cesarean section should be questioned, as the risk for post-operative maternal infection varies widely, or to say is actually not high. Low-risk women, elective cesarean section with intact membranes, approximately 1,000 women should receive antibiotics in order to prevent 6 cases of endometritis and to prevent 4.4 cases of abdominal wound infections. This clearly shows, how much overuse of antibiotics will happen if we use it in inverted commas routinely. However, in women who have higher risk, emergency cesarean section, ruptured membranes, obesity, etc., the number needed much lower. It is 5.25 to avoid 5 to 25 to avoid 1 case of maternal postpartum morbidity. So here it may be indicated. The answer to this is research on long-term infant outcomes. The safe strategy, whether it is mainly if it is for the baby you are giving antibiotics, then or it is the intrapartum time you are giving antibiotics, just wait for a few minutes and you give the antibiotic prophylaxis after the cord is clamped. That will save a lot of ill effects on the baby, especially during intrapartum administration. The next one is group B streptococcus, still not very high in our country. Now, intrapartum PCR should be the gold standard when deciding systematically to screen the GBS pregnant women, intrapartum. It does not preclude all the GBS cases, but it will reduce the use of antibiotics drastically. And even in this case, you can give the antibiotics after the cord is clamped. If our main objective is to prevent GBS early neonatal sepsis as well as in utero antibiotic administration, then the solution should be to work very hard on having a vaccine, GBS preventive vaccine. I don't think it is available in India still, and even in many parts of the world it is under research umbrella that it is being used, GBS vaccine. I hope that it will come to market very soon. And there, coamoxiclav is the commonly used antibiotic for prevention of GBS. This rogue antibiotic is the reason for risk of NEC in preterm babies. This was one of the secondary outcomes of the Oracle trial. There is fourfold increase in proven suspected of NEC, that is necrotizing enterocolitis in the newborn, compared to placebo. And necrotizing enterocolitis is what you call as a nightmare of any neonatologist, especially in preterm babies. The experience remains in your mind for a long time. Whether the baby survives or doesn't survive, you will never forget necrotizing enterocolitis management, because it's a very horrible thing. Now, abnormal microbial colonization happens when you give antibiotics freely. So this is something which we will go into details. Perinatal antibiotic exposure affects the transmission between maternal and neonatal microbiota, and it is associated with early onset sepsis. But no excuse for overuse of antibiotics to treat respiratory and genital infection during pregnancy. Just because the mother sneezes or coughs twice, there's no point in giving antibiotics. We shouldn't be trigger happy while prescribing antibiotics to mothers, and we should be very aware that there should be some form of evidence for bacterial infection in the mother to give antibiotics. Now, long-term effects of antenatal antibiotics, many a times we don't think, because modern generation, we live in the present times. We are neither bothered about the old tradition, nor we are bothered about saving for tomorrow, live happily today. So that shouldn't be the theory while using antibiotics in the antenatal period. Bryant et al. Have very elegantly shown that vast numbers of bacteria in our gut, as well as viruses and occasionally fungi, all these microorganisms form what we call as the microbiome. Our microbiome is essential for normal health and development. We should not disturb that. And disturbance of that can cause ever-growing list of health outcomes, such as mental health, immunity, obesity, heart disease, and cancer. Please remember, these studies are not easy to perform, and you should have a very long period of vertical follow-up in order to assign the morbidity like these to the rampant use of antibiotics in the antenatal period. In India, though, it is very, very difficult, because they deliver in one place, go to their mother's house, then come back to another city, and then they relocate. Especially in the computer world now, a person changes the job very often than the olden days where a job was permanent for life. An infant's major contact with bacteria and other microbes occurs at birth. Babies born vaginally acquire their initial organisms microbiome from the birth canal and the gut of the mother. But if they are delivered by cesarean section, more likely to acquire bugs from their mother's skin and hospital, which are dangerous. There comes the MRSA and various other organisms from the labor unit. Perinatal antibiotic exposure may be associated with vaginal microbiota dysbiosis in the mother, and that is highlighted by substantial decrease in the lactobacillus species, and this will elevate the risk for vaginal GBS infection and preterm delivery. So the problem for mother and problem for baby both. Then there are studies which have shown that full-term gestational age and absence of perinatal antibiotic exposure seems to be the protective factor in the transmission of dysbiosis in resulting in early onset sepsis in the newborn. I don't know many of you know about this. This is becoming more and more educative, and prenatal exposure to antibiotics can suscept a baby to infant wheezing both during infancy and younger age. Especially in the first and third trimester of pregnancy, wheezing in children aged more than 18 months has been noticed. Agreed, there are a lot of confounding factors. It is still not that straightforward. Some studies say that it's not associated with first trimester exposure, and it's only present in the third trimester exposure of the mother to antibiotics. The risks of wheezing after genitourinary infections during pregnancy when they get antibiotics were independently of antibiotic treatment. This is one confounding factor. There are some studies that say the risks of wheezing in mothers who have had genitourinary infections, they will have infection even whether you give antibiotics or not. I mean, these studies always confuse you. The association between prenatal antibiotic exposure and infant wheezing could be largely explained by the confounding factors. So that is something which we should bear in mind. Now, the question of antibiotic resistance developed by the neonate. Ampicillin resistance was more common in neonates with intrapartum antibiotics. 50% versus 16%, significant, statistically significant. Resistance to at least one maternally administered antibiotic was more frequent with intrapartum exposure, 56% versus 0%, which is very, very significant. So if you give antibiotics due to in the interpartum period, lot of babies later on will develop resistance to that antibiotics, not just in the neonatal period. This is again, antepartum antibiotics affect enteral feeding in newborns. They affect their body growth curve and neonatal infection in preterm infants. The numbers of this study were not very large, but substantial. I think 224 cases were studied. So the effect on body growth vary by the exposure levels of antenatal antibiotics and the gestational age of infants, which means lower the gestational age and the amount of antibiotics received by the mother have a bearing. So these two are factors which you have to look at. We know that antibiotics kill off not only bacteria causing infection, but also bacteria of the microbiome, as I have earlier mentioned. So this imbalance is called dysbiosis, microbiome dysbiosis. Now, the early microbiome acquired from the mother, they actually educate the infant's immune system in the first few weeks and months of life. And so we have to be very, very careful by giving antibiotics unnecessarily to mothers. So end of the day, these may increase the risk of infection even in childhood, just not neonatal period. This is again very interesting. In a recent Danish study, mothers' exposure to antibiotics in pregnancy was associated with increased risk that her child would develop a severe infection requiring hospitalization in the first 6 years of life. Perhaps we are not tuned and we are not accustomed to think that far, but this study has shown that. The increase in risk was greatest among children whose mothers were prescribed more antibiotics and who received antibiotics closer to the delivery. So it's always there's a reason why, if possible, antibiotics should be given after the cord is clamped. This is again autoimmune diseases like Crohn's, celiac disease. These are all linked to the early childhood, and in early childhood they are all linked to antenatal exposure of antibiotics through the mother. The exact risk is difficult to quantify, but children receiving 7 courses of antibiotics were reported to be at 7-fold risk of Crohn's disease. I took the liberty of this. This is not in the mother, but this is in the early neonatal period and childhood. If you give 7 courses of antibiotics, within the first few years, the risk of developing Crohn's disease is very high. That also, this long-term effect also includes juvenile idiopathic arthritis in the children and adolescents. So, coming to the, if you summarize the whole talk, there are indications where antibiotics to the mother are useful, like in ruptured membranes with chorioamnionitis, or maybe severe respiratory infections where it has been proven that the mother has bacterial lower respiratory tract infections and things like that. Cesarean section where there are comorbidities, obesity and things like that, maybe prophylactic antibiotics may help. But you should remember, a lot of mothers will receive antibiotics who actually did not need antibiotics. So again, the good and the bad and the ugly comes to the picture. So some are good, some are not so good, some are definitely ugly. The good, as I said, genuine indications. Mother's health is protected and the newborn health is protected in a way that it may prophylactically act. Bad is the rampant use of antibiotics, especially for cesarean sections, and scant consideration of maternal-fetal and neonatal microbiota dysbiosis. Antibiotic stewardship should be practiced. Antibiotic stewardship means use of narrow-spectrum antibiotic in proper doses, proper duration, and to monitor for any side effects. And when the culture results come negative, to stop the antibiotics and not to continue. Ugly, of course, necrotizing enterocolitis, long-term problems of wheezing, autoimmune diseases. These are all the ugly stories of antenatal antibiotics. Now, the small second part of my talk will be on perinatal approach. I am a great fan of perinatal approach to improve the mother and child outcome. When I returned from abroad, that's about 25 years ago, the dictum was, I am in charge till the cord is cut, you take over afterwards. That is, we now know that's not at all good. The liaison between the pediatricians and the obstetricians should start early in the antenatal period, and in some cases even before the pregnancy is established. In some cases of illness, they may have to liaise and talk to each other and then do whatever is necessary and then plan the pregnancy, then discuss when to deliver and where to deliver. So this is the ideal case. And I'm glad to say that in the last 25 years, I'm in the 41st year of neonatology. And it's 26 years since I came back from abroad to Bangalore. So I have seen that the scene has improved vastly. People are talking to each other and respecting each other, and the liaison has improved. The handover and takeover should be smooth and effective. Health education should be coordinated, because there are a lot of things which obstetricians put in a word during the antenatal period regarding uses of surfactant, regarding newborn screening. The parents will be receptive when the pediatrician mentioned that. We should have regular perinatal meetings to discuss the mortality, not just the mortality, even the morbidity, the impending cases which may deliver in the next month or so. They all should be discussed. Involve the nurses and other relevant specialties in whatever we do in our joint team. Train the PGs, fellows and nursing philosophy about that philosophy of joining hands together early in the pregnancy. It's not just you and me, even the professional bodies should cooperate. I can tell you even now, in a neonatal conference, there is no perinatal aspect, no obstetricians are attending it, and in the obstetric conference, there is not much neonatal medicine involved. Conferences are big. Pediatric conference, I call it as Kumbh Mela, and obstetric gynecology conference, I call it as Maha Kumbh Mela. But the joint cooperation and joint sessions are still to be improved. The other thing, we should now concentrate on perinatal centers where obstetric care, antenatal care and neonatal care are available under one roof. And to extend it, even the subspecialty consultants should come to that hospital and attend the cases or look after the cases, like a pediatric neonatal cardiologist should be attached. Neonatal metabolic person should be attached. So perinatal centers are important, and I can boldly tell that a state like Kerala, where the indices like neonatal mortality rate, infant mortality rate, under 5 mortality rate is equivalent to the Western standards, I think you should starting perinatal centers probably in each district. I don't know, it might be already there. I must commend the government. The minister will be here soon. The hospitals and all of you pediatricians and obstetricians who are responsible to have such a low mortality rates in all the 3 categories in Kerala. I hope this trend will continue, and it will reach a stage where they, once you reach 1, 2 and 3, I was talking to Samuel Rajadurai in Singapore, after you reach that 1, 2, 3 per 1,000 births, some of them are unavoidable. So I hope Kerala reaches that stage soon. We always say that, neonatal care is very, very expensive. Look at these cost-effective interventions. Antenatal steroid hardly costs few rupees. Antenatal magnesium sulfate in preterm babies for neuroprotection hardly cost few rupees. Delayed umbilical cord clamping, some use the word deferred, because delayed means you have purposely made late, though it is purposely late, deferred is better. No cost involved. Temperature control in delivery room, because hypothermia is a big morbidity and mortality cause independently and combined with other morbidities of the newborn. Regulated oxygen use. Naturally, when you don't use oxygen and regulated use of oxygen, you will be spending less. Kangaroo care is a fantastic intervention. Usage of non-invasive ventilations is very good. Our nectar of life, breast milk, human milk feeding will save a lot of money. Hand washing, only the soap has to be bought. Restricted use of antibiotics, what I said, antibiotic stewardship. Look at all these interventions. Are they expensive? No. But if you use these in babies, your outcome will be better and their hospital stay will be shorter. You may say, I do all these things. No, we don't do all these things in all the babies. We do, some units will have some people very interested in breastfeeding. They will do that, but the antibiotic usage will be neglected. So we have to look at all these interventions. Then only, then our outcome will be better and the cost effectiveness will be evident. I started, when I came back to India, a journal called Perinatology. This is an index journal now. Next year we'll be celebrating the Silver Jubilee of this journal. I felt that it was a signal. I told people that they should be joined. Now this journal is indexed in Accepta Medica, Scopus, Copernicus, and this year it will be indexed in PubMed. So there are articles from all specialties involved in perinatal medicine. May it be fetal medicine, ultrasonography, obstetrics, neonatology, and subspecialties like neonatal cardiology. Everything is involved and it is running well. My only problem is I can't find anybody to take it over from me. The youngsters are very busy. They will do their hospital work in the designated hours, disappear. They have Facebook, they have WhatsApp, they have 2 to 3 vacations per year, but no time for academic activities or time to give for the professional body to conduct CMEs like this and conduct conferences. But that trend has to change. The other thing I noticed when I returned was that the nurses were left far behind. So again, I started a journal called Nursing Digest, which is in its 12th year now, and it is doing well. Some of the publications which we brought out, clinical protocols in perinatology during my as president of National Neonatology Forum, very, very useful book. It is sold out currently. And I again say that perinatal approach is one of the best approaches which will improve the neonatal outcome, which will bring the obstetricians and pediatricians together. Many places OPDs are next to each other, but that doesn't they meet and talk. In the labor ward and cesarean section, it's all masked. And now you can't talk much because it's epidural anesthesia. Mother will be listening. So we have to have platforms, we have to have meetings, and where obstetricians and neonatologists or pediatricians join. I started a program called Sat Sat. Sat Sat means the obstetricians and pediatricians have joint meeting, one-day CME. In the morning, there is pediatrics for obstetricians and obstetricians for pediatrics in separate halls. For pediatrician, topics like recent developments in assisted reproduction, fetal monitoring, things like that are taught by the obstetricians. For the obstetricians, the pediatricians teach recent advances in neonatal resuscitation, newborn screening, and things like that. After lunch, they both join together and we have common topics like preventing sepsis, congenital anomalies, ethical dilemmas in periviable deliveries, things like that. And please, I am happy to say it was a hit and people wanted to come for those meetings and they really met each other, discussed, and the outcome was very good. So with these few words, I complete my oration and I hope you have absorbed a few things, especially about the perinatal approach and the antibiotics in the antenatal period. Once again, thanks to all of you for a patient hearing.
Thank you, sir. This truly deserves a standing ovation for this oration on antibiotics, the good, bad, and ugly. Not only did you navigate the topic with finesse, but you also sprinkled it with a lot of humor and entertainment. Thank you so much for gracing this occasion. I call upon Dr. Sridevi ma'am to give away the memento to Dr. Ranjan Kumar Pejawar. I also request Dr. Ranjan Kumar Pejawar to give away the mementos to our moderators, Dr. Sajid Hashim and Dr. Arun Thomas.
Next, we move on to the inaugural ceremony.
നമ്മുടെ ഇല്ല.
All delegates kindly be seated. We will begin our inaugural function in another 2 to 3 minutes. Now, let's move on to the much-awaited inaugural ceremony. To grace this auspicious event, we have with us the Honorable Minister for Health, Women and Child Development, Government of Kerala, Srimati Veena George, Dr. C.P. Vijayan, Pro Vice Chancellor, Kerala University of Health Sciences, Dr. Ranjan Kumar Pejawar, Chief Neonatologist, People Tree Hospitals, Bangalore, Professor Dr. Manoj V.C., Head, Department of Neonatology, Jubilee Mission Medical College and Research Institute, Thrissur. Vice Consul of the Consulate General of UAE in Kerala, His Excellency Mr. Mohammed Musabe Saleh Musabe Al-Shamsi, and our own patrons, our dearest Sri P.M. Sebastian Sir, Chairman, KMC Hospital, and Reverend Father Dr. Alexander Kudarathil, Managing Director, KMC Hospital. We, the team of KMC Hospital, wholeheartedly welcome you to this knowledge feast. Request all dignitaries to please be seated on the dais.
Once again, a warm welcome to all the dignitaries on the dais, the enthusiastic speakers, the excited delegates, and our colleagues gathered out here at Dr. K.M. Cherian Institute of Medical Science, Kallisheri, Chengannur, for the International CME on Perinatology and Infertility, UPCON 2023. Dr. K.M. Cherian Institute of Medical Science is a well-equipped super specialty hospital located at the heart of Chengannur in Alleppey district of Kerala, God's own country, initiated by a group of professionals and entrepreneurs under the chairmanship of international industrialist and healthcare management expert Sri P.M. Sebastian, and clinical leadership of world-renowned cardiac surgeon Padma Shri Dr. K.M. Cherian, and directorship of Reverend Father Dr. Alexander Kudarathil. This institute is fanned out over an area of 3.5 lakh square feet with 300 plus beds, 100 plus ICU beds, and a multifunctional cath lab, and a fully fledged emergency department with level 1 trauma care. We have more than 32 departments, including specialties and super specialties, with the state-of-the-art care. Hoping this CME would be a formidable platform to share ideas and forge collaboration. Welcome to one and all.
Now, let's seek God's blessings before we move on. I request everyone to rise for the prayer. I call upon Dr. Pooja for the prayer.
ദൈവമേ നിന്റെ സ്നേഹസാഗരം എന്നിലേക്കൊഴുകേണമേ, ഹൃത്തിലെ തിന്മയൊക്കെയും മാറ്റി ശുദ്ധമാക്കി തരേണമേ. ദുഃഖമിൻ ചിത്ത ഭൂമിയിൽ വർഷ മേഘമായി പെയ്തിറങ്ങുമ്പോൾ സാന്ത്വനത്തിൻ്റെ കുഞ്ഞു തെന്നലായി എന്നെ വന്നു തലോടണേ. നിത്യവും എൻ്റെ ചിത്തവീണയിൽ മുഗ്ധരാഗമായെത്തണേ. സത്യരാഗത്തിൽ ധർമ്മഗാനങ്ങൾ പാടുവാൻ കഴിവേകണേ. ഹിന്ദു ക്രിസ്തു നബികളൊക്കെയും ഏകമാണെന്ന സത്യത്തെ അന്ധലോകത്തെ ബോധ്യമാക്കുവാൻ ധ്യാനമേകു സർവേശ്വരാ.
Thank you, Dr. Pooja. Please be seated. Next, I request Reverend Father Dr. Alexander Kudarathil, Managing Director, Dr. K.M. Cherian Institute of Medical Sciences, for the welcome address. Reverend Father Dr. Alexander Kudarathil started his career as the Secretary to His Holiness Morin Mar Basilios Marthoma Matthews II, Supreme Head of Indian Orthodox Church in 1992. From 1999 to 2011, his tenure as the CEO at St. Gregorius Medical Mission Hospital, International Cancer Care Center, College of Nursing, School of Nursing, College of Social Science, College of Medical Lab Technology, Director of St. Gregorius de-addiction center made him one of the most respected administrator in the Kerala healthcare sector. Since 2015, he is the managing director of Dr. K.M. Cherian Institute of Medical Sciences, Chengannur, and the chief counselor and therapy of the de-addiction center. Currently, he is the joint director of TRADA, that is, Total Response to Alcohol and Drug Abuse, a center for alcoholic and drug addiction treatment by the ecumenical churches. Also, he is a member of Pradhana Mantri Jan Vikas Karyakram, Pathanamthitta District Committee. He is also the winner of the prestigious award by the World Malayali Council. He is the author of Lahari Ini Agale, a book on de-addiction and substance abuse, which was well received by the Malayali community across the globe. There are many more to his credit. Over to you, Father.
UPCON 2023 ഈ ഉദ്ഘാടന വേദിയിൽ അധ്യക്ഷം വഹിക്കുന്ന ഡോക്ടർ കെ എം ചെറിയാൻ ഇൻസ്റ്റിറ്റ്യൂട്ട് ഓഫ് മെഡിക്കൽ സയൻസിൻ്റെ ചെയർമാൻ ശ്രീ PM സെബാസ്റ്റ്യൻ അവറുകൾ, മഹത്തായ UPCON 2023 ഉദ്ഘാടനം ചെയ്യുന്ന കേരളത്തിൻ്റെ ആദരണീയായ ആരോഗ്യവകുപ്പ് മന്ത്രി ശ്രീമതി വീണ ജോർജ് അവറുകൾ, ഇതിലെ മുഖ്യ പ്രഭാഷണം നടത്തുന്ന കേരള ആരോഗ്യ സർവകലാശാല പ്രോ വൈസ് ചാൻസലർ പ്രൊഫസർ ഡോക്ടർ CP വിജയൻ സർ അവർ, ആശംസകൾ അർപ്പിക്കുന്ന ഡോക്ടർ ചഞ്ചൻകുമാർ, ഡോക്ടർ മനോജ് CB, എൻ്റെ ഏറ്റവും പ്രിയപ്പെട്ട ഡോക്ടർ സജി ഹവൻ, വൈസ് കോൺസുൽ ജനറൽ ഓഫ് UAE ഇൻ കേരള മിസ്റ്റർ മുഹമ്മദ് സലോം, പ്രിയപ്പെട്ട ഡോക്ടേഴ്സ്, സ്റ്റാഫ് അംഗങ്ങളെ, ഡെലിഗേറ്റ്സ്. കലിശ്ശേരി, a small village, established its identity in the medical science of Kerala for the last 2.5 years. History began and records engraved with the joint service of the management, the staff, the doctors altogether. കല്ലിശ്ശേരി എന്ന ചെറുഗ്രാമം മെഡിക്കൽ സയൻസിൽ അതിൻ്റേതായ വ്യക്തിത്വം സ്ഥാപിച്ചു കഴിഞ്ഞു ഈ കഴിഞ്ഞ 2.5 വർഷമായിട്ട്. മാനേജ്മെൻറ്റും ഡോക്ടേഴ്സും സ്റ്റാഫുകളും ഒത്തുചേർന്നപ്പോൾ ഇവിടെ ചരിത്രം കുറിക്കപ്പെട്ടു, റെക്കോർഡുകൾ എഴുതപ്പെട്ടു. We have started a department called ARA, Analysis, Research and Academic. Last year, we have conducted an international cardiology conference which was inaugurated by the Kerala Governor, His Excellency Sri Arif Mohammed Khan. More than 300 interventional cardiologists and cardiovascular surgeons participated in that conference. In this year, we are conducting this UPCON 2023. We are opening the door for the upcoming treatment methodology, studies and research in the field of obstetrics and gynecology and obstetrics, infertility, neonatology, etc. ഞാൻ എൻ്റെ കർത്തവ്യത്തിലേക്ക് കടക്കട്ടെ. മഹത്തായ ഈ UPCON 2023 ഉദ്ഘാടന ചടങ്ങിൻ്റെ അധ്യക്ഷ പദം അലങ്കരിക്കുന്നത് ഈ ഹോസ്പിറ്റൽ ഡോക്ടർ KM ചെറിയാൻ ഇൻസ്റ്റിറ്റ്യൂട്ട് ഓഫ് മെഡിക്കൽ സയൻസിൻ്റെ ചെയർമാനായിരിക്കുന്ന ശ്രീ PM സെബാസ്റ്റ്യൻ അവറുകളാണ്. കേരളത്തിൻ്റെ മെഡിക്കൽ ട്രീറ്റ്മെൻറ്റ് രംഗത്ത് ഒരു വലിയ നാഴികക്കല്ലായി തുടങ്ങിയ, അല്ലെ പ്രൈവറ്റ് സെക്ടറിൽ ഏറ്റവും വലിയ ഒരു സംരംഭമായി തുടങ്ങിയ ലേക്ക് ഷോർ ഹോസ്പിറ്റലിൻ്റെ ഫൗണ്ടറും 20 വർഷത്തിനപ്പുറമായിട്ട് അതിൻ്റെ വൈസ് ചെയർമാനുമായിരിക്കുന്ന ശ്രീ PM സെബാസ്റ്റ്യൻ സാർ അവറുകൾ, കൊച്ചിയിലെ വൈറ്റിലിൽ തുടങ്ങിയിരിക്കുന്ന വെൽകെയർ ഹോസ്പിറ്റലിൻ്റെ അധിപൻ, ഈ തെക്കൻ തിരുവിതാംകൂർ ഞങ്ങൾ ഇങ്ങനെ ഒരു സംരംഭം തുടങ്ങണമെന്ന് അദ്ദേഹത്തോട് അപേക്ഷിച്ചപ്പോൾ യാതൊരു മടിയും കൂടാതെ എന്നാൽ വെല്ലുവിളികൾ ഏറ്റെടുത്തുകൊണ്ട് ഈ പ്രസ്ഥാനത്തിൻ്റെ ചെയർമാനായി നേതൃത്വം കൊടുക്കുവാൻ അദ്ദേഹത്തിന് സന്മനസ്സായി. യു എയിലെ ബോസ്കോ ഗ്രൂപ്പ് എന്ന് പറയുന്ന വ്യവസായ ശൃംഖലയുടെ അധിപൻ, വ്യവസായ രംഗത്തും മെഡിക്കൽ രംഗത്തും തൻ്റേതായ വ്യക്തിമുദ്ര പതിപ്പിച്ച മാന്യ വ്യക്തി. ലാസ്റ്റ് ഇയർ the UAE government honored him to give presenting the golden visa also. ഞങ്ങൾക്ക് സന്തോഷമാണ്, നമുക്ക് അഭിമാനമാണ്, കേരളത്തിന് അഭിമാനമാണ്. നിങ്ങളെല്ലാവരുടെയും നാമത്തിൽ അദ്ദേഹത്തെ ഈ യോഗത്തിലേക്ക് സ്വാഗതം ചെയ്തുകൊള്ളുന്നു. കേരളത്തിൻ്റെ ആദരണീയ ആരോഗ്യവകുപ്പ് മന്ത്രി ശ്രീമതി വീണ അവർ ഇങ്ങനെ അപ്കോൺ 2023 തുടങ്ങുന്നു എന്ന് പറഞ്ഞപ്പോൾ ചെയർമാൻ്റെ പ്രത്യേക താല്പര്യമായിരുന്നു ഈ CME പ്രോഗ്രാം, ഈ കോൺഫറൻസ് ഉദ്ഘാടനം ചെയ്യുന്നത് ശ്രീമതി വീണ ജോർജ് അവറുകളായിരിക്കണമെന്ന്, കേരളത്തിൻ്റെ ആരോഗ്യമന്ത്രി ആയിരിക്കണമെന്ന്. ഈ വിവരം ഞങ്ങളുടെ പ്രിയപ്പെട്ട ഡോക്ടർ സുരേഷ് വഴി അറിയിപ്പിച്ചപ്പോൾ മാഡം വളരെയധികം സന്തോഷത്തോടുകൂടി അത് സ്വീകരിക്കുകയാണ് ചെയ്തത്. കൃത്യസമയത്ത് ഇവിടെ എത്തിച്ചേരുകയും ചെയ്തു. നമുക്കറിയാം, വിഷ്വൽ മീഡിയ രംഗത്ത് ഒരു വനിതയ്ക്ക് കേരളത്തിൽ ഏറ്റവും ഉയർന്ന പദവിയിലെത്താവുന്ന അതേ പദവിയിലെത്തിയപ്പോൾ കഴിഞ്ഞ 2 ടേമിലായിട്ട് നമ്മുടെ ഏറ്റവും അടുത്തുള്ള ആറന്മുള നിയോജക മണ്ഡലത്തെ പ്രതിനിധാനം ചെയ്യുന്ന മാഡം, നമുക്കറിയാം ഈ കഴിഞ്ഞ ഒരു മാസമായിട്ട് കേരളം മുഴുവന് ഒരു ഭയത്തിൻ്റെ നിഴലിലായിരുന്നു. നിപ്പോ എന്ന് പറയുന്ന രോഗം വീണ്ടും നമ്മളെ പിടിക്കപ്പെട്ടപ്പോൾ നമ്മുടെ ആരോഗ്യവകുപ്പ് മന്ത്രിയുടെ നേതൃത്വത്തിലുള്ള ടീം, ആരോഗ്യവകുപ്പ് ശക്തമായ ഇടപെടലിലൂടെ അതിനെ കൺട്രോൾ ചെയ്തു, ഇല്ലായ്മ ചെയ്തു. അത് നമുക്ക് അഭിമാനമാണ്, ഞങ്ങൾക്ക് സന്തോഷമാണ് മാഡം. നമ്മുടെ എല്ലാവരുടെയും നാമത്തിൽ മാഡത്തെ ഈ അപ്കോൺ 2023 ഉദ്ഘാടനം ചെയ്യുന്നതിന് ഈ വേദിയിലേക്ക് സ്വാഗതം ചെയ്തുകൊള്ളുന്നു. കീനോട്ട് അഡ്രസ്സ് നൽകുന്നത് കേരള ആരോഗ്യവകുപ്പ് ആരോഗ്യ സർവകലാശാലയുടെ വൈസ് ചാൻസലർ ഡോക്ടർ CP വിജയൻ സാറാണ്. സാറ് കോട്ടയം മെഡിക്കൽ കോളേജിൻ്റെ ഒബ്സ്റ്ററ്റിക് ആൻഡ് ഗൈനക്കോളജിയുടെ HOD ആയിരുന്നു. ഇപ്പോൾ വൈസ് ചാൻസലറായിട്ട് സേവനമനുഷ്ഠിക്കുന്നു. ഞങ്ങളുടെ പ്രിയപ്പെട്ട ഡോക്ടർ സാറ ഈശോ വഴി ബന്ധപ്പെട്ടപ്പോൾ വളരെ സന്തോഷത്തോടുകൂടി അദ്ദേഹം അത് സ്വീകരിച്ചു. രാവിലെ തന്നെ ഇവിടെ എത്തിച്ചേർന്നു. പിന്നെ കീനോട്ട് അഡ്രസ് നൽകുന്ന അദ്ദേഹമാണ്. നിങ്ങളെല്ലാവരുടെയും നാമത്തിൽ അദ്ദേഹത്തെ ഈ അപ്കോൺ 2023 സ്വാഗതം ചെയ്തുകൊള്ളുന്നു. As per our request, Dr. Ranjan Kumar, he is the head of the department, Neonatology, People Tree Meenakshi Hospital, Bangalore, is here. On behalf of Upcon 23, sir, I welcome you. Thank you. രണ്ടാമത് ആശംസ അർപ്പിക്കുന്നത് ഡോക്ടർ പ്രൊഫസർ CP മനോജ് സാറാണ്. അദ്ദേഹം ജൂബിലി മിഷൻ ഹോസ്പിറ്റൽ ആൻഡ് റിസർച്ച് സെൻ്ററിൻ്റെ നിയോനറ്റോളജി വിഭാഗം HOD ആണ്. അദ്ദേഹത്തെയും നിങ്ങളെല്ലാവരുടെയും നാമത്തിൽ ഈ യോഗത്തിലേക്ക് സ്വാഗതം ചെയ്തുകൊള്ളുന്നു. We are very happy for the presence of the Vice Consul General of UAE in Kerala, Sri Muhammad Salam. Last year, you have received me and you have given me a warm welcome in your Trivandrum Consul General office. I am very much happy. We are very much happy. On behalf of Upcon 23, we welcome you, sir. ഞങ്ങളുടെ ബോർഡ് ഓഫ് ഡയറക്ടേഴ്സ് മെമ്പറായിരിക്കുന്ന അഡ്വക്കേറ്റ് NC ജോസഫ് സാറിൻ്റെ സാന്നിധ്യം ഞങ്ങൾക്ക് വളരെ സന്തോഷമാണ്. ഞങ്ങളെല്ലാവരുടെയും നാമത്തിൽ അദ്ദേഹത്തെ ഈ യോഗത്തിലേക്ക് സ്വാഗതം ചെയ്തുകൊള്ളുന്നു. ഞങ്ങളുടെ ശക്തി, നമ്മുടെ ശക്തി ഇവിടുത്തെ പാർട്ടിസിപ്പൻസാണ്. പ്രധാനപ്പെട്ട ഡോക്ടേഴ്സ്, അവരുടെ സ്പീക്കേഴ്സ് രാവിലെ 8:30 മണി മുതൽ ഭംഗിയായിട്ട് അത് നടന്നു പോകുന്നു. എല്ലാ പാർട്ടിസിപ്പൻസും വന്നിട്ടുണ്ട്. സ്പീക്കേഴ്സ്, എല്ലാ ഡോക്ടേഴ്സും അതിലെല്ലാവരോടും നിങ്ങൾ രാവിലെ തന്നെ ഇവിടെ എത്തിച്ചേർന്നു. കേരളത്തിൻ്റെ പല ഭാഗങ്ങളിൽ എത്തിച്ചേർന്നു. ഔട്ട് ഓഫ് കേരളയിൽ നിന്ന് വന്നിട്ടുണ്ട്. എല്ലാ പ്രിയപ്പെട്ട ഡോക്ടേഴ്സ്, ഡെലിഗേഷൻ എല്ലാവരെയും ഡോക്ടർ കെ എം ചെറിയാൻ ഇൻസ്റ്റിറ്റ്യൂട്ട് ഓഫ് മെഡിക്കൽ സയൻസിൻ്റെ പേരിൽ പ്രത്യേകിച്ച് ബഹുമാനപ്പെട്ട സിസ്റ്റേഴ്സ് വളരെ സന്തോഷമുണ്ട്. എല്ലാവരെയും ഈ ഡോക്ടർ കെ എം ചെറിയാൻ ഇൻസ്റ്റിറ്റ്യൂട്ട് ഓഫ് മെഡിക്കൽ സയൻസിൻ്റെ പേരിൽ പ്രത്യേകമായിട്ട് സ്വാഗതം ചെയ്തുകൊള്ളുന്നു. അതോടൊപ്പം തന്നെ ഞങ്ങളുടെ സംഘാടക സമിതി ചെയർമാൻ ഡോക്ടർ സജീദ് ഹഷിം, അദ്ദേഹത്തിൻ്റെ നേതൃത്വത്തിലുള്ള ലീഡേഴ്സ്, അതുപോലെ ഞങ്ങളുടെ റിസപ്ഷൻ കമ്മിറ്റിയുടെ ചെയർമാൻ ഡോക്ടർ കെ ജി സുരേഷ്, അങ്ങനെയുള്ള ഒരു നീണ്ട നിരയുള്ള ഡോക്ടേഴ്സ്, അവർ കഴിഞ്ഞ 3 മാസത്തെ പ്രയത്ന ഫലമാണ് ഇത്ര മഹത്തരമായ ഈ UPCON 2023 ഇവിടെ തുടങ്ങാൻ കഴിഞ്ഞത്. എല്ലാവരെയും, ഇതിൻ്റെ പ്രവർത്തകരെയും സ്റ്റാഫുകളെയും എല്ലാവരെയും ഈ യോഗത്തിലേക്ക് സ്വാഗതം ചെയ്യും. ഏറ്റവും പ്രിയപ്പെട്ട നമ്മുടെ ജോസഫ് സാറ്, അതുപോലെ തന്നെ നമ്മുടെ മലയാറ്റൂരിൽ നിന്ന് വന്നിരിക്കുന്ന ഏറ്റവും പ്രിയപ്പെട്ട സാറ്, ഇവരെല്ലാവരെയും സ്വാഗതം ചെയ്തുകൊണ്ട് ഞാൻ വാക്ക് ചുരുക്കുന്നു. നന്ദി, നമസ്കാരം. താങ്ക് യു.
Thank you, Father.
Next, we welcome our dearest Shri P.M. Sebastian Sir, Chairman of K.M. Cherian Institute of Medical Science Hospital, for the presidential address. Shri P.M. Sebastian is a self-made successful international industrialist and a healthcare management expert who started his own enterprise in the year 1987 by establishing Bosco Group in UAE. He is also involved in various ventures and heads quite a few organizations in India as well. He is a founder partner and vice chairman of Lakeshore Hospital, Cochin, Wellcare Hospital, Waitila, Cochin, and Wellcare College of Nursing, Puvakotu Developers Private Limited, Bosco Metals India Private Limited, and Galaxy Aluminium Industries Private Limited. Over to you, sir.
Thank you. ബഹുമാനപ്പെട്ട കേരള ആരോഗ്യമന്ത്രി ശ്രീമതി വീണ ജോർജ് അവരുടെ മുഖ്യപ്രഭാഷണം നടത്തുന്നതിനായി ഇവിടെ എത്തിയിട്ടുള്ള കേരള യൂണിവേഴ്സിറ്റി ഓഫ് ഹെൽത്ത് സയൻസ് പ്രോ വൈസ് ചാൻസലർ ഡോക്ടർ CP വിജയൻ അവരുടെ, ഹോസ്പിറ്റൽ മാനേജിംഗ് ഡയറക്ടർ റവറൻഡ് ഫാദർ ഡോക്ടർ അലക്സാണ്ടർ കൂടാരത്തിൽ, ബാംഗ്ലൂർ മീനാക്ഷി ഹോസ്പിറ്റൽസ് ചീഫ് നിയോനറ്റോളജിസ്റ്റ് and pediatrician Professor Dr. Ranjan Kumar Vejava, Trishur Jubilee Mission Medical College and Research Institute Department of Neonatology Head Professor Dr. Manoj VC, Hospital Consultant Neonatologist and Pediatrician Dr. Sajid Hashim, respected Vice Council of the Consulate General of UAE in Kerala, His Excellency Mr. Mohammad Musba Salam Musba Al-Ashmi, all the delegates who came from different parts of the country to participate in this UPCON 23. Dear KMC Board of Directors, members, doctors, staff, and friends. Dr. K.M. Cherian Institute of Medical Sciences established its involvement in the society to provide world-class treatment and state-of-the-art equipment for the last 2.5 years with the support of more than 100 doctors and 1,000 staff. Here we provide treatment at international quality level and introduce new technologies in the global health sector. Our clinical leadership is provided by the world-renowned cardiac surgeon, Padma Shri Dr. K.M. Cherian. He is the first surgeon to perform heart bypass, heart lung transplant, pediatric transplant, and TMR laser heart surgery in India. He is the first Indian to become the president of the World Congress of Thoracic Cardiac Surgeon. World-renowned oncologist Dr. M.V. Pillai is the chairman of Oncology Advisory Board of Dr. Cherian Institute of Medical Sciences. Also, the clinical professor of oncology at Thomas Jefferson University, Philadelphia, USA, president of International Network of Cancer Treatment and Research. KMC ഹോസ്പിറ്റൽ പുതിയ വളർച്ചയുടെ പാതകളിലേക്ക് നടന്ന് കയറുകയാണ്. ജനുവരിയിൽ ലോകപ്രശസ്ത ഓൺകോളജിസ്റ്റ് ഡോക്ടർ എം.വി. പിള്ളയോടൊപ്പം യു.എസിലെ ന്യൂജേഴ്സി ബർണബാസ് ഹെൽത്ത് മെഡിക്കൽ ഗ്രൂപ്പ് ഹീമറ്റോളജി ആൻഡ് ഓൺകോളജി സ്പെഷ്യലിസ്റ്റ് ഡോക്ടർ സാറ ഈശോയുടെ നേതൃത്വത്തിൽ ഇവിടെ ഓൺകോളജി സെൻറ്റർ 2.5 ലക്ഷം സ്ക്വയർ ഫീറ്റിൽ 309 കിടക്കകളുമായി ആരംഭിക്കുകയാണ്. റേഡിയേഷൻ ഓൺകോളജി, മെഡിക്കൽ ഓൺകോളജി, സർജിക്കൽ ഓൺകോളജി, ഹീമറ്റോ ഓൺകോളജി, പാലിയേറ്റീവ് ഓൺകോളജി, റീഹാബിലിറ്റേഷൻ ഓൺകോളജി, കമ്മ്യൂണിറ്റി ഓൺകോളജി തുടങ്ങിയ വിവിധ ഓൺകോളജി ഡിപ്പാർട്ട്മെൻറ്റുകൾ പ്രവർത്തിക്കുന്നതാണ്. ഇതോടൊപ്പം തന്നെ KMC ഹോസ്പിറ്റൽ ലോകപ്രശസ്ത ഡോക്ടേഴ്സിൻ്റെ നേതൃത്വത്തിൽ കിഡ്നി, ലിവർ, ഹാർട്ട് ട്രാൻസ്പ്ലാന്റ് യൂണിറ്റുകളും ആരംഭിക്കുന്നതാണ്. തികച്ചും അന്താരാഷ്ട്ര നിലവാരത്തിൽ പ്രവർത്തിക്കുന്ന ഗൈനക്കോളജി, നിയോനറ്റോളജി, വന്ധ്യതാ ചികിത്സാ വിഭാഗമായ ലല്ലബി ഫെർട്ടിലിറ്റി സെൻറ്റർ എന്നിവയുടെ നേതൃത്വത്തിൽ നടത്തപ്പെടുന്ന അന്താരാഷ്ട്ര കോൺഫറൻസ് UPCON 23 സയൻറ്റിഫിക് സെഷൻ ആരോഗ്യ മേഖലയിലെ നവീന ചികിത്സാ രീതികൾ പരിചയപ്പെടുത്തുന്നു. The famous Alice L. Walton School of Medicine, USA, founder, dean and CEO Dr. Sharmila Makilja is doing the lead presentation in this conference. Renowned national and international doctors from gynecology, neonatology and fertility treatment are participating in this conference. Around 300 eminent doctors and healthcare experts are present here to impart new ideas and technology in the respective departments. UPCON 23 aims to bring out an insight into recent treatment advances from the pre-conceptual stage to make our future generation healthy and stable growth of nation. This international conference has 13 scientific sections in IVF, OBG and neonatology by renowned doctors. UPCON 23 will make an impact on Kerala's healthcare sector by discussing the technical advancements, treatments in infertility. It will make a broader perception towards the optimization of IVF outcome. UPCON 23 will introduce the newer concepts in the perinatal interventions that improve outcomes preterm birth. I assure you that UPCON 23 will be a promising event to promote healthcare sector in Kerala. Let the new deliberations and ideas generate new solutions to address the issue of health concerns in our modern world. The doors of KMC Hospital will be open to such positive thoughts always. Thank you. Jai Hind.
Thank you, sir.
Ladies and gentlemen, it is indeed an honor to invite Srimati Veena George, the Honorable Minister for Health, Women and Child Development, Government of Kerala, who represents Aranmula constituency of Pathanamthitta district in the 15th Kerala Legislative Assembly. Her portfolios include health, family welfare, medical education, medical university, indigenous medicine, Ayush, drug control, women and child welfare. She contested in general elections for the first time in 2016 from Aranmula constituency and is the sitting MLA of Aranmula. Prior to joining politics, she has worked with major Malayalam news channels for over 16 years. She was also the first female executive editor among regional Malayalam news channels. She has already proved her mettle in serving humanity. Cordially invite you, ma'am, to light the lamp of knowledge and wisdom, followed by your inaugural address. Request the dignitaries to join.
എല്ലാവർക്കും നമസ്കാരം. യോഗത്തിന് ആധ്യക്ഷം വഹിക്കുന്ന KMC ഹോസ്പിറ്റലിൻ്റെ ബഹുമാന്യനായ ചെയർമാൻ ശ്രീ PM സെബാസ്റ്റ്യൻ, വന്ദനായ ഡോക്ടർ അലക്സാണ്ടർ കൂടാരത്തിൽ അച്ഛൻ, ഏറെ ബഹുമാന്യനായ പ്രോ വൈസ് ചാൻസലർ കേരള യൂണിവേഴ്സിറ്റി ഓഫ് ഹെൽത്ത് സയൻസസ് ഡോക്ടർ CP വിജയൻ, ഏറെ ബഹുമാന്യനായ പ്രൊഫസർ ഡോക്ടർ രഞ്ജൻ കുമാർ പെജവ, ബഹുമാന്യനായ പ്രൊഫസർ ഡോക്ടർ മനോജ് VC, ബഹുമാനപ്പെട്ട ഡോക്ടർ സജീദ് ഹഷീം, ഇവിടെ സന്നിഹിതരായിരിക്കുന്ന വിശിഷ്ട അതിഥികളെ, ഈ ഹോസ്പിറ്റലിൻ്റെ കുടുംബാംഗങ്ങളെ, പ്രിയപ്പെട്ട ആരോഗ്യ പ്രവർത്തകരെ, സഹോദരി സഹോദരന്മാരെ, സുഹൃത്തുക്കളെ. First of all, I would like to congratulate Dr. K.M. Cherian Institute of Medical Sciences for organizing this conference on perinatology and infertility. In a short span of time, this hospital has proved its dedication and commitment to the society and to the service of mankind. And the hospital has become an inevitable part of the health sector of Kerala. When we speak about health sector of Kerala, it includes both the private sector and the government sector. കേരളത്തിൻ്റെ ആരോഗ്യ മേഖലയെക്കുറിച്ച് പറയുമ്പോൾ അത് ഗവൺമെൻറ് മേഖലയും സ്വകാര്യ മേഖലയും ചേർന്നതാണ്. വളരെ ചുരുങ്ങിയ ഒരു കാലയളവിൽ KM Cherian ഇൻസ്റ്റിറ്റ്യൂട്ട് ഓഫ് മെഡിക്കൽ സയൻസസ് ഈ സമൂഹത്തോടും ഈ നാടിനോടും ജനങ്ങളോടുമുള്ള സമർപ്പണവും പ്രതിബദ്ധതയും പ്രൂവ് ചെയ്യുകയും അതോടൊപ്പം തന്നെ പ്രവർത്തനത്തിൻ്റെ മികവ് ഇതിനോടകം തന്നെ തെളിയിക്കുകയും ചെയ്തിട്ടുണ്ട്. കേരളത്തിൻ്റെ ആരോഗ്യ മേഖലയുടെ അഭിവാജ്യമായിട്ടുള്ള ഒരു ഘടകമായി കൂടി KM Cherian ഇൻസ്റ്റിറ്റ്യൂട്ട് ഓഫ് മെഡിക്കൽ സയൻസസ് മാറിയിരിക്കുന്നു എന്നുള്ളത് വളരെ വളരെ ശ്ലാഘനീയമായിട്ടുള്ള ഒരു കാര്യമായി കാണുന്നു. അഭിനന്ദനവും ഈ അവസരത്തിൽ അറിയിക്കുകയാണ്. I would like to congratulate the chairman and also the managing director and all other team members of this hospital. ഈ ഹോസ്പിറ്റലിൽ എല്ലാവരെയും അഭിനന്ദിക്കുന്നു. ഈ ഇന്നത്തെ വിഷയം വളരെ പ്രധാനപ്പെട്ടതാണ്. Perinatology and infertility. When we speak about the health indices of Kerala, we do have the best health indices in the country. When we speak about the infant mortality rate, we have the lowest infant mortality rate in the country, which is comparable or which is similar to the data of United States of America and other developed countries. And also when we speak about the maternal mortality rate, we do have the lowest maternal mortality rate in the country, and which is also the best when we compare the data with that of the developed countries. When we speak about the life expectancy, we do have the highest life expectancy in the country. ഈ മൂന്ന് കാര്യങ്ങളും ഇൻഫൻറ്റ് മോർട്ടാലിറ്റി, നവജാത ശിശു മരണനിരക്ക് നമ്മൾ പറയുമ്പോൾ രാജ്യത്തെ ഏറ്റവും കുറവ് നവജാത ശിശു മരണനിരക്കുള്ള സംസ്ഥാനം കേരളമാണ്. അതോടൊപ്പം തന്നെ മെറ്റേണൽ മോർട്ടാലിറ്റി റേറ്റ്, മാതൃമരണനിരക്ക് പറയുമ്പോൾ രാജ്യത്തെ ഏറ്റവും കുറവ് മാതൃമരണനിരക്കുള്ള സംസ്ഥാനം കേരളമാണ്. ആയുർ ദൈർഘ്യം ഏറ്റവും കൂടുതലുള്ള സംസ്ഥാനം കേരളമാണ്. നമ്മുടെ പൊതുജനാരോഗ്യ പ്രവർത്തനങ്ങൾ എന്തുകൊണ്ടാണ് നമുക്ക് നിപ്പായോ അല്ലെങ്കിൽ അതുപോലെയുള്ള പകർച്ചവ്യാധികളെ പ്രതിരോധിക്കാൻ കഴിയുന്ന നമ്മുടെ പൊതുജനാരോഗ്യ സംവിധാനം അത്ര സുശക്തമായതുകൊണ്ടാണ്. ഇതൊരു ദിവസം കൊണ്ടും 2 ദിവസം കൊണ്ടും നമ്മൾ നേടിയ ഒരു നേട്ടമല്ല. നവോത്ഥാന കാലഘട്ടത്തിൽ തുടങ്ങി നമുക്കുണ്ടായ ബോധ്യങ്ങളും നമ്മുടെ കാഴ്ചപ്പാടുകളുമാണ്. ഇപ്പോൾ കേരളത്തിൻ്റെ ആദ്യ നിയമസഭ പാസാക്കിയ സുപ്രധാനമായിട്ടുള്ള നിയമങ്ങളിലൊന്ന് സാർവത്രിക വിദ്യാഭ്യാസ നിയമമായിരുന്നു. എല്ലാവർക്കും വിദ്യാഭ്യാസം എന്നുള്ളതായിരുന്നു. അപ്പോൾ സാമൂഹ്യ മുന്നേറ്റത്തിലൂടെയും വിദ്യാഭ്യാസ മുന്നേറ്റത്തിലൂടെയുമാണ് നാം ഈ തലത്തിലുള്ള ബോധ്യങ്ങളിലേക്ക് എത്തപ്പെട്ടത്. ഒരു കുഞ്ഞ് ജനിക്കുമ്പോൾ ആ കുഞ്ഞ് മരിക്കാൻ പാടില്ല, ആ കുഞ്ഞ് ആരോഗ്യത്തോടെ ഇരിക്കണം. ഒരു പ്രസവം നടക്കുമ്പോൾ ഒരു സ്ത്രീക്ക് മരണം സംഭവിക്കാൻ പാടില്ല, ആ സ്ത്രീ, ആ അമ്മ ആരോഗ്യത്തോടെ ഇരിക്കണം. അമ്മയുടെയും കുഞ്ഞിൻ്റെയും ആരോഗ്യം വളരെ വളരെ പ്രധാനപ്പെട്ടതാണ്. അതോടൊപ്പം തന്നെ ആളുകൾ മരണപ്പെടുമ്പോൾ അത് ഏത് തരത്തിലുള്ള രോഗം മൂലമാണെങ്കിലും അങ്ങനെ മരിക്കാതിരിക്കുന്നതിന് അതിന് ചികിത്സ കൊടുക്കണമെന്നുള്ളത്. ഇപ്പോൾ നമ്മുടെ പോപ്പുലേഷൻ 3.5 കോടിയാണ്. 3.5 കോടി ജനങ്ങളാണ് കേരളത്തിലുള്ളത്. പക്ഷേ ഏറ്റവും കൂടുതൽ ഹോസ്പിറ്റൽസും ഏറ്റവും അധികം ഡോക്ടേഴ്സും, അതായത് ജനസംഖ്യാനുപാതികമായി നോക്കുമ്പോൾ രാജ്യത്തെ ഏറ്റവും ബെസ്റ്റ് റേഷ്യോ പ്രൊപ്പോർഷനുള്ള സ്റ്റേറ്റ് കേരളമാണ്. ഏറ്റവും കൂടുതൽ ഒരു പനി വന്നാൽ, ഒരു ജലദോഷം വന്നാൽ നമ്മൾ ഹോസ്പിറ്റലുകളെ ഹെൽത്ത് സമീപിക്കും. ഹെൽത്ത് സീക്കിംഗ് ബിഹേവിയർ ഏറ്റവും കൂടുതലുള്ള സംസ്ഥാനം കേരളമാണ്. അപ്പോൾ ഇതെല്ലാം ഇതിൻ്റെ ഭാഗമായിട്ട് നമ്മുടെ ആരോഗ്യ സൂചകങ്ങളെ മികച്ച നിലയിൽ നിലനിർത്തുന്നതിന് സഹായിച്ചിട്ടുണ്ട്. ഈ വർത്തമാന കാലഘട്ടത്തിലും നമ്മുടെ ഹെൽത്ത് ഇൻഡെക്സസ് ഏറ്റവും മികച്ചതാണ്, അതുകൊണ്ട് ഇത് മതി എന്നുള്ള നിലയിൽ നമ്മൾ തുടരുകയല്ല ചെയ്യുന്നത്. അതിന് പകരം ഇപ്പോൾ നിലവിൽ 1000 കുഞ്ഞുങ്ങൾ ജനിക്കുമ്പോൾ 2021 ഡേറ്റ 1000 കുഞ്ഞുങ്ങൾ ജനിക്കുമ്പോൾ 6 കുഞ്ഞുങ്ങൾ മരണപ്പെടുന്നു എന്നുള്ളതായിരുന്നു. ദേശീയ ശരാശരി അത് 27ആണ്. 27നും 30നും ഇടയിലാണ്. 1000 കുഞ്ഞുങ്ങൾ ജനിക്കുമ്പോൾ അത് 27ഉം 30ഉം കുഞ്ഞുങ്ങൾ മരിക്കുന്നു. കേരളത്തിൽ 6 കുഞ്ഞുങ്ങൾ എന്നുള്ളതാണ്. ട്രൈബൽ മേഖലയിലേക്ക് പോകുമ്പോൾ ദേശീയ തലത്തിൽ 1000 കുഞ്ഞുങ്ങൾ ജനിക്കുമ്പോൾ 57 മുതൽ 60 കുഞ്ഞുങ്ങൾ വരെ മരിക്കുന്നു എന്നുള്ളതാണ്. അപ്പം നമ്മൾ കണ്ടത് 1000 കുഞ്ഞുങ്ങൾ ജനിക്കുമ്പോൾ 6 കുഞ്ഞുങ്ങൾ മരിക്കുന്നു എന്നുള്ളത്, ആ ഡേറ്റ ഇനിയും കുറച്ചു കൊണ്ടുവരുന്നതിന് സാധിക്കുമോ എന്നുള്ളതായിരുന്നു. അതിന് വർത്തമാന കാലഘട്ടത്തിലെ നമ്മൾ ചെയ്ത ഏറ്റവും മനോഹരമായിട്ടുള്ളൊരു ഇൻ്റർവെൻഷനിൽ ഒന്നാണ് ഹൃദയം. കോൺജനിറ്റൽ ഹാർട്ട് ഡിസീസസ് ചികിത്സിക്കുന്നതിന് വേണ്ടി നമ്മളൊരു പരിപാടി ആവിഷ്കരിച്ചു. നമുക്കറിയാം, ഒരു പുരുഷനും ഒരു സ്ത്രീയും അല്ലെങ്കിൽ ഒരു ഭാര്യയും ഭർത്താവും അവരുടെ ജീവിതത്തിൻ്റെ ഒരു തുടക്കത്തിൽ അവർക്ക് കുഞ്ഞൊക്കെ ആകുമ്പോൾ ഫിനാൻഷ്യലി സ്റ്റേബിൾ ആകണമെന്നില്ല. എല്ലാവർക്കും സാമ്പത്തികമായിട്ട് ഒരു രോഗത്തെയോ അല്ലെങ്കിൽ കുഞ്ഞിനൊരു അസുഖമുണ്ടായാൽ അത് സർജറി ചെയ്യാനുള്ള ഒരു സാമ്പത്തിക ചുറ്റുപാടൊന്നും ഉണ്ടാകണമെന്നില്ല. നമ്മൾ കണ്ടത് ഈ കോൺജനിറ്റൽ ഹാർട്ട് ഡിസീസ് ഈ കുഞ്ഞുങ്ങളുടെ മരണത്തിനുള്ള ഒരു പ്രധാന കാരണമാണ് എന്നുള്ളതാണ്. അങ്ങനെയാണ് സംസ്ഥാന സർക്കാർ ഒരു പ്രോഗ്രാം ആവിഷ്കരിച്ചത്. ആ പ്രോഗ്രാമിൻ്റെ പേരാണ് ഹൃദയം ഫോർ ലിറ്റിൽ ഹാർട്ട്സ്, കുഞ്ഞു ഹൃദയങ്ങൾക്കായി ഹൃദയം എന്നുള്ളതാണ്. ഞാൻ ഈ സംസാരിക്കുമ്പോൾ ഇന്ന് 6450 സർജറികൾ ഹൃദയത്തിൻ്റെ ഭാഗമായി സംസ്ഥാന സർക്കാർ ചെയ്തിട്ടുണ്ട്. അതായത് ഫ്രീ ആയിട്ട് ഹാർട്ട് സർജറി കൊടുക്കുകയാണ്. ഇത്ര സമയത്തിനുള്ളിൽ ഏറ്റവും ജനിച്ച് എത്രയും പെട്ടെന്ന് ഹൃദയ സംബന്ധമായിട്ടുള്ള അസുഖങ്ങളുണ്ടെങ്കിൽ സർജറി ചെയ്യുകയാണ്. 12,000-ലധികം കേസസ് രജിസ്റ്റർ ചെയ്തതിൽ 6450 കേസുകൾ നമ്മൾ ഇതുവരെ ചെയ്തിട്ടുണ്ട്. ഈ 12,000-നും സർജറിക്കൽ ഇൻ്റർവെൻഷൻ ആവശ്യമുള്ളതല്ല, അല്ലാതെയുള്ള അസുഖങ്ങളുള്ള കുഞ്ഞുങ്ങളുമുണ്ട്. അപ്പോൾ അതോടൊപ്പം തന്നെ നമ്മൾ ചെയ്യുന്ന മറ്റൊരു കാര്യം അത് ന്യൂ ബോൺ സ്ക്രീനിങ് ആണ്. അതായത് ജനിച്ച് 24 മണിക്കൂറിനുള്ളിൽ ബർത്ത് ഡിഫക്ട്സ് നമ്മൾ സ്ക്രീൻ ചെയ്യും. രാജ്യത്ത് തന്നെ ഏറ്റവും മികച്ച രീതിയിൽ, മെച്ചപ്പെട്ട രീതിയിൽ ബർത്ത് ഡിഫക്ട് സ്ക്രീനിങ് ചെയ്യുന്ന ഒരു സംസ്ഥാനമാണ് കേരളം. വി ഹാവ് ഡെവലപ്ഡ് എ പോർട്ടൽ കോൾഡ് ശലഭം, where we enter all these details of the children. ന്യൂ ബോൺ ബേബീസിൻ്റെ ഈ ഡീറ്റെയിൽസ് എല്ലാം നമ്മൾ അതിൽ എൻറ്റർ ചെയ്യും. അതുകൂടാതെ ഈ ബർത്ത് ഡിഫക്ട്സ് ആണ് ന്യൂ ബോൺ സ്ക്രീനിങ്ങിൻ്റെ ഭാഗമായിട്ട് 24 മണിക്കൂറിനുള്ളിൽ നമ്മൾ കണ്ടുപിടിക്കാൻ ശ്രമിക്കുന്നത്. Now we have started a program where we have decided to integrate the private sector also to capture the data from the private sector. Private മേഖലയിൽ നിന്ന് കൂടിയുള്ള ഈ ഡേറ്റ ക്യാപ്ചർ ചെയ്ത് അതൊരു സമഗ്രമായിട്ട് ഒരു പൂർണ്ണമായിട്ട് ആക്കുന്നതിന് വേണ്ടിയിട്ടുള്ള we have started a program and we have decided to integrate this at the district level where DMOs will have a lead role. District medical officers ഒരു പ്രധാനപ്പെട്ട റോൾ അതിലുണ്ടായിരിക്കും ഇൻ്റഗ്രേഷൻ്റെ ഭാഗത്ത്. രണ്ടാമത് ഇതിൻ്റെ ഭാഗമായി നമ്മൾ ചെയ്യുന്നത് ഓഡിയോ കേൾവിശക്തി കുഞ്ഞിൻ്റെ കേൾവിശക്തി കൂടി പരിശോധിക്കുന്നു. മൂന്നാമത് നമ്മൾ ഇതിൻ്റെ ഭാഗമായി ചെയ്യുന്ന ഒരു കാര്യമാണ് ഇൻബോൺ എറേഴ്സ് മെറ്റബോളിസം. അതിൻ്റെ ഭാഗമായി തൈറോയിഡിൻ്റെയൊക്കെ കാര്യങ്ങൾ വരും, കുഞ്ഞിൻ്റെ ബൗദ്ധികമായിട്ടുള്ള വളർച്ചയുടെ കാര്യങ്ങളും ഒക്കെ തന്നെ ഇതിൻ്റെ ഭാഗമായിട്ട് സ്ക്രീൻ ചെയ്യപ്പെടും. അപ്പോൾ ഇത് കേരളത്തെ സംബന്ധിച്ചിടത്തോളം നമ്മൾ മുന്നോട്ട് പോകുമ്പോൾ നമ്മൾ ഏറ്റെടുത്തിട്ടുള്ള വളരെ പ്രധാനപ്പെട്ട കാര്യങ്ങളാണ്. ഇന്നിവിടെ ചർച്ച ചെയ്യാൻ പോകുന്നത് കുഞ്ഞ് ജനിക്കുന്നതിന് തൊട്ട് മുമ്പ് അല്ലെങ്കിൽ ഗർഭസ്ഥാവസ്ഥയിലുള്ള കുഞ്ഞിൻ്റെ അവസ്ഥകളെ സംബന്ധിച്ച് അല്ലെങ്കിൽ രോഗങ്ങളെ സംബന്ധിച്ച് നേരത്തെ തന്നെ അത് കണ്ടുപിടിക്കുന്നത് സംബന്ധിച്ചിട്ടുള്ള കാര്യങ്ങളും അത് അവിടെ തന്നെ ഗർഭാശയത്തിൽ വെച്ച് തന്നെ ഗർഭപാത്രത്തിൽ വെച്ച് തന്നെ ഇത് ട്രീറ്റ് ചെയ്യാൻ കഴിയുന്ന സംബന്ധിച്ചിട്ടുള്ള കാര്യങ്ങളുമാണ്. അപ്പോൾ ഇതിൻ്റെ ഒരു പോസിബിലിറ്റീസും അതിൻ്റെ സാധ്യതകളും എക്സ്പ്ലോർ ചെയ്യുക എന്നുള്ളത് വളരെ വളരെ പ്രധാനപ്പെട്ട ഒരു കാര്യമാണ്. ഇത് ലേൺ ചെയ്യുക എന്നുള്ളതും വളരെ പ്രധാനപ്പെട്ട ഒരു കാര്യമാണ്. അതുകൊണ്ടാണ് ഇന്നത്തെ ഈ കോൺഫറൻസ് വളരെ പ്രധാനപ്പെട്ടതായിരിക്കുന്നത്. പെരിനെറ്റോളജി ആൻഡ് ഇൻഫെർട്ടിലിറ്റി ഇതിനോടൊപ്പം തന്നെ വളരെ പ്രധാനപ്പെട്ടത് നമ്മളെപ്പോഴും എല്ലാം ആത്യന്തികമായി നമ്മൾ ശ്രമിക്കുന്നത് വി ആർ ട്രൈങ് ടു ഇംപ്രൂവ് ദ ക്വാളിറ്റി ഓഫ് ലൈഫ്. നമ്മുടെ ജീവിതത്തിൻ്റെ ക്വാളിറ്റിയെ മെച്ചപ്പെടുത്തുന്നതിന് വേണ്ടിയിട്ടാണ് ശ്രമിക്കുന്നത്. നമ്മുടെ ഈ പ്രവർത്തനങ്ങളൊക്കെ അതിൻ്റെ ഭാഗമായിട്ടാണ് സംഭവിക്കുന്നത്. തീർച്ചയായിട്ടും ഈ ഒരു കോൺഫറൻസിൻ്റെ ഔട്ട്കം നമ്മുടെ ഈ മേഖലയുമായി ബന്ധപ്പെട്ട ഹോസ്പിറ്റലിൻ്റെ പ്രവർത്തനങ്ങളെയും അതോടൊപ്പം ആരോഗ്യ മേഖലയിൽ ഇതുമായി നടത്തുന്ന പ്രവർത്തനങ്ങളെയും ശാക്തീകരിക്കുന്നതിന് ഇവിടെ നടക്കുന്ന ഇൻ്റർവെൻഷൻസിലൂടെ സാധിക്കും എന്നുള്ളതാണ് ഞാൻ കരുതുന്നത്. അങ്ങനെ ആശംസിക്കുന്നു. അതോടൊപ്പം ഒരു കാര്യം കൂടി പറഞ്ഞുകൊണ്ട് എൻ്റെ വാക്കുകൾ അവസാനിപ്പിക്കുകയാണ്. അത് മറ്റൊന്നുമല്ല, നമുക്ക് നല്ല ആശുപത്രികളുണ്ട്, നല്ല ആരോഗ്യ പ്രവർത്തകരുണ്ട്. നമ്മുടെ ആരോഗ്യ പ്രവർത്തകരാണ് ആഗോളതലത്തിൽ എല്ലായിടത്തും. ഇപ്പോൾ കഴിഞ്ഞ ദിവസം ഓസ്ട്രേലിയയുടെ ഡെപ്യൂട്ടി ചീഫ് മിനിസ്റ്റർ അവിടെ തിരുവനന്തപുരത്ത് വന്ന് എന്നെ കണ്ടിരുന്നു. എന്നെ വന്ന് കണ്ടിട്ട് പറഞ്ഞത് ഞങ്ങൾ കേരള സംസ്ഥാനത്തോട് നന്ദി പറയുകയാണെന്നാണ് പറഞ്ഞത്. കാരണം അത്രയും അധികം ഹെൽത്ത് വർക്കേഴ്സ് ഓസ്ട്രേലിയയിലുണ്ട്, എല്ലായിടത്തും. ഇപ്പോൾ UK നമ്മൾ നോക്കിയാലും ലോകത്തിൻ്റെ ഏത് രാജ്യം നോക്കിയാലും അവിടെ ചെല്ലുമ്പോൾ മലയാളിയായിട്ടുള്ള ഒരു ഡോക്ടറോ നമ്മുടെ ഒരു നഴ്സിംഗ് ഓഫീസറോ അല്ലെങ്കിൽ മറ്റ് പാരാമെഡിക്കൽ സ്റ്റാഫോ ഒക്കെ അവിടെ ഉണ്ടാകും. അപ്പം എന്തുകൊണ്ടാണ് നമുക്ക് ലോകത്തെ കേരളത്തിലേക്ക് ക്ഷണിക്കാൻ സാധിക്കാത്തത്? കേരളത്തിലേക്ക് വന്ന് ഹീൽ ചെയ്ത് ചികിത്സിച്ച് ട്രീറ്റ് ചെയ്ത് പോകാൻ സാധിക്കാത്തത് എന്തുകൊണ്ടാണ്? വളരെ ഗൗരവത്തോടെ സർക്കാർ ചിന്തിക്കുന്ന ഒരു കാര്യമാണ്. കേരളത്തിൻ്റെ പ്രൈവറ്റ് സെക്ടറിനെയും ഗവൺമെൻറ് സെക്ടറിനെയും യോജിപ്പിച്ചെന്ന് വെച്ചാൽ ലിങ്ക് ചെയ്തുകൊണ്ട് ആ ഒരു വലിയൊരു ലക്ഷ്യം സാക്ഷാത്കരിക്കുന്നതിന് വേണ്ടിയിട്ടുള്ള ഒരു പ്രവർത്തനം സർക്കാർ ഏറ്റെടുത്തിട്ടുണ്ട്. അപ്പോൾ പുറത്തു നിന്നുള്ള പേഷ്യൻസ്, അത് ഏത് മേഖലയുമായി ബന്ധപ്പെട്ട് ഏത് ട്രീറ്റ്മെൻറ്റ് ആവശ്യമുള്ളവരാണോ അവർക്ക് കേരളത്തിൻ്റെ ആരോഗ്യ മേഖലയിലേക്ക് വന്നുകൊണ്ട് അവർ ഇഷ്ടപ്പെടുന്ന ഹോസ്പിറ്റലിൽ നിന്ന് ട്രീറ്റ്മെൻറ്റ് എടുക്കുന്നതിനും ആ ട്രീറ്റ്മെൻറ്റ് ഏറ്റവും മികച്ച ട്രീറ്റ്മെൻറ്റ് അവർക്ക് നൽകുന്ന ഒരു സാഹചര്യം ഉണ്ടാകുക എന്നുള്ളത് തന്നെയാണ്. അതിന് സാധിക്കും. അതൊരു ടൈം ബൗണ്ടായിട്ട് ആ ഒരു പ്രവർത്തനം നടത്തണം എന്നുള്ളത് നമ്മൾ കണ്ടിട്ടുണ്ട്. ചില തടസ്സങ്ങൾ അതിൻ്റെ ഭാഗമായിട്ട് ഉണ്ട്. ആ തടസ്സങ്ങൾ ഔദ്യോഗികമായിട്ടുള്ള കാര്യങ്ങൾ നീക്കുന്നതിന് കേന്ദ്ര ഗവൺമെൻറ്റുമായി കൂടി ആരോഗ്യ വകുപ്പ് സംസ്ഥാന സർക്കാർ അതിനെ സംബന്ധിച്ചിട്ടുള്ള ചർച്ചകൾ നടത്തുന്നുണ്ട്. ഈ അവസരത്തിൽ എല്ലാ ആശംസകളും ഞാൻ നേരുന്നു. Dr. Ranjan Kumar Pejawar is also here. He is from Bengaluru. And also some others are also joining from other parts of the country. I think I learn. Okay, ഈ അവസരത്തിൽ എല്ലാവിധമായിട്ടുള്ള ആശംസകൾ നേർന്നുകൊണ്ട് ഔപചാരികമായി നമ്മുടെ UPCON 2023 ഉദ്ഘാടനം ചെയ്യുന്നതായി അറിയിച്ചുകൊള്ളുന്നു. നന്ദി, നമസ്കാരം.
Thank you, ma'am. Your interventions are truly making a difference in the lives of common people.
For the keynote address, we kindly invite Professor Dr. C.P. Vijayan, Pro Vice Chancellor, Kerala University of Health Sciences. He has a MBBS degree from University of Kerala, Trivandrum.
Thank you, ma'am, for joining us in spite of your busy schedule.
Professor Dr. C.P. Vijayan sir has a MBBS degree from University of Kerala, Trivandrum. He has completed his post-graduation in OBG from Mahatma Gandhi University. He also has an MPhil in clinical epidemiology from University of Kerala. He has more than 30 publications to his credit. He also has a share of contributions to various medical books. He has been awarded various research grants. He is the recipient of the first Best Teacher Award from Kerala University of Health Sciences. He has been recognized for innumerable social works, including participation in special medical camps for endosulfan victims in Kasaragod. He has assumed various academic and administrative positions in several government healthcare organizations. Over to you, sir.
Honorable Chairman, Sri P.M. Sebastian, Honorable Minister for Health and Family Welfare, Srimati Veena George, Father Dr. Alexander Kudarathil, Dr. Ranjan Kumar Pejawar, Dr. Manoj, Dr. Sajid, board members of Dr. K.M. Cherian Institute of Medical Sciences, organizers of this conference, delegates and faculty. It's indeed a great pleasure to deliver the keynote address here, but time constraints are there. I won't take too much time. It was Minister mentioned about the importance of the treatment of infertility, perinatology and neonatology in her speech. Let me explain the importance further from the societal point of view in the present context. As all of you know, the population is aging. That was also mentioned in her speech. Aging in population that is more predominant in the state of Kerala. Now nearly 11 to 13% of the population is aged population or senior citizens. And in the next 1 or 2 decades, the proportion will rise to nearly 20%. That means 1 in every 5 persons that we see outside will be a senior citizen. So we have to plan our health scenario to cater for this elderly population. So the government of Kerala is organizing several programs. Vayomitram എന്ന് പറയുന്ന ഒരു പരിപാടിയുണ്ട് അല്ലേ? വയോമിത്രമുണ്ട്, അവർക്ക് ചികിത്സ കൊടുക്കുന്നുണ്ട്, മരുന്നുകൾ എത്തിക്കുന്നുണ്ട്. പക്ഷേ ഈ ചികിത്സ കൊടുക്കുവാനും സംരക്ഷണം കൊടുക്കുവാനും കെയർ കൊടുക്കുവാനുമൊക്കെ നമുക്ക് യങ് ജനറേഷൻ ആവശ്യമാണ്. യങ് ജനറേഷൻ. അവിടെയാണ് ഈ ഇൻഫെർട്ടിലിറ്റിയുടെയും അതുപോലെ പെരിനറ്റോളജിയുടെയും എല്ലാം പ്രാധാന്യം എടുത്തു പറയേണ്ടി വരുന്നത്. നമ്മുടെ അടുത്ത തലമുറ, അതിനുവേണ്ടി നമ്മൾ നോക്കുന്ന ഇന്നത്തെ യങ് ജനറേഷൻ, അവരുടെ കാര്യം എടുത്തു നോക്കിയാലോ, പലരും മാരേജിന് പോലും താല്പര്യപ്പെടുന്നില്ല ഇന്നത്തെ സമൂഹത്തിൽ. കുറച്ച് കൂട്ടര് മാരേജ് ചെയ്യാൻ റെഡിയാണ്, പക്ഷേ they don't want children. ഇനി വേറൊരു കൂട്ടരുണ്ട്, അവർ റെഡിയാണ്, പക്ഷേ ആഫ്റ്റർ സെറ്റിലിംഗ് എവരിതിങ് ബൈ ദ ടൈം അതെ ഇവിടെ ഡിസ്കസ് ചെയ്ത പ്രോബ്ലംസ് എല്ലാം വരികയായി. അപ്പം അതുകൊണ്ട് ഈ ഇൻഫെർട്ടിലിറ്റിയുടെയും പെരിനറ്റോളജിയുടെയും പ്രാധാന്യം വർദ്ധിച്ചുകൊണ്ടിരിക്കുകയാണ്, ഡേ ബൈ ഡേ വർദ്ധിച്ചുകൊണ്ടിരിക്കുകയാണ്. ഈ ഒരു പോയിന്റ് പറയാൻ വേണ്ടിയാണ് ഞാൻ ഇത്രയും പറഞ്ഞത്. തീർച്ചയായിട്ടും ഇത് സമൂഹത്തിൻ്റെ കണ്ണു തുറപ്പിക്കേണ്ട ഒരു പ്രധാനപ്പെട്ട ഭാഗമാണെന്ന് ഞാൻ കരുതുന്നു. പിന്നെ ഇവിടെ ചെയർമാൻ ഈസ് എൻ ഇൻഡസ്ട്രിയലിസ്റ്റ് ആൻഡ് ഹെൽത്ത് അഡ്മിനിസ്ട്രേറ്റർ. അതുപോലെ നമ്മുടെ ഫാദർ കൂടാരത്തിൽ തിയോളജി എക്സ്പേർട്ടാണ്. ഇവിടെ ഡോക്ടേഴ്സ് ഉണ്ട്, മറ്റ് പല പല പ്രവൃത്തികൾ ചെയ്യുന്നവരുണ്ട്. ഈ ഹെൽത്തിനൊരു പ്രത്യേകതയുണ്ട്. യു തിങ്ക് അബൌട്ട് എനി ഫാക്ടർ അണ്ടർ ദി സൺ, ഇൻക്ലൂഡിംഗ് സൺ, ദാറ്റ് വിൽ ഹാവ് ഡയറക്റ്റ് ഓർ ഇൻഡയറക്റ്റ് റിലേഷൻ വിത്ത് ഹെൽത്ത്. അതാണ് ഹെൽത്തിൻ്റെ ഒരു പ്രത്യേകത. ആ ഒരു പ്രത്യേകത നിലനിൽക്കുമ്പോഴും വിവിധ രംഗങ്ങളിൽ പ്രവർത്തിക്കുന്നവർ, തിയോളജി ആയാലും ടെക്നോളജി ആണെങ്കിലും അഡ്മിനിസ്ട്രേഷൻ ആണെങ്കിലും ട്രാൻസ്പോർട്ടേഷൻ ആണെങ്കിലും എന്താണെങ്കിലും ഹെൽത്ത് ആണെങ്കിലും ഭാരതീയ ദർശനമനുസരിച്ച് എല്ലാവരും ഒരേ ലക്ഷ്യത്തിന് വേണ്ടിയാണ് പ്രവർത്തിക്കുന്നത്. ഒരൊറ്റ ലക്ഷ്യം, വെൽബീയിങ് അല്ലെങ്കിൽ ക്ഷേമ ഐശ്വര്യം, അതിനുവേണ്ടിയാണ് പ്രവർത്തിക്കുന്നത്. ട്രയാങ്കുലേറ്റ് ചെയ്ത് കൺജോയിൻ്റ് ചെയ്ത് ആ ഒരു പോയിന്റിലേക്ക് എത്തും. അതുകൊണ്ടാണ് നമ്മുടെ ഭാരത ദർശനത്തിൽ പറയുന്നത് സ്വസ്തി പ്രജാപ പരിപാലയന്ത പ്രായേണ മാർഗേണ മഹിം മഹിഷ ഗോബ്രാഹ്മണേഷു സുഖമസ്തു നിത്യം ലോകാ സമസ്ത സുഖിനോ ഭവന്തു എന്ന് പറയുന്നത്. ഇവിടെ ഗോബ്രാഹ്മണേഷു എല്ലാം പറയുന്നുണ്ട്. കാര്യം നന്മ നിറഞ്ഞ മനുഷ്യരെയും ജീവജാലങ്ങളെയും പ്രകൃതിയെയും എല്ലാം അവരുടെ ആരോഗ്യം കാത്തു സൂക്ഷിച്ചാൽ മാത്രമേ നമ്മുടെ ആരോഗ്യം കാത്തു സൂക്ഷിക്കാൻ പറ്റുകയുള്ളൂ എന്ന് ഇന്ന് നമുക്കറിയാം. വൺ ഹെൽത്തിൻ്റെ കൺസെപ്റ്റ് അതാണ്. ഒരിക്കൽ കൂടി എല്ലാവർക്കും ലോകാസമസ്ത അല്ലെങ്കിൽ സർവേ ഭവന്തു സുഖിന ആശംസിച്ചുകൊണ്ട് എൻ്റെ വാക്കുകൾ നിർത്തുന്നു. ജയ് ഹിന്ദ്.
Thank you, sir, for that insightful talk.
Next, we invite Dr. Ranchan Kumar Pejawar, Chief Neonatologist, People Tree Hospital, Bangalore, for the felicitation.
Good afternoon. Dignitaries on the dais, dignitaries off the dais, the staff members of the institute, delegates, guests, and friends. It is my great pleasure to be here at the International Infertility and Perinatal CME. Dr. Sajjad was one of my early registrars in Bangalore, and I'm very proud of him. He has taken the lead of organizing this CME. And the CME is brilliant. It has ticked all the boxes. It is international, it is perinatal, and infertility is required because the babies are required. And the hospital has all the sub and super specialities to look after the mothers and the babies. So it ticks all the marks. And like the Honorable Minister said, the private-public partnership is very, very important for the success of healthcare delivery and healthcare activities. So even that is fulfilled by this CME. Kerala is leading, we all know. We are very proud of the state of Kerala, toppers from a long time regarding neonatal mortality, infant mortality, under 5 mortality, maternal mortality, everything. There are beautiful, handsome gentlemen and beautiful ladies are there, but even they have to look at the mirror from time to time to see how they are. In the same way, medicine being a very, very progressive field, updating is very essential. Otherwise, we will stagnate. And CMEs like this will fulfill that. And looking at the program, I am very happy and sure that the intentions and the reasons for holding this CME will be fulfilled. I once again thank all here for inviting me as an orator, and I hope you have enjoyed your first half of the CME, and there is still more to come in the afternoon. Thank you very much.
Thank you, sir.
Now we invite Dr. Manoj VC, Professor and Head, Department of Neonatology, Jubilee Mission Medical College and Research Institute, for the felicitation.
Respected dignitaries on the dais, off the dais, and my dear friends. I have great honor and pleasure to be part of this event. One of the events that Dr. Cherian Hospital and Institute conducts over the periods of time in the last few years. There are times when it becomes a great challenge to manage or rather balance the interests of the mother and the baby, and there are potential areas of conflicts. And this is where perinatology becomes a important field for discussion. And as the keynote speaker was mentioning, as we age, we have an aging population, later pregnancies, infertility, the problems are on the rise. And until we talk to each other, those who take care of the baby versus the those who take care of the mother, sit together and discuss, we are not going to do justice to both the mother and the baby. So I am really thankful to this institute for having organized this program, and I am sure that all of us will benefit learning very few important concepts from this conference. Thank you. Thank you so much.
Thank you, sir.
Now we call upon Shri PM Sebastian, sir.
Now I invite Dr. Sajid Hashim, Head and Senior Consultant, Department of Pediatrics and Neonatology, to deliver the vote of thanks.
Good afternoon, everyone. Actually, I would have planned to say good morning, but we are late by half an hour. So I feel honored and privileged to deliver a vote of thanks on this special occasion. On behalf of the Dr. K.M. Cherian Institute of Medical Sciences, I would like to convey our deep regards and heartfelt thanks to our Honorable Minister of Health, Women and Child Development, Government of Kerala, Srimati Veena George. We are proudly grateful for her invaluable time and effort in inaugurating this function amid her busy schedule. We acknowledge the guest of honor, Dr. C.P. Vijayan, Pro Vice Chancellor of Kerala University of Health and Allied Sciences. His keynote address and remarkable insights were truly enlightening, and we appreciate his significant contribution to this event. No event, conference, or function can come to fulfillment without a hard-working leader. Conducting this CME program would have been impossible without zealous efforts of our chairman, Mr. P.M. Sebastian. His dedication of time and energy to this program is greatly appreciated, and we sincerely thankful to you, sir. I also express our gratitude to our Managing Director, Reverend Father Alexander Kudarathil, for his generous support of this event. Father's encouragement has consistently motivated all our endeavors, and thank you, Father, for your unwavering support. I am immensely grateful to our guest speaker, Professor Dr. Ranjan Kumar Pejawar, Chief Neonatologist, People Tree at Meenakshi Hospital, Bengaluru. He took his demanding schedule to felicitate this occasion, also delivering oration of this event. Sir, I mention my deepest sense of appreciation. I also express my heartfelt thanks to Professor V.C. Manoj, Head of the Department of Neonatology, Jubilee Mission Medical College, Thrissur, who have facilitated this occasion and will be participating in the following scientific session. I would like to express our sincere gratitude to all the invited speakers, which include my teachers, my colleagues, and invited delegates. I would also like to extend our heartfelt appreciation to all participants of this program. I would like to thank our medical superintendent, Dr. Naveen Pillai, all the doctors and staff members who tried too hard to make this occasion lively. I extend my gratitude to Chief Operating Officer, Marketing Department, HR Department, Guest Relations, media person, and police officials. I would also like to thank all the people who have worked for the technical arrangements, stage settings, cafeteria chef cooks, security staff, photographers, sound and light engineers. In closing, I extend our sincere appreciation to all who have played pivotal role in ensuring the success of this event. Your contributions have made this occasion truly exceptional. Thank you. Thank you all. Jai Hind.
Thank you, sir. We also request Sri P.M. Sebastian, sir, our chairman, to hand over the memento to Dr. C.P. Vijayan, sir, Pro Vice Chancellor, Kerala University of Health Sciences.
Thank you, sir. We are at the conclusion of the inaugural ceremony. So kindly everyone, please rise for the national anthem.
पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उत्कल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मागे गाहे तब जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Kindly everyone, please be seated. We will be continuing with the presentations.
Now we'll move on with the CME. We have 2 more talks left before we break for lunch.
Our next topic is newer concepts in the perinatal interventions that improve outcomes in preterm birth. I invite Dr. Nelby George, Consultant in Charge, Department of Neonatology, TMM Hospital, Tiruvalla, and Dr. Jacob Abraham, HOD and Professor, Pediatrics and Neonatology, Pushpagiri Medical College Hospital, Tiruvalla, to chair the event. I also call upon Professor Dr. V.C. Manoj, Head of the Department, Neonatology, Jubilee Mission Medical College and Research Center, Thrissur. Dr. V.C. Manoj is a Professor and Head, Department of Neonatology, Jubilee Mission Medical College and Research Institute, Thrissur. He is the President-elect 2024 of National Neonatology Forum of India. He was a National Executive Member, Neonatology Chapter of Central IAP. He was also the State Academic Coordinator, Kerala for Advanced Neonatal Resuscitation Program. He is a trainer of trainers in Basic Neonatal Resuscitation Program and NSSK projects, Navjat Shishu Suraksha Karyakram. He was a President of NNF Kerala during the years 2019 and 2020. And he is elected President of IAP Thrissur 2017 and 18. And he was also the Secretary of Neonatology Forum of Kerala during the years 2011 to 2013. We welcome you, sir. Over to you.
Thank you for the kind words. Well, ladies and gentlemen, in the next half an hour or so, we would try to have a re-look at the interventions that we carry out in the perinatal period to improve the outcome, especially in the most vulnerable set of patients, the preterm babies. Perinatology has progressed in leaps and bounds. Gone are the days when babies used to be delivered, holding the legs, keeping the baby upside down, and striking the baby to make the baby breathe. The era has changed, and we have tremendous progress. But one thing we have realized over a couple of years is that the more we talk about newer advances, the more we come back to some of the golden old practices. So before we go on to the newer insights into the intervention that we do, some of the great interventions that saved babies in the last century, let's remember them. Hand hygiene, one of the interventions, very low cost, but probably we still consider as one of the most important intervention. And antenatal steroids, we all agree, is the intervention of 20th century, probably as far as perinatology is concerned. You intervene in the maternal, to the mother in the maternal phase of the whole perinatology, and you get a beautiful outcome in the in the neonatal phase of the perinatology. Antenatal steroids have gone a great way, and then probably we will discuss some of the newer concepts in antenatal steroids in the next few minutes. Babies are, more and more babies are born preterm, so interventions like surfactant and then delivery room CPAP were actually newer things that were suggested in the last century, but we know they are all now the standard norm that we do. And evolution of the neonatal resuscitation protocol has probably paved the way for improving the already existing practices in neonatal resuscitation. There is a vast list of interventions, so I would like to concentrate on few of the interventions that probably are the most important ones, and probably where there is some newer things happening. Of course, 5 of them I will just mention, and then I am sure that the time is so short, we may discuss the other ones also if there is time. Maternal lifestyle. It has been realized in this century that the maternal lifestyle is one of the most important parameters that influences the neonatal outcome, and it is being smart. You do something in the primary prevention level, probably that is being smart. Body mass index of mothers is a parameter that has been looked at, and from the original study of 24,000 women, this is of course from US, when they looked at the body mass index of the mother versus the incidence of miscarriage, stillbirth, neonatal death, and the death in the postnatal period in the first year, they realized this is the curve they got. And I'm sorry, there is no pointer. So, the BMI of 20 was a magical figure, and anything between 18.5 to 23 was where we had the best results. This is something amazing and very interesting, because if you look at the body mass index of a lady at the time of consumption, I am very sure it's challenging to find them in this range. And this is something we need to really look at. And we have seen that as the BMI increases, the chances, the outcome becomes more and more worse. This is, you can say that this is just a one study, but probably it is not, because there is all the data that was piled up till then was subsequently analyzed, and then they came to the meta-analysis was titled Maternal Body Mass Index increasing to about 20 is associated with increased risk of miscarriage, stillbirth, neonatal death, and postnatal death. The problem is that this is a big challenge for most of us, because for us nutrition means eating a lot of food. We don't talk about micronutrients, and this has led to obesity being the norm rather than an abnormal feature. And probably the results, when you look at the perinatal outcome and the preterm outcome, this is a very challenging task for most of us. There is recently, in the last 5 years, a new branch of medicine called lifestyle medicine has been evolved with the formation of the American College of Lifestyle Medicine, and then subsequently they have formalized 6 pillars of lifestyle medicine, and all these 6 pillars have been evaluated in the pregnancy period, and they have all been related to the outcome. And it is better to talk about these primary prevention rather than creating a problem and then creating a preterm birth and then solving the riddles that comes with it. The 6 pillars, of course, healthy eating pattern is the most important pillar, adequate physical activity, and adequate measures for management of stress. The other 3 pillars are social connectivity, adequate sleep, 7 to 8 hours of sleep, and of course the substance abuse, in which the number of substances abused are going up. Even now food is also being abused when we go for such foods. And we also realize that we have just 25,000 genes of our own, whereas 3 million genes of ours are from our guts in our body, the microbiota that inhabit our gut, skin, and various other organs. And their genetic material has a say. And if you feed them the right kind of food, they will give the right kind of signal to the brain. And maternal nutrition during pregnancy probably, and the maternal microbiota has now been a subject of lot of research, lot of papers coming out saying that this has implications in the fetal well-being and subsequently the neonatal well-being. The best would be a mother on a healthy diet, taking care of all the 6 pillars of lifestyle medicine and delivering a term through vagina and exclusively breastfeeding for 6 months. This is a tall challenge. When you have late marriages, late pregnancies, infertility treatment, you get preterm delivery, you get abnormal babies, and they are born by cesarean section, so the first good microbiotal influence that they are going to get is being denied when they are taken out through an abnormal route. Then they are fed formula, and then we had an excellent oration on antibiotic misuse. Rather, you kill all the fronts of your body and then allow the enemies to prosper. Antibiotics does that. You deny them the right to be with their mother. You take them to ICU. Well, you are promoting abnormal microbiota and you're causing dysbiosis. And of course, the outcome is going to be bad. So this is a field where there is a lot of research happening, lot of studies. When I was looking, when Dr. Sajid told me to give this talk, I was looking at the literature. There is no end of to the number of literature. So probably I will just summarize it here. All the things that we knew previously are still holding good, but now coming with more and more strong evidence. Maternal lifestyle do matter. It is the micronutrients, not the macronutrient, not the protein. Of course, I'm not saying protein is a is a subject anyway. We will not be able to cover in a short period, but then concentrate more not on the macronutrients, on the micronutrients if you want better outcome. And try to keep the BMI low. Kerala is the capital of diabetes. Kerala is the capital of obesity, or whatever, or rather India, I should say. And so these are issues that we have when we adopt to another set, a lifestyle that is meant for a different set of genes. Our genes are different. So we have lean body with excess body fat. So these are problems, and then so obviously your BMI will be different. So BMI is a parameter that is now increasingly being looked at. And of course the comorbidity, that is coming as part of the parcel, because you have obesity, you have diabetes, you have hypertension, they come as a package. So all the things that we knew previously are now being substantiated again. Few words about the antenatal steroids. Well, we all know all the fetuses, what is the WHO recommendation, what is the Government of India recommendation, NNF recommendation, all society recommendations, all fetuses between 24 and 34 weeks of gestation at risk of preterm delivery within the next 7 days, they have to receive antenatal steroids. And benefits are profound. We know there is no the controversy regarding this. We have proven it time and again. It's a global phenomenon all over the world, whether from India, whether from US, whether from Australia, wherever you check, there is profound reduction in the short-term morbidity like respiratory distress, the neonatal death per se, intraventricular hemorrhage, neurodevelopmental sequelae, and all these things. But we also know that if you are not able to complete the course of steroids, incomplete dose also is very good. Actually, it is also effective, pointing to probably the dose that we give may not be required. So this is something that has been recently being pointed out in some newer researchers last year from University of Cincinnati. Now, what about giving steroids after 34 weeks, or rather after 33 weeks? The so-called, they don't, even though 35, 36 weeks, we call them preterms by classic definition. They are not preterm. They don't have any preterm physiology. They are actually late preterm babies. And do you give steroids to them? Can I ask, if I may ask humbly, can I request for a show of hands, how many of you in your centers give steroids, antenatal steroids to late preterm delivery? Like some numbers. Well, we have post the ABS trial, the antenatal late preterm corticosteroid trial, which looked at all the outcomes. And then I am going to tell you the long-term outcome in the last year's meta-analysis as well. So we found that definitely the incidence of respiratory distress comes down. But mind you, this is what you're talking about in general. But the incidence of respiratory distress requiring mechanical ventilation is no different. Which means this is one of those transient tachypneas you can even manage with your CPAP. That is what you're going to reduce by giving this steroid. You are going to increase the incidence of neonatal hypoglycemia, especially in hidden diabetes and all that, because it is gone. Maybe after 10 years we will say every mother is gestational diabetes, otherwise, unless proved otherwise. Those days are not far. Take it from me. After 10 years, I challenge you, that will be the norm. So, like, you are going to create hypoglycemia to these babies by giving steroids. RDS, mechanical ventilation incident, they are all similar in both the groups. Now, long-term effects. What is you think it's a small intervention that we said it's a life-saving intervention. Just following the footstep of the title of the previous orator, Professor Ranjan Pejawar, good, bad and ugly. There is an ugly side to steroids as well. Of course, in the preterm category, below 34 weeks, it is the medicine to give. It's the good guy. But later, if you give in the late preterm period, and then you follow up these babies at 10 years, 15 years. There's a large meta-analysis published last year. If you look at the outcome of, the number is too huge, so you can't ignore this. Even though very few centers are India, you can't ignore this outcome. And it very clearly says that more number of late preterm pregnancies, when they receive steroids, these are the children who land up with slight scholastic defects or higher risk of investigation for neurocognitive disorders, even though generally they are okay. But what about the term category? You give it for 37 weeks, 38 weeks, the early term category, or 39, 40 weeks, the term category. Well, there is definite higher risk of mental and behavioral disorders. So it is playing with steroids probably is not the way to go, or just to get away. Probably in a state where the medico-legal issues are too many, if you want to reduce the incidence of respiratory distress, steroids may be one way, but you are playing with something higher. Now the concept in perinatology is less is more. Certain things you use it as a blanket, you use it for select category below 34 weeks. There you get benefits. So to summarize, steroids, definitely evidence is very strong to use between 24 and 34 weeks. Between 34 and 36 weeks, absolutely there is no benefit. You may have some reduction in respiratory distress, but hypoglycemia is a risk, and mechanical ventilation, this is not statistically significant. Term category, respiratory distress will come down if you give, but then low academic abilities and scholarship performance, all these are gone. So this is with a double-digit NNT. Those of you are familiar with this concept of number needed to treat, anything with double-digit NNT, they are significant interventions, double or single-digit significant interventions. So probably giving antenatal steroids above 33 weeks and 6 days is not a good idea. It should be tailored, customized to the specific case if at all it requires. Which one? I will not spend much time on this. Of course, WHO has recommended dexamethasone in resource-limited settings in countries where the complex salt of betamethasone acetate phosphate is not available. Like in India, we don't have that salt. Dexamethasone should be given. Betamethasone as phosphate, which is the salt available in India, is a poor substitute because it has shorter half-life. It is not equivalent to the betamethasone that is being tried in trials. Hydrocortisone is a new kit that is being tried to get both the effect, because we know steroids reduces neuronal growth and delays maturation. That's why all those effects we see. So hydrocortisone, can you get over that? That's again an area of research. And then repeat courses not of much use. The next intervention, antenatal magnesium sulfate. Again, I will not waste time looking at the time allotted. I will not waste much time on this. Well, we now know that even though initially it started like when mothers were treated with eclampsia, they were given magnesium sulfate, and then later on analysis they found that the incidence of cerebral palsy was much less if a mother received magnesium sulfate and the delivery was in the preterm category. The incidence of cerebral palsy was much less, which meant that magnesium sulfate. That's how the whole concept came. Then there was a large study, BEAM trial in US, following which the same authors did the meta-analysis, the first of the meta-analysis that is to follow. So there is now enough evidence to say that magnesium sulfate reduces the rate of cerebral palsy significantly in preterm labor. WHO now recommends it. What is the problem? The center which gives it should have facility for tertiary care for the mother, in the sense that magnesium sulfate is not so safe a drug, but I am sure that our obstetric colleagues would have given even in other ways also. So this is one drug. A good candidate for neuroprotection. Dose, all of you know, 4 gram loading in the first hour, followed by 1 gram per hour up to 24 hours, whichever is earlier. And the best benefits are before 32 weeks. The other, I will skip all these. Now, we have ensured the good lifestyle for the mother. We have given corticosteroids. We have given magnesium sulfate. At the time of how much time do I have? I will wind up accordingly. 5 minutes, okay. All right. So anyway, the baby is out. And when the baby is out, how do we manage cord? When is the right time to clamp the cord? Well, we just remember some physiology. In the fetus, the left ventricle, which is the key organ required to sustain life, left ventricle gets its preload from the placenta. The moment cord is clamped, the preload has to come from the lungs, aerated lung. So if baby is not breathing properly, there is no blood coming from the lungs, and you are clamped. So preload comes down. So obviously cardiac failure ensures. So physiology, cord clamping is basically clamping the cord once lung is well aerated. So that is why we have the concept of early and delayed cord clamping. Early cord clamping, when there is no guarantee this would have happened. Early cord clamping is, by definition, is before 30 seconds. After 30 seconds is delayed cord clamping, but then WHO recommendation is for delaying for 1 to 2 minutes. Now we can do it for preterms also. Now for babies who are depressed at birth, we can't take this chance because resuscitation takes precedence. So can we milk the cord instead? This was tried, large study all over the world. Our center was also part of it. We got a letter from the principal investigator, Anup Kataria, saying, please stop the study below 28 weeks because extreme preterm babies associated with adverse outcomes like intraventricular hemorrhage. So not to be done. There is a concept of physiology cord clamping where you wait after the baby is born until baby cries to clamp cord, and then there is some basis for that, and then even if the baby is depressed at birth, now we have machines like LiveStart which will resuscitate the baby with the intact cord. Probably that is the way to get the best of both the worlds. Zero separation at birth. Well, this is one intervention, very low cost and probably very effective intervention, which has lot of science behind it. You actually avoid all the stressful stimuli, even the vitamin K, if you go by the definition in the first hour. Deliver the baby onto the mother's abdomen, then assess whether baby requires resuscitation. If required, if you can delay, otherwise clamp the cord. If you are not delaying, just let the baby be with the mother. Well, in addition to the cord clamping, the message is delay cord clamping for at least 1 to 2 minutes if possible, unless baby is depressed at birth. There are various other interventions which are of research. I would just skip all these, like targeting tidal volumes, using non-invasive positive pressure ventilation in delivery room, etc. What is the future for us? Well, future is precision medicine. The branch that has come in oncology is coming into perinatology, neonatology also. I'll just explain this concept. You have a disease, you treat it with a plan, a strategy. Whereas in precision neonatology, you subdivide them. The same disease, but you give 4 different treatments to them based on the input that you get from microbiota, from the genetic genomics, proteomics, etc., etc. So the same baby, a 32 weeks baby with RDS gets different treatment. Now, can we take it into a science? Well, that is where artificial intelligence comes in. And now with the various emerging, interesting data that is available, probably it is very much feasible to do precision neonatology and precision perinatology. I realize my time is up, so I will just wind up with just a message about how we do things. These babies are surviving probably despite us, not because of us. Because iatrogenesis is a genuine problem in the modern day ICUs. We do more than what is required and we forget the basics. And this is creating problem. 60% of the low birth weight babies have been known to have iatrogenic problems. So the concept is, the last message, less is more. The less you do, better it is, but sticking to your basics. I will stop here for lack of time. I'm not sure if there is a forum for discussion. I would like to have some discussion. Thank you.
Yes, sir, there is a forum for discussion is open now. We have 5 minutes for that.
There's a question that has come from the audience, Dr. Manoj. Is it justified to administer antenatal steroids in a planned late preterm birth in a mother who has uncontrolled blood sugars to reduce RDS?
Well, there are 2 aspects I understand to that question. One, giving antenatal steroids a late preterm. Secondly, when mother is diabetic. Well, if it is a preterm delivery, there is enough evidence and there is a WHO recommendation. I am always quoting WHO because the source limiter setting, that is what will stand good in any medico-legal thing. But leave aside that. WHO recommendations have their own pitfalls. There is scientific evidence that below 33 weeks, even if the mother is diabetic, antenatal corticosteroid should be administered and the blood sugar titrated accordingly. However, in the late preterm category, it is not justifiable. The only contraindication for not giving steroids before 33 weeks is frank maternal chorioamnionitis, which anyway we know is even otherwise implicated in the later development of periventricular leukomalacia and things like that. But otherwise, diabetes, mother on insulin, these are not. You have to have a titration plan for and monitoring and titration plan for glucose. But you need to give that because we need the baby to have better outcome.
Thank you, sir. Any more questions? Thank you, sir, for the excellent presentation. So for me, 3 points I as a take-home message. One is we always forget about the physical activity and proper nutrition. That was an eye-opener. Second thing, regarding the late preterm, if it is to choose between TTN and hypoglycemia, TTN as the name indicates it is transient. So I will choose TTN over hypoglycemia. So no steroid in late preterm. And thirdly, we should not, as per WHO, it is dexamethasone. This the betamethasone available in our setup cannot be replaced with dexamethasone. That are the 3 points. One question to
Having said that, any steroid is better than no steroid at all. So like that is the thing. But then the problem is the betamethasone phosphate, the only form that is available in our country, has a shorter half-life. So people are even tried in our country. There are some trials right now going on giving this at the dexamethasone dosage, 6 mg per kg 12th hourly, because just to counteract. But they are all under this thing. We have something that is very well proven. Having said all this, betamethasone, the complex salt may have a edge. But don't worry about all that. Give some steroids at least.
Sir, one question, sir. You talked about 24 to 34 weeks. What about steroid for less than 24 weeks? Can you just explain a bit?
Now we have periviable babies surviving. If you look at the scientific evidence and hypothesize, definitely it will be useful. We don't have studies to prove that they are useful. That's all. What I mean, whatever recommendations I given are based on scientific evidence. But there is no reason to doubt that a delivery happening before 24 weeks, mother should not receive steroids. Even I am sure all of us do give. But then studies have not come out. Probably it will come soon.
So thank you, Dr. Manoj. That was a very insightful talk. I mean, I think you set the tone for the future as well. And I think artificial intelligence and individualized care is something that we need to think about in newborn care. Thank you so much. And I'd like to thank the organizers for calling me over for moderating this session. Thank you very much.
Ladies and gentlemen. All the organizers for giving me an opportunity.
Thank you. Thank you so much for it.
Sir, please be on the stage. Ladies and gentlemen, let's acknowledge the brilliance we just witnessed now. In our speaker's presentation, their expertise illuminated the hall, leaving us all inspired and enlightened. Thank you, sir, for your outstanding lecture. Thank you so much.
Thank you, thank you.
So I invite Dr. Sajid Hashim to give away the memento. Our senior consultant and head, Department of Pediatrics and Neonatology, Cherian Institute of Medical Science. Thank you, sir. Next, I would request Dr. V.C. Manoj to give the mementos to the moderators. Thank you, sir. Thank you all.
Now we have one more session and then we break for lunch. The next topic is torsion in gynecology, present concepts. To chair the session, I invite Dr. Sadi M.S., Professor, Department of Obstetrics and Gynecology, Government Medical College, Kottayam, and Dr. Nisha S., Consultant in Reproductive Medicine, Mother Hospital, Kottayam. For the talk, I invite Dr. Sushant Y.S., Consultant Gynecologist, Laparoscopic and V-Node Surgeon, Mother Hospital, Kottayam. He's also a visiting gynec surgeon at the LLM Hospital, Kottayam, St. Mary's Hospital, Mandargad. He did his MBBS and MD in Obstetrics and Gynecology from JIPMA. He also holds a DNB. He has been performing several laparoscopic surgeries for more than 10 years and specially trained and proficient in vaginal natural orifice transluminal endoscopic surgery. He has been a faculty at multiple state and national conferences. You might also want to check out his YouTube channel, Kottayam Laparoscopy and Notes, which contains a diverse collection of gynecological surgeries. Over to you, sir.
Thank you for that introduction. Good afternoon, everybody. Thank you to Dr. Cherian Institute for giving me this opportunity for presenting a lab topic in this Perinatology conference. I'll get on with it as I know everybody is hungry. So today's talk is about torsion. Torsion is partial or complete rotation of an organ with ischemia. Unfortunately, women are more prone to it, and the pelvic organs generally bear the brunt. Now, in torsion, we should remember about the mass effect. Generally, torsion does not occur unless there is a mass. It can be a fibroid, it can be an ovarian cyst, or it can be a tube. Without a mass, generally, torsion does not occur. Now, these are some of the conditions which result in torsion, which I'll be covering in detail. The pathogenesis, it happens when the ovary twists over its supports. Ovary, as you know, is a mobile organ. As the ovary undergoes torsion, it also involves the tubes. Hence, it is called adnexal torsion. When torsion occurs, there is impedance of venous outflow. So there is congestion, hemorrhage. Because of the pressure effect, it causes impedance of arterial inflow. And this soon results in necrosis and non-viability of tissues. What we should remember is that this entire process generally takes around 24 to 36 hours. So even if you do an intervention one day after the onset of symptoms, the ovary may still be salvageable. Theoretically, adnexal torsion is more common on the right side because of these factors, but in my experience, you see it equally distributed in both right and left sides. Risk factors, as I said before, mass effect. There should be presence of an ovarian cyst more than 5 centimeter is what predisposes an ovary to torsion. The cyst may need to be just 3 centimeter in size. Any surgical treatment may predispose to torsion. Pregnancy is a risk factor, 10 to 22% of cases, and also it occurs in late first trimester and early second trimester. Fertility treatment, it enlarges the ovaries and hence predisposes to torsion. Premenstrual girls have long IP ligaments, hence are susceptible to it. Then tubal sterilization. What happens is that once we cut the tubes, the distal segment becomes more mobile and it becomes capable of 360 degrees torsion. And generally, hydrosalpinx is more common after sterilization, and hydrosalpinx per se also predisposes to torsion. Torsioned ovarian cysts are generally benign, but malignant tumors can also twist. Now, clinical features, there is acute onset of lower abdominal pain, nausea and vomiting, low-grade fever. On examination, there will be tachycardia, tenderness in lower abdomen, tender palpable mass in lower abdomen. In my experience, what I have seen is that the symptoms generally start in the morning, maybe due to the tossing and turning in the night. The pain starts around 8 o'clock in the morning. By 10 o'clock, it becomes unbearable. Then the patient goes to the hospital. The assessment takes around 3 to 4 hours, blood investigation, scan. So by around 2 o'clock, the diagnosis is confirmed. Then it takes another 2 hours for the parents, the husband, the patient to digest the fact that it is torsion and it requires surgery. And then she gets referred to a hospital for managing the torsion. So generally the patient comes to you at night, around 7 o'clock, 8 o'clock. That is the usual time when the patients come to us. This is almost 90% of my patients come like that. And then they will end up requiring surgery. And torsion surgeries are generally not easy. They are difficult. And if by 8 o'clock, by 10 o'clock, the patient will get ready. So generally I postpone the surgeries to next day morning because the gynecologist will be tired. You will not have an adequate staff. Anesthetist will be tired. So such cases better to do in the morning when everybody is fresh. Investigations, you should do a TCDC to rule out septicemia. Do a CA 125 because in case there is a mass, you should avoid surprises. Do pre-op investigations, chest X-ray, ECG, and serum AMH also. If it is a young girl, a young lady, a married woman who does not have children, a baseline AMH will help you later. If there is a mass, diagnosis is straightforward. Otherwise, you should do a scan. The ovaries generally, you can see that it is edematous. The follicles get pushed to the periphery. This is called what is known as the string of pearls appearance. The appearance is very characteristic. If you see it, you will not forget it. Then vascularity may be absent, may be present because there may be still some circulation in the ovary. And whirlpool sign, because of the twisted vessels, the appearance will be that of a whirlpool. That is very characteristic. If you see it, that means there is generally torsion. But you should remember that the confirmation of diagnosis is by visualization during surgery. The preferred mode of surgery is laparoscopy. If you do not have a laparoscopy setup in your hospital, or if you have a laparoscopy setup but no experienced surgeon, then you can go for laparotomy. The ideal procedure is a detorsion with ovarian cystectomy with oophoropexy. The thing which we should remember is that a toast ovary should be considered potentially viable, as ovarian necrosis is quite rare. The vast majority of toast ovaries can and should be salvaged. Now, what exactly is necrosis? A gelatinous or poorly formed mass which falls apart on manipulation. You touch the ovary, it comes off in your hand, full of blood clots. Then there is no point in preserving that ovary. You should remove it. In case of suspicion of malignancy, you should remove the ovary and the tube. Now, a few things about detorsion. Detorsion is the preferred surgery of choice. Avoid going and removing an ovary immediately. Don't go by appearances. Even an ovary which looks very bad initially can regain function after detorsion. When we were PGs, we saw a lot of torsion cases, but I don't remember a single case where the ovaries were conserved. And even now, it is actually very disheartening when we see patients who come with an ovary removed because of torsion. And they generally be young girls. They may end up with infertility issues. They may land in endometriosis. So it's very difficult to give them a child once they lose one ovary. So as much as possible, preserve the ovary. The advantages are good rate of ovulation after detorsion. AMH levels are much better. And when we were PGs, they used to tell us you should immediately clamp the ovary after detwisting the ovary, because all those necrotic factors and blood clots will go into the circulation, cause thromboembolism. But that is all old concepts. They are all gone. We can detort the ovary, nothing will happen. Now, how do you go about detorsion? First of all, you see the mass. Once you see it, confirm torsion, you untwist it. Now, the next is the most important part. You wait for 15 to 20 minutes. Release the pneumoperitoneum, straighten the patient. You can describe if you want, watch some YouTube, listen to your favorite music, watch some reels if you want. But at the end of 20 minutes, again, inflate the pneumoperitoneum, check it again. Generally, if there is a return of tissue color and vascularity, that means that ovary can be saved. 20 minutes is nothing. It's just a grain of sand in the whole hourglass of life. The anesthetist will not complain. Wait for 20 minutes. It might make a difference to that patient's life. Now, oophoropexy is fixing the ovary to avoid a further episode of torsion. Does it have to be done in every patient? No. When the patient has only one ovary, or the ovary has a long uterovarian ligament, in case of young girls, then it's preferable to do a fixing. Generally, if the ovary is the twisting organ in a young patient, it's better to fix it. If the ovary is taken along during torsion, like a perovarian cyst which undergoes torsion, and taking the ovary along with it, then you need not fix the ovary. How do you fix the ovary? There are two ways. You can just shorten the uterovarian ligament by plication, or you can transfix it to the round ligament. Some hot cross bun technique is there. The thing to remember is that you should use a non-absorbable suture, either a Prolene or a PDS, and it can be done laparoscopically by endosuturing. Now we'll go to a few videos. This was a 35-year-old. She had finished her family, came with severe abdominal pain, as usual, present at night. There was a mass in the adnexa. You can see the twisted mass in the right adnexa. The tube actually looks quite bad, but then we have to untwist it now and see. You can see the normal ovary on the left side. When you untwist the ovary, try not to manipulate the ovary too much. If you hold it, it will tear, it will start bleeding. Remember hockey. I don't know if you have played hockey or not. Just keep two instruments, just manipulate the ovary in between. Don't catch it. Now you can see that I have detorted the ovary. Now look at the tube. The tube is actually much better. What looked very bad initially is now much better. But this patient was 35-year-old, finished her family, so I decided she also was willing to remove the ovary. So we removed the adnexa. This was a torsion hydrosalpinx. This was a chronic torsion. The patient had abdominal pain 1 week back, then it subsided, but she had dull aching pain. Ultrasound showed a mass. We thought it was an ovarian torsion. We did a laparoscopy. You can see that the ovary is actually normal, but when you can see there is something in the pelvis, a blackish mass, plus the pedicle is sort of twisted there. So since the more the time passes from the onset of torsion, the more will be the adhesions to surrounding organs. This was around 1 week, so the adhesions were not very bad. They were inflammatory. You could just peel it off. When the twisting organ is not the ovary, you can actually hold the mass. Holding the mass, releasing the adhesions. Generally, they will be stuck to the POD. You will have to tease it off gently. You can see the mass now. That was actually a hydrosalpinx. You can see the pedicle, which is completely twisted. No point in conserving a hydrosalpinx, so we did a salpingectomy. Such patients always check the other side as well, because if the other side is also, the tube is completely free, then better to do a salpingectomy on the other side as well. This was a 14-year-old. She came from Nedungandam, from the mountains, torsion, again landed up at night, but her symptoms had all subsided by then, so we did it in the morning. You can see the torsion there. You can look at the ovarian color, it's much better, it's white, there is no darkening. So the tissue is viable. So decided to do a cystectomy, draining the cyst. I hope you understand what the pathology is. That is cartilage. This is actually a dermoid cyst. Dermoid cysts and perovarian cysts are very prone to torsion, that you should remember. So cystectomy is completed. So this was a very young girl. And you can see that the ovarian ligament is actually a bit long. So she is at risk for recurrent torsion. Here you can see the length of the ligament. So we did a plication of the ovarian ligament with Proline. She did well. She comes for yearly checkups. Both her ovaries are fine. This was a 15-year-old obese patient, around 88 kgs. She came with torsion. She came around 7 o'clock, so we did it that night itself. It was a very difficult laparoscopy, difficult to put the ports. There's a large adnexal mass. You can see the normal ovary on the left side. Initially, I thought it was a hydrosalpinx, but on the left side, very young girl, no history of previous surgeries. It is unlikely to be a hydrosalpinx. The normal ovary can be seen on the right side. So again, did the untwisting first. You can see the twisted pedicle. It doesn't matter how many twists are there in the pedicle. Even one, you can have a very bad ovary. You may have 4 or 5 twists and the ovary may be absolutely fine. Again, the tissues didn't look very great. This is a slightly longer video. So once you untwist, you can see the tube, which is actually, the initial part is relatively okay. But since I was not sure of the pathology, I decided to remove the entire twisted mass. You can see that tissue is sort of necrosed here, sort of peels away. You can see the other ovary, which is normal. Now you can see that I can peel that cyst off. So this is actually a perovarian cyst. This was the final picture. You can see that the ovary, although it looks black, bluish, the color has improved much better as compared initially. So I preserved the ovary. The patient went home without any issues. She came for review after 2 years, but with irregular cycles, but the scan was absolutely normal. Again, this is a chronic torsion. Again, chronic torsion, the symptoms start, then they subside, either with treatment or without treatment, and then they come with dull aching pain. Again, we found an adnexal mass. Initially, we thought it was a ovarian mass. In this case, the time period was more, some 2 to 3 weeks. So we can see that the adhesions are a bit more organized. That is the appendix, which is stuck there. This one. Okay. And in such cases, you might not be able to peel off all the adhesions. You will have to do some sharp dissection. Again, we were thinking it was the ovary, but you can see the normal ovary below. So this actually turned out to be a hydrosalpinx. The previous hydrosalpinx was stuck to the POD, but this hydrosalpinx was stuck to the anterior cul-de-sac. Again, you can see the pedicle, which is completely gone. Do sharp dissection to release it from the surrounding tissues. It's a bilateral ovarian torsion. Very young lady, 23 or 24, previous 3 cesareans, sterilized. This was the initial picture. You can see that the ovary is twisted, but it is okay. Now, once untwisted, you can see where the ovary is. It is in the right iliac fossa. It is such a mobile ovary. And you can see the ovarian ligament, how long it is. Something must have happened during the sterilization. Now, this patient had severe abdominal pain 2 weeks back. She was admitted in a hospital, gave analgesics, and the pain subsided. So I was checking for the other ovary, couldn't find it. And then we found a whitish mass in the POD. Then realized that the initial pain was due to the left ovarian torsion. This ovary was densely adherent, so it was not an easy task to release it from the POD. That is the ovary after releasing. You can see that, look at that tissue, it is completely saponified, mummified. So there is no point in preserving that ovary, you have to remove it. Since the right ovary was fine, we did a cystectomy. Again, no prices for guessing what is the cyst. Because such a long ovarian ligament, I did a fixation. The ovarian ligament was fixed to the round ligament. This was, again, a 25-year-old. First was a cesarean, done 2 years back, presented with torsion. So we did a laparoscopy. That tissue character initially did not register with me. You can see that angry-looking tissue with the papillary projections. But I thought the ovary was looking very unhealthy, so I decided to remove the ovary itself. It was not an easy task to get the consent from the bystanders because she was so young. Again, you can see the protuberances, papillary protuberances. Again, it didn't strike me even then. It was only when I started removing the mass that I realized that it was a solid tumor and it was friable. By then, spillage had already occurred, so I completed it laparoscopically, just kept pulling the tissue off. It came as a malignancy. They could not find out what malignancy it was because the tissue was all necrosed. We referred her to medical college for chemo, but she succumbed 1 year back. This patient I had done TLH in 2020, previous 3 cesareans. In 22, she presented with severe abdominal pain. It looked like a torsion. This was the picture. You can see the appendix there. And we discussed the follicles being pushed to the periphery, right? So that those are the follicles. You can also see a band here. I don't know whether the torsion occurred because of this band. This was the other ovary, left ovary. So untwisted the ovary. This is the ovary, and this is actually a hydrosalpinx. It was this hydrosalpinx which resulted in the torsion. I had done a salpingectomy for this lady, but then I went and looked back at the initial TLH video. I saw that I had 1 centimeter of tube had been left behind, and that tube had become a hydrosalpinx and resulted in this torsion. This ovary could have been preserved, but she was 53 years old, so she wanted removal. This was the other ovary, again normal, but we didn't want a recurrence. So we removed both ovaries. Isolated fallopian tube torsion is very rare. I'll skip this. Myoma torsion doesn't generally happen. It's a very rare entity, usually seen in pedungulated subserous myomas, which have a stalk. In patients with previous fibroids, which we know is there, the diagnosis is actually a bit more easier. On imaging, there will be loss of vascularity, presence of a twisted pedicle, absence of contrast enhancement, but usually diagnosis is made intraoperatively. This is how a twisted fibroid will look. You can see the stalk which is twisted and the unhealthy looking myoma. The pain can be confused for myoma degeneration. So generally you may keep keeping her on conservative management, but the bowel can get adherent to the necrosed fibroid. It can cause peritonitis, intestinal volvulus. So if you diagnose it, you have to do a surgery, myomectomy or hysterectomy, depending on the patient's choices. Now this was a very interesting case. Patient had a lab myomectomy 4 years back. Then she presented with severe abdominal pain in the casualty. She was found to have an RIF mass. She was advised surgery, but she went off. Again presented after 1 week with severe pain. She went to the surgeons. So they took her up for laparoscopy, and then I was called. This is how it looks. You can see one solid mass there. The consistency is that of a solid mass. That is the stalk. You can see the congestion, the hemorrhage. This is all suggestive of a twisted mass. This was the connection to the peritoneal cavity. You can see the vascular connection there. This patient had 2 to 3 or 4 other masses in the peritoneal cavity. You can see again the discoloration. This was another fibroid adherent to the omentum. You can see the pedicle very clearly. It is attached to the bowel. There is a vessel which is supplying that myoma, and it is twisted. And that is what caused the pain. So we removed all the fibroids, released all the adhesions. You can see the discolored mass. It was difficult to, ideally these masses should be removed by in-bag morcellation, but this happened in 2020, so that time we didn't have an in-bag. You can see the dark fluid inside the fibroid. So we did a normal morcellation. Patient came after 2 months, she was fine, but lost follow-up after that. Now torsion of the uterus, it's exceedingly rare in humans. It's actually more common in animals. I don't know if you have read James Herriot books. He describes torsion of a uterus managed very beautifully in his books. Torsion refers to rotation of the uterus more than 45 degrees. It is more common in the gravid uterus and generally occurs in advanced pregnancy. It's very rare. You might see 1 or 2 cases in your lifetime unless you work in a medical college. The problem with torsion uterus is that there's a high rate of abruption and perinatal complications, and is usually diagnosed on table. I have seen only 1 case in my life. It was a gravida 9, para 8. She had 7 children. It was a twin pregnancy. She came at term with pulmonary edema. We had to take her for section. I was doing the section. Generally, when I do the section, I catch the UV fold, open it, push the bladder down, and then give the incision. But in this case, I could not pick up the UV fold at all. But then I just delivered the babies, took out the uterus, then realized that I had given the incision on the posterior aspect of the uterus. Then I had to twist the uterus to realize that it was normal. But unfortunately, it did not end well. The patient arrested on table. Both the babies were moribund. They both died on the next day. Patient was intubated for a long time. She developed neuronal damage, was bedridden. last I heard of her. So treatment is cesarean followed by uterine detorsion. Generally, you need not have to do a hysterectomy in pregnancy. If the patient survives the initial episode, the long-term sequelae are very rare. This is, as I said before, James Herriot's conservative management of torsion. I'll put it up at the end of the presentation if you get time. Gynecological causes, again, you need to have a mass. It can be a fibroid, it can be a large ovarian tumor. One thing to remember is that congenital uterine anomalies can cause torsion. Because if the cervix is absent, there will be a hematometra that will act as a mass and it will cause a torsion. Clinical symptoms are the same: lower abdominal pain, very difficult to diagnose. Radiology will give you some information. One way to diagnose is if you do a PV, you will not be able to reach the cervix because the vagina will also get twisted along with the uterus. But in premenarcheal girls, you cannot do a PV, so difficult to diagnose. The problem is because the diagnosis is late, by then necrosis would have occurred, and there is a high incidence of hysterectomy and subsequent loss of fertility. If you diagnose it early enough, you can preserve the uterus. So coming to the take-home points, you should remember that torsion is a real risk with any ovarian cyst. When you see a patient with ovarian cyst in your OPD, they'll be worried about rupture, malignancy, increase in size, fertility. But you should tell them that torsion is a real risk and you should get operated for the risk of torsion alone, especially dermoid cysts and parovarian cysts. Those are at very high risk of torsion. And we should remember that torsion is a much more common pathology than we think. Torsion can occur in any age group. Laparoscopic detorsion is the treatment of choice. One thing I forgot to tell is that when you do a detorsion, it's better that a gynecologist do it or be there at the OT. In hospitals where surgeons do it, they may not be very, they may not bother too much about the nuances. They will just take the ovary and leave. But if you're there in the theater, you can tell them that this ovary might be salvageable, just wait for some time. And always, only one thing to remember, a torsed ovary should be considered potentially viable as ovarian necrosis is rare. The vast majority of torsed ovaries can and should be salvaged. Remove the ovaries only if absolutely required. Thank you.
Thank you, Dr. Sushant, for the very interesting session. And it is quite elaborate and descriptive also, and very interesting videos, and how expertly he's managing all the case. I have witnessed live also, he's performing. Very good laparoscopic surgeon. Congratulations on all of this.
Thank you, madam. Thank you so much.
And a very good message that we should try and save the torsed ovary. Actually, till recently, even we used to remove, but we have started doing, and then even if and when we wait for, in our medical college, we don't have laparoscopy during emergencies. We have lap facility only for elective table. So when we do for emergency dilaparotomy, we apply hot mops, warm mops, and wait. And the color slowly changes, and it's very satisfying. And we always should try detorsion and wait and save the ovary. Then, Dr. Nisha, you can ask.
Women in first trimester with torsion ovary, can we do laparoscopic oophorectomy or should we opt for laparotomy?
Women in first trimester, we can do laparoscopy. I have done personally some 2 or 3 cases. The principles are the same. If the ovary can be salvaged, please salvage it. But I think in pregnancy it's better to fix the ovaries because again, the chance of retorsion might be slightly higher. But you need not do a laparotomy. Laparoscopy can be done. It can be done up to 16, 20 weeks if you are comfortable with laparoscopy.
Regarding fixing the ovary, ovarian ligament you plicate. You also said you can plicate it with round ligament. This tube will interfere.
You go under the tube. You take a stitch on the round ligament, go under the tube, and fix it to the ovarian ligament. That way the tube will not be affected.
Okay, fine. Thank you.
Have you seen cases of torsion in a normal ovary? Usually it occurs with masses, no?
Actually, I have seen it in my PG time only once.
It is more common in premenarcheal girls.
Yeah, in young girls it's more common because their tissues are a bit more mobile. The ovary is small, the pedicule will be large, longer. So young girls, you might get a normal ovarian torsion. But always the thing to remember is that we should take it out of our head that see a torsion, you have to remove that ovary. That is not the thing. That is the only thing we have to remember. Preserve the ovaries.
Any more questions? So we can wind up the session now. Thank you, Dr. Shashad.
So please, could you stay on stage? Round of applause for our speaker, whose passion for the subject matter was contagious. Your eloquence and deep depth of knowledge made the topic not only understandable, but truly fascinating. We are grateful for your enlightening talk and those enthralling videos. I request Dr. Farish, Head and Chief Consultant, Minimal Invasive and Laparoscopic Surgery, Dr. K.M. Cherian Institute of Medical Sciences, to hand over the memento to Dr. Sushant Y.S. Thank you, sir. I request Dr. Sushant Y.S. to hand over the mementos to the moderators, Dr. Sati M.S. and Dr. Nisha S. Thank you, sir. Thank you, ma'am.
Now we are breaking for lunch. Lunch is 30 minutes, plus or minus 5, I guess. There are washrooms. If you just step into a hospital, in the entrance itself towards the right, there are washrooms. There's a travel desk near the reception if anyone needs travel assistance. There is also a wash towards the right side. And food counters are open. Right side of the hall, in the front, you have place to wash. As well as Dr. Anu Ivan Koshi, Consultant Gynecologist and Laparoscopic Surgeon, TMM Hospital, Tiruvalla. I also invite the speaker for the topic, Dr. Indu Biyar. She is the lead consultant in obstetrics and gynecology in Wellcare Hospital, Kochi. Dr. Indu Biyar has had a remarkable journey as an OBG obstetrician and gynecologist at Veena Medicity, where she played a crucial role in establishing the department. In 2011, she completed her primary medical degree from Academy of Medical Sciences, in 2001, at Academy of Medical Sciences, Pariyaram, and went on to obtain her MD from Trivandrum Medical College in 2006. Afterward, she worked at Lakshmi Hospital in Ernakulam. Dr. Indu is widely recognized for her exceptional professionalism, individualized care, and compassionate approach. Her areas of specialization revolve around high-risk obstetrics and minimally invasive gynecological surgeries. We welcome you, ma'am.
Good afternoon. And first, I thank the organizing committee for welcoming me for the talk. So my topic is on late onset FGR, fetal growth restriction. And it's a post-lunch session. I don't know how many will enjoy this. First, so definition of fetal growth restriction. The clinical challenge is always like the diagnosis. It's very difficult to diagnose, and if you don't look into it, we will miss it. And it's one of the most common causes of perinatal mortality and morbidity at term, and more than 50% of the unexplained fetal demise, stillbirths, are due to late onset fetal growth restriction. And what is fetal growth restriction? Is the failure of the fetus to attain the genetic potential, and when we diagnose after 32 weeks, in the absence of congenital anomaly, we call it late onset. And it's exclusively an ultrasound diagnosis. So The diagnosis definition according to the ICOG Delphi consensus is abdominal circumference or AC or estimated fetal worth less than third centile, or at least two of the three following, like abdominal circumference or estimated fetal weight less than 10 centile, or AC or EWF crossing two quartile or on growth centile. That is we call crossing centiles. That in two subsequent growth scans, if it is in the first 70th centile, if it comes below the 20th centile, then it's a crossing centile and we have to take it as a late onset fetal growth restriction. And the third one is the cerebral placental ratio is less than 5th centile, or umbilical artery PA more than 95th centile. The daily clinical challenge of late onset fetal growth restriction remains the compelling priorities of minimizing stillbirth. That is our nightmare. And avoiding excessive obstetric intervention and neonatal sequelae of iatrogenic preterm birth, that is less than 37 weeks. Tools for late onset FGR diagnosis and surveillance is very poor comparing to the early onset fetal growth restriction, and it is characterized by mild and more asymptomatic placental lesion. That is, we don't see some specific placental lesions or alteration in oxygen and nutrient diffusion. We will be seeing only small infarcts in the placenta. And there is the association is commonly between they diagnosed with Dopplers, and the association between MCA, that is middle cerebral artery vasodilatation, that is reduction in MCA PA, that is the reaction of the fetus to the hypoxemia, or the alteration of its ratio with uterine artery PA and poorer perinatal outcome, including stillbirth, high risk of cesarean delivery, and increased risk of abnormal neurodevelopment at birth and at 2 years of age. Evaluation of CPR ratio, that is ratios of MCA PA and uterine artery, umbilical artery PA, may improve the prediction of adverse perinatal outcomes in growth restricted fetus. In fetuses with late FGR, it seems that the biophysical profile becomes abnormal only shortly before stillbirth, and therefore it is not useful in determination of monitoring intervals. So BPP is now not in the monitoring sequelae for this FGR. We have to depend upon the Doppler itself. Despite presenting with milder clinical form from early FGR, late FGR is still associated with poor perinatal outcome and longer educational attainment. These near-term fetuses have reduced tolerance to hypoxemia, so more frequent monitoring is required, just as in those with early fetal growth restriction. So the dilemma is always like that. In early FGR, the management is our main challenge, but in late, it's the detection, and it is more common. More than 70% of fetal growth restriction is in late onset, and we diagnose after 32 weeks. But the cringe is like fetus not necessarily very small. Fetus may not be small, but it may be not attaining the fetal genetic potential. So the weight may be normal, but it could be a fetal growth restriction. The spectrum, the Doppler velocimetry, like the difference is there, that mainly we have to depend on the cerebral blood flow redistribution. That is, the fetus reaction to the hypoxemia is what we see in middle cerebral artery. Biophysical profile may be normal or abnormal. Hypertensive disorders, that is, the risk factors may not be there. The mother will be a low risk primary, low risk mother, and we have to anticipate or screen for fetal growth restriction, then only we'll be finding out late FGR. In placental pathology, like less specific placental pathology, mainly altered diffusion we'll see, and perimeter mortality is high, low comparing to the fetal growth, but the morbidity is high if we miss this, especially the unexplained fetal demise. Then maternal vascular hemodynamic status is less marked, and maternal cardiovascular is more in the low early onset FGR. And another entity is how to differentiate between a fetal growth restriction and a small for gestational age baby. See, both will be less than 10th centile of estimated fetal weight, but SGA baby is otherwise healthy and has normal Doppler findings. That is, the baby weight will be between 3rd and 10th centile, but then the Doppler will be normal. But if the weight is less than 3rd centile, we have to take it as fetal growth restriction even if the Doppler findings are normal. there is some evidence that even SGA fetuses with normal Doppler velocimetry might suffer some degree of growth restriction and not identified by standard biophysical profile. So how we are going to monitor? Monitoring is also an ultrasound mode. We don't have any other things to monitor this fetal growth, late onset fetal growth restriction. The mainly is the metacerebral artery PI and the ratios to umbilical artery PI are the most important Doppler parameters in the surveillance of late fetal growth restriction. If the umbilical artery PI is more than 95th percentile, we should monitor at least once or twice in a week, because the deterioration will be very fast, and many studies, like large studies, have showed that fetal growth FGR pregnancies after 34 weeks, the median interval between a low MCA PA and stillbirth was less than 5 days. So twice in a week monitoring is always good. And we should monitor twice weekly Doppler after 34 weeks. Almost 90% of the stillbirths within 1 week of a normal BPP score in the presence of cerebral vasodilatation, suggesting that BPP may have a poor value in determining the frequency of fetal monitoring. For SGA, that is small for gestational age, once in 2 weeks growth assessment is recommended. Along with that, we have to go for an umbilical artery PA and MCA PA monitoring once in 2 weeks. This is for small for gestational age babies. And when you decide to deliver, that steroid prophylaxis, and most of our guidelines recommend corticosteroid prophylaxis if it's before 34 weeks, and RCOG recommends till 35 plus 6 weeks. In our unit, we usually give up to 35 weeks plus 6 weeks. In this maternal intervention, actually, this intervention does not have any role in late onset, but most of the time when we counsel that our mothers that the baby is small, they will ask what we can do. What are the role of maternal interventions? First is always nutritional deficiency. We can say that you take high protein diet and all that, but nutritional deficiency or intervention is proven good in only in baby mothers after bariatric surgery or eating disorders. And smoking cessation, and one of the studies have shown that statins appears to promising, like a pilot study of 38 patients with singleton pregnancies and FGR diagnosed at less than 28 weeks. I told you it's for the early onset FGR. Observed that administration of pravastatin 40 mg improved birth weight compared with no treatment. But the differences was not statistically significant, but some angiogenic improvement was found, but not in the Doppler parameters. Antihypertensive therapy, especially in chronic hypertension, and phosphodiesterase 5 enzyme inhibitors, that is our sildenafil, appeared promising, but large studies showed there is no benefit. And this is the time, like practicing, our role is how to decide and when to deliver. So there is no confusion, like if you diagnose fetal growth restriction and is more than 37 weeks, you should deliver, even if the Doppler parameters are normal. That is less than 3rd percentile for FGR, and Doppler normal, you deliver before 37 weeks and 6 days. In late FGR and uterine artery PI, more than 95th percentile, should deliver between 36 and not later than 37 plus 6 weeks. That is, no other parameters, even if the biophysical profile is normal, everything is normal, the uterine artery PA above 95th percentile, deliver after 36th week. When SG has been identified, that there is no Doppler abnormalities, then the growth percentile is between 3rd and 10th. It's large studies like digital studies also shows that it should be, delivery should be planned between 38 and should not exceed 39 weeks of gestation. And how to deliver, like always, like C-section, obstetric indication is the only indication, and when you have an absent and reversal end diastolic flow, but this is very not commonly seen in late onset, but sometimes after 34th week we detect fetal growth restriction and it is reversal end diastolic flow, then the mode of delivery should be cesarean section. And trial of labor is always indicated, and better to, if the Bishop score is unfavorable, mechanical dilatation followed by PG2 is what we prefer. And intrapartum monitoring, we should offer continuous fetal monitoring. And don't get confused with this. This is a common chart including the early and late. Just concentrate on this. We have after 34 weeks, deliver if there is reverse end-diastolic flow or absent end-diastolic flow if more than 34 weeks. Here is our area of interest, like between 36 and 36 weeks plus 6 weeks, if the uterine artery PA is more than 95th percentile, deliver. If more than 38 weeks, if there is a signs of cerebral redistribution, that is like you have an umbilical artery PA is normal, your MCA PA is more than 5th percentile. But when you compare this ratio, like major cerebral artery CPR ratio is abnormal. So what to do? Initially it was thought like if you have CPR abnormal ratio more than less than 5th percentile, deliver. Now they say that the perinatal outcome is not much related to the only when it is an abnormality in CPR, but we have to deliver by 38 weeks, not later than 38 weeks. And the outcome of prognosis, like we have, like it's an indicator of a long outcome. What is the prognosis? What we can do when we have a fetal growth restricted baby delivered and with the mother. What are the pediatric outcomes? Like short-term morbidity and mortality, immediately our fetal demise, neonatal death and neonatal morbidity are more common in fetal growth restricted babies than in neonates with birth weights that are appropriate for gestation, that is AGA baby. What is the long-term morbidity? FGR may predispose to hypertension, type 2 diabetes mellitus, coronary heart disease and chronic kidney disease in adulthood, which has been attributed to partial resetting of fetal metabolic homeostasis and endocrine system in response to the in utero nutritional deprivation. That is, fetal growth restriction may have long-term diseases like hypertension. The combination of preterm and severe FGR increases the risk of long-term neurodevelopmental abnormalities and impaired cognitive performances. What are the maternal prognosis and outcome? So, increased long-term maternal risk of cardiovascular disease like coronary artery disease, myocardial infarction, coronary revascularization, peripheral arterial disease and transient ischemic attack and stroke. Whether this risk reduction intervention should be recommended because of a history of fetal growth restriction is unclear, but healthy lifestyle changes in patients with traditional risk factors for cardiovascular disease like smoking, overweight, obesity, unhealthy diet and physical inactivity can be beneficial. And what about the future pregnancy? We have a mother who had a previous history of fetal growth restriction, how to counsel from the periconceptional time. There is always a recurrence risk. There is a tendency to repeat SGA births in successive pregnancies. The odds of recurrences increase markedly as the number of previous SGA birth increases. Risk reduction, how we can reduce the risk? There is a general principle in subsequent pregnancy, any potentially treatable causes of suboptimal fetal growth should be addressed, like cessation of smoking, alcohol, chemoprophylaxis and mosquito avoidance in areas where malaria is prevalent, balanced energy or protein supplementation in patients with significant nutritional deficiency. And the other thing is increase in the pregnancy interval, at least 3 years gap between the next pregnancy. Selective low dose aspirin is recommended only in the presence of risk factors for preeclampsia. And how to manage? Management of subsequent pregnancy, accurate dating by early ultrasonography is important to establish gestational age with subsequent intermittent ultrasound examinations to monitor fetal growth. And what is the take-home message? That the universal screening triples the detection rate of fetal growth restriction. And so when we have, usually we all do an ultrasound at 32 weeks, growth scan, but we have to go for a late onset fetal growth screening around 35 to 36 or before 37 weeks. And each unit should have a dedicated monitoring protocol. What we do in our hospital is we'll have a growth scan at 32 weeks and we'll be screening the babies around 35 to 36 that we will be doing, the obstetricians will be doing the ultrasound, and if everything is okay, we'll be continuing it as a long risk. But if we have any suspicion like any Doppler changes or a crossing sendiles, we usually refer to the fetal medicine radiology and do a detailed Doppler scanning. And each practice in obstetrician should develop this basic skill to measure fetal biometry and Doppler so that we can screen our babies and we can take good decision at the right time to prevent the perinatal mortality. Thank you.
Thank you, Dr. Indu, for that crisp and to the point talk. There's a question from the audience. How frequently should we do ultrasound in third trimester in low-risk women so that we don't miss the late onset FGR?
So we should have a growth scan at 32 weeks. That is mandatory. Everybody will be looking at growth scan around 32 to 34 weeks. Ideally, we have to screen after 2 weeks or at least 2 to 3 weeks to screen for there is any crossing days. And the thing is, only the ultrasound, like without Doppler, won't help you. The Doppler screening is mandatory. Like you have to go for an umbilical artery PA and MCI PA, then only we will be detecting the fetal growth restriction. I will recommend actually we will be doing a scan after 3 weeks in our maternity unit and screen this, and if there is a high risk, then we refer to a fetal medicine radiology department.
Thank you. I would suggest as practicing obstetricians, our main thing is to watch out for the late onset FGR, to be suspicious for it.
Good afternoon. Before we jump into this FGR, we should make sure the dates are correct. So 50 years ago when I was doing PG, there was no ultrasound, there was no Doppler. So the dating scan is done how? By doing a PV. 6 weeks patient comes with amenorrhea. That time there is no test, urine pregnancy test kit also is not available. So amenorrhea, vomiting, these are the signs that patient is pregnant. So we used to do PV at 6 weeks and make sure that uterus is corresponding to 6 weeks. And clinically, we assess the patient by doing serial PV till 12 weeks, and after that, seeing the patient, listening to the fetal heart with a fetoscope. There is no Doppler or anything those days. So like that we see. And around 32 weeks, and we see that the baby is not growing well. Clinically, we can assess we used to assess the Liker also. Clinically, we used to make out. And then what we do, we admit these patients and do serial histiols, 24 hours. What we used to do, 24 hours, urine is collected in a big jar, and they kept it, and patient has to stay there. So every day, our boss used to say, okay, you correct 24 hours, and then send it to the lab. So they take 5-6 hours to give you the results. If it is growing nicely, increasing, that means baby is growing. So then you discharge the baby, give them good proteins. There's no ARG9 powder, nothing like that. Just tell them to take and exercise and monitor like that. Like that we used to do. And then there is no cytotech or no Foley's or anything. Then by giving syntocinon, stress tests. So we used to do that stress test by giving syntocinon and see if the fetal heart is going down. That means baby she's having some stress. So we used to do cesareans. So this is what we used to manage. Now it becomes very easy because scan is there, ultrasound, Doppler is there, cerebrovascular supply is there, umbilical artery, everything you are doing now is so easy now to manage. Those days it was so difficult, but still we used to manage. Even then we used to have our cesarean rates only 15 to 16%. Cesarean rates. We used to deliver VBAC also. Sometimes when you so like these patients having FGR, we deliver them only. And then one thing about the inductions, only if the Bishop score you said if it's favorable, then you induce. What about Foley's?
We are doing mechanical induction, sir. If the Bishop score is less than 6, we'll put Foley's and mechanical dilatation. We give around 24 hours, and if it expels after expelling, usually we use PGE2 gel. And misoprostol usually we don't use for SGA and FGR babies.
We found that Foley's is very good, even if the service is not favorable, becomes favorable.
And we can give actually one more day, usually you can give one more day for the ripening also. We'll give time for reinduction and we reinduce after 48 hours.
Thank you so much.
I take this opportunity to thank the organizers for giving us an opportunity. Thank you.
Thank you.
Thank you, ma'am. Please stay on stage. That was a very incredible talk on late onset FGR, touching on all concepts, and I congratulate Dr. Indu for that, and also thank the moderators. I now kindly invite Dr. Madhu Paulos, Chief Interventional Cardiologist, Dr. K.M. Cherian, Institute of Medical Sciences. I kindly invite Dr. Naveen Pillai, Medical Superintendent, Dr. K.M. Cherian, Institute of Medical Sciences, to give away the memento to Dr. Indu. I also request Dr. Indu to give away mementos to moderators, Dr. M.J. Koshi sir and Dr. Anu Ivan Koshi.
Our next topic for the day is antenatal steroids. Are they brain safe? So I invite Dr. Sumita Arun, Head and Assistant Professor, Neonatology, Believers Medical College Hospital, Tiruvalla, and Dr. Deena Thomas, Consultant and Head, Neonatologist, Muthoot Hospital, Korancheri, to chair. I also invite Dr. Naveen Jain, Consultant and Senior Consultant, Neonatology, KIMS Hospital, Trivandrum. He is also a visiting consultant to Sri Chitra Tirunal Institute of Medical Science and Technology, Center for Excellence, Trivandrum, and a guest faculty at Child Development Care, Government of Kerala. He has been the editor for many books, notably Flaherty and Stark's Manual of Neonatal Care. He held several posts at the national level, including National Coordinator for Neurodevelopment, up for the high-risk newborns for NNF annual conventions, National Faculty for Neonatal Ventilation Workshops for more than 15 years at AIMS and PGIMER, and Joint Zonal Director of Advanced Neonatal Restoration Program course of IAP and National Faculty for NNF. He was awarded the National Oration for the Indian Academy of Pediatrics Disability Chapter and the Annual Oration for Masonic Children's Hospital, Coimbatore. Welcome you, sir. Over to you.
Thank you so much. When I heard the description, I was wondering who you are talking about. I don't know where you found all this anyway. Thank you so much. So who all are young obstetricians in this hall and young? Ajay is young, he's as young as me. Why I'm asking is I know it's post-lunch and a very different topic, because we all love antenatal steroids. Is there anybody who is not giving antenatal steroids now? It is the logo of all Cochrane systematic review is antenatal steroids. And so much was the passion to give antenatal steroids when we were residents in PGI. The joke in obstetrics department used to be, if a mother comes in preterm labor, first you take a betamethasone, give her a shot, and then ask her what is your name. They were in a hurry to make sure that something goes in quickly. So it has grown from there, and now we want to give antenatal steroids to very small babies, to late preterms, terms, and just give it because anyways things will be safe. So hopefully I will try and shake up a little bit of what we know about antenatal steroids. This is something we know, that antenatal steroids would cross the placenta, but they are invariably associated with babies who are lower birth weight than those who would not be exposed to antenatal steroids. They have all, preterm, term, late term, everyone has a change in brain development. Any medicine that works does bad things also. So it can, no medicine can work only in one direction. It can alter our HPA axis and set up adult onset syndromes also. So there is, to start with, an effect on every part. And we know something about brain development, but what is very important is by 23-24 weeks we have all the neurons that you want. But those neurons joining together, what is called as synapses, myelination, organization of the brain, that's all that matters. That happens between 24 weeks and goes on till maybe largely till term, and then after that till 8 years of age. So this synapse formation is like networking. If you all have cell phones, but if there is no network, what use is it? There is no use with that cell phone. So there are neurons, but the synapses are distorted, then you're going to have problems. So the antenatal steroids we give are being given at a time when maximum synapses are happening in the brain. Whether it is endogenous steroids produced by what we heard in the last presentation, fetal growth restriction, chorioamnitis, inflammation, or whether it is steroids that you give. These steroids are same as bad, as dangerous as your patients don't like steroids. They are not wrong. Their fear is not wrong. There is a concern. Microglia are the bad guys, the inflammatory cells in the brain, and they are triggered by antenatal steroids and can distort the brain development. Now coming to evidence. This is the biology of it. 2022, last year, there was a very huge systematic review. Every study published under the sun on antenatal steroids for the last 45 years, 47 years was taken in to find out what is the outcome of these babies who received antenatal steroids. 30 studies, 1.25 million children whose development of at least 1 year age was known if they have received antenatal steroids. So what did we find? Extreme preterm birth, single dose antenatal steroids, there is an improvement in brain development. This is despite the damages, because the damages of being preterm, being RDS, being shock, being PDA is so much that if you didn't treat with antenatal steroids, either the baby would die or he would have multiple health issues. But once you start going up, late preterm birth, what happened? Increase in neurocognitive disorders. 25,000 children, consistent increase in neurodevelopment disorders. And term baby who received antenatal steroids, both developmental disorders and mental health disorders, more of behavior disorders, consistently proven. 60,000 children. We're not talking of 2 or 3 people in a study. This is all the studies published so far, and the term study comes from 5 lakh children who have been followed up for this purpose, and consistently, if a term pregnancy received antenatal steroids because you're doing an elective CS, unfortunately, in this whole cohort, 50% of antenatal steroids were given to late preterm or term, not to preterm, because that is the current trend. We want to give it to them. So the first message is there has to be a caution with antenatal steroids when you're talking about late preterm pregnancy and full term pregnancy. A single dose given to very preterm baby, fetus, is okay, it is good. But if you're going to give antenatal steroids to a late preterm or term, you are going to be in trouble. You're creating a baby who may have neurodevelopmental disorders and is going to have mental disorders. I am going to try and zoom this. Let me see here. Yeah. So this is what you can see. If you gave to preterm babies, I don't know, yeah, there's a pointer here. You gave to preterm babies, neurodevelopment favors standard course, single course of antenatal steroid, decreases cerebral palsy, decreases auditory impairment. But if you give it to term or preterm, then there is an increase, favors unexposed fetuses, whether it is mixed group or term group. So if you gave antenatal steroids to a late preterm or term, then the disability rate significantly increases, and we are harming. There is consistent proof from all the evidence that is available. What problems do you see? Virtually everything. See here. You're going to have term pregnancy. Follow the middle line everywhere. Favors no treatment, no antenatal steroids. For what? Developmental disorders of speech and language, scholastic skills, motor function, psychological development, vision and hearing loss, epilepsy, cerebral palsy. All of them are going to be more if a late preterm or term baby is exposed to antenatal steroids. Similar study, single study, but again showing hypoglycemia is more if a late preterm has received antenatal steroids, and clear recommendations that if you are dealing with a late preterm or term pregnancy, do not delay the delivery for the sake of giving antenatal steroids. Don't give tocolysis, don't delay the process, because the harm of antenatal steroids is significant. Term pregnancy, more babies got admitted to ICU if the mother received antenatal steroids, more intubation, decrease in head circumference, and any developmental disorders. This was published in BMJ last year, this year only, and clear messages: do not give. Late preterm, again more low birth weight, more need for resuscitation, more ICU admission, more 5-year development showing cognitive disorders, visual problems and auditory problems, again published in the archives the same year. Teachers reporting, you may say these are all developmental tests and they are all just technical jargon, scientific jargon. Teachers' report showed that when they looked at the babies who were having problems in school and were once preterm, they were more likely to have been exposed to antenatal steroid. This includes preterm and late preterm and term. So this was known well ahead. So this is the infographic given by the British Society, Royal College, which says here, antenatal steroids at term for planned cesarean. This is for parents, what they should be given before they agree. There is evidence that steroids given late in pregnancy may cause low blood sugar in baby after birth. There is less information on long-term effects. Steroids may affect baby's brain development, resulting in decreased milestones and affecting educational achievement. So parents have to be shared this card before a late preterm or term has to be given antenatal steroids. This is the first study, Liggins and Hoey. That one where antenatal steroids are discovered by accident. That cohort was followed up till 30 years age. So they were okay, but they are ones who received between 30 weeks and 34 weeks. And all of them are having reasonable development, no issues. So if you're giving it the right age, it is a good medication. Clear evidence against serial courses. Again, if you give 2 courses rather than 1, decreased birth weight, decreased head circumference. Cerebral palsy is more, almost 5.7 times if you're giving serial courses, again published recently. Can I give to the lower gestations? Because now we are all dealing with 23 and 22 weeks babies also. Yes, there it seems to benefit. When it comes to 23 weeks, you can see right now in our unit there would be at least 4 babies who are 23 weekers. They will benefit by antenatal steroids. When it comes to 22 weeks, disability and death rates are very similar because they're very high already. So currently till survival improves, there may not be magical improvement in 22 weeks. But 23 weeks and upwards, antenatal steroids may be given, upper limit being 34 weeks. Now next 8 or 9 slides would be on the evidence behind this, the biological models to making such sweeping statements before you. So what does it affect? It affects both lung and brain, we know that. So what does it do? This slide may look complicated, it is not. This is a very small animal study with almost 3 animals being studied, but they studied multiple genes. And all those genes on the right side did good to the baby's lung. So there was an improvement in lamellae which produce surfactant, lipid transport, but there was decreased immune response, decreased system development, morphogenesis, branching of alveoli, all this was poorer. So even the lung development didn't universally get better with antenatal steroids. And when it comes to brain development, hippocampus, some things became better, but there were issues. Differentiation of neurons was poorer, neurogenesis was poorer, regulation of development was poorer. So there are genes which are going to be harmed when you look at the firing of cortisol levels in normal babies, pregnancy, the firing of cortisol level and the development of brain that is shown by neuronal growth factors happens at the same time. But if you give antenatal steroids, this will be preponed. And that preponing causes decrease in the total surface area of the brain and the prefrontal cortex, which is your cognition and development. So these things are affected when you give it early. This is the statement which has come last year by Alan Jobe, who is a world authority on antenatal steroids. And he has said, we have probably used the wrong drug for last 48 years. So they have a publication said antenatal steroids, reappraisal of the drug formulation and dose. So we have been using betamethasone, phosphate and acetate, and the reason for using the P version is it was improving the longevity of the antenatal steroids in the pregnancy. The effect was lasting for a long time. Acetate has very short action. But that is the one which is causing harm also. They showed that it is measurable in the baby's brain, the fetal brain, up to 2 weeks after giving one shot. So it will continue to cause harm to the developing brain. Also, the doses we are giving currently 6 milligram of DEXA, or you give 12 milligram of beta, this is presumed to be about 10 times the dose what the baby needs actually. And there are safety concerns. This is looking a busy graph, difficult graph, but just focus that this gray area is the healthy zone at which antenatal steroids should produce cortisol levels in the baby's circulation. When you give 1/4 of it in the animal model, 25% dose, there were peaks which are going very high. So if you give, this is only single dose. When you give one more dose, and at 4 times the dose than in the animal study, they presume that you will end up in getting 10 times the dose of steroids that you want to give. So we do not have more studies with lower doses in human beings, but these studies were done in Indian women, because some of you may have concern that this is animal study, how can we implicate? The Indian volunteer women were there who were non-pregnant, who agreed to this study, and they were volunteers in studying the levels of medications in the circulation after giving antenatal steroids. This is for Sajid and for Nelbis, that will we lose out on lung benefit? No. So again, busy looking graph of PV loops, but the lung efficiency, this is what it's showing, at very low dose of only the beta acetate was producing similar benefits as a combination of much higher doses. So probably you need 1/4 dose is what is being presumed, and only the beta component or DEXA like what we are using now may be probably safer. So clinical trials are en route now to see whether you can manage with 1/4 or 1/3 of the dose, whether you can manage with 1/4 or 1/3 of the dose that we've been giving. Again, looking busy slide, but very easy to follow. The gray bars are half dose and the black bars are the clinical dose, what we currently give. And you can see all these are brain areas, hippocampus and SVZ and all that. You can see that the black ones, if you gave the full clinical dose, the brain damages were more than if you gave half the dose. Half the dose was same as a placebo vehicle in terms of damages. So if you gave half the dose of steroids, probably, I'm not going to make recommendations that you change your practice to half the dose, but probably it is coming soon. So half the doses when they were given, the damages to brain were much lesser. This is the last but one slide. Don't give antenatal steroids hoping that if I give now, even if the mother delivers later, at least I would have protected something. Because the time of delivery of the medication to time of birth has a very important, this one, in balancing the benefit versus risk. This is a Lancet paper which came last month. Again, huge systematic review of more than 1 lakh pregnancies. And they have shown that this green is the one which benefited. If you gave the steroid 1 to 7 days before the birth of the baby, there was decrease in mortality of the baby. In all others, there was no benefit noted. Similarly, in terms of RDS, the baby should not go to ICU and get ventilated. 1 to 7 days, just over 7 days, there was some benefit. But if you went to 14 days, 21 days, between the dose of the medication and delivery, no benefit in mortality, no benefit in distress, but only the damage to brain that you saw in the last slides. We had done a study 2 years back. We had started feeling that more late preterm and term babies were coming with hypoglycemia to the unit. So we spoke to our obstetricians and saying that shouldn't we stop this practice, because the number needed to treat one baby getting to a unit and getting ventilated, 100 mothers should get antenatal steroids if it is late preterm or term. But the number of hypoglycemia was 9. That was the current published review. So we said, should we have 9 hypoglycemic babies getting IV fluids for reducing 1 TTNB actually, not intubation. So the obstetrician said, it's your problem. We are only trying to give antenatal steroids to save your baby. If you say you have no problem, we have no problem. So we had a consensus and we took a study to see what happened after and before we changed the practice. So the green is the one which is not exposed to steroids. You can see the distress, any respiratory morbidity of 16% and 17%, 190 babies late preterm or term. Moderate respiratory distress same, requiring ventilation total together, both of them only 1, just like what the world has seen that this group don't get ventilated very often. Late preterm, slight increase in distress was there, but it was not significant. Term babies, actually there was a decrease in distress in the no antenatal steroid groups. Any hypoglycemia was not different, but symptomatic hypoglycemia requiring IV fluids was different in both the groups. So we have not been using antenatal steroids in late preterm and term pregnancies for last 3 years now, or 2.5 years now. So this is what I will conclude with. Where are we in 2023? Some clear messages. No antenatal steroid to a term mother because she is going to deliver on an elective cesarean section. Remember that British guideline is there with an infographic to parents showing that it is doing harm, and the minute you do steroids, obstetricians are being asked by the parents, do you need to give steroids to my pregnancy? They will find all this guideline if we didn't find it. Late preterm, no. Serial courses, no. Yes, even if you are having 22 weeks pregnancy, beta-methazone combination seems to be unsafe. Whether DEXA is better, we don't know, but doses will have to be looked at. Probably we are using a very high dose, and maybe in the next 1 or 2 years, you would be using half or 1/3 of the dose currently you're using. Do not give just because you want to be safe. Unless the delivery is likely to happen in a week's time, antenatal steroids will not produce mortality benefit or distress decrease, but may harm the brain of the growing fetus. And our own personal practice, we think that we have benefited by stopping antenatal steroids in late preterm and term pregnancies. Thank you for your attention.
Thank you, sir, for an excellent presentation. Dr. Naveen has been a role model from our DM training times, and I thank the organizers for giving me this opportunity. Sir, our gynecologist must have become happy after seeing your slide on beta-methazone acetate and phosphate. So Alan Jab told that they have been giving the wrong drug in US also. So half of us are happy that we don't have that drug here. So coming to the main question, sir, do you find any, in the evidence, is there any difference that between beta-methazone and dexamethasone or neurodevelopmental impairment in the diet?
Most of the studies were including the combination drug of beta-methazone, acetate and phosphate. So they seem to be sure that enough damages was being done by that. Dexamethasone should be safer merely because it is going to have a shorter action. It's a presumed thing. When we were residents, that time we were taught B for brain and D for damage. So we were using beta-methazone in PGI, but obviously not the right salt at that time also. And at that time itself, the British were talking about dexamethasone. They had systematic reviews proving that dexamethasone better, and the Americans were using. India chose dexamethasone for different reasons. One is it was much cheaper. The stability of the drug was more. You could store it and give it to everywhere that you know. And also that it was available easily compared to the beta-methazone. But now it seems that fortunately we picked up the right medication, and so it looks like we are on a safer medication.
Probably we'll get a better answer with the Action 3 trial, which is actually recommending 2 mg of beta-methazone phosphate, the one that we have available in our country. So they are going to use in LMIC country, in which India is also a center. I think so PGI is one of the center, and then one Bhubaneswar hospital is a center. So they'll be using 2 mg, 4 doses. That is just like dexamethasone, 4 doses, 12 hours apart. They'll be using 2 mg of beta-methazone phosphate, vis-a-vis the same dose of dexamethasone that we routinely use. So probably when the results of that trial come out, we'll get a better idea of whether we should go in for beta-methazone phosphate or dexamethasone in India at least. Thank you, sir.
Thank you, sir. Thank you for that talk. It was very clear, sir. Very clearly you're stating that beyond late preterm, 34 weeks, we should stay away from antenatal corticosteroids. And you've put forward your argument, whether it is with a meta-analysis or with a teacher's report or even animal studies. I just have one question from the audience. what is the role of rescue dose steroids and when should it be given after the first dose?
Probably the current practice still talks about giving a rescue dose steroids if the baby is still going to deliver probably less than 34 weeks or maybe even lower gestations. 27, 28, you came in preterm labor, you gave an antenatal steroid, 2 weeks have lapsed, again the mother comes. But if she's getting closer to 32, 33, 34, you must weigh the benefits versus risk, because today 32, 33, 34 would rarely land up in getting ventilated and getting surfactant. So I think going by guideline, 1 dose is still recommended for a baby who may deliver much earlier, but not closer to late preterm.
What is the lowest gestational age, sir, at which you practice antenatal corticosteroids, the lower border?
This recommendation says 22 weeks may not show benefit, but that is because currently both sides are equally bad. 93% of death or disability. But 23 onwards it is beneficial. So we were trying to write up our guidelines for the unit because we wanted to know what to do for these. But currently it is clear that periviable, what we call, may be given antenatal steroids for the benefit it has.
So from 23 weeks you're saying, sir?
Yeah.
And in the late preterm category, is there any situation where you still use antenatal corticosteroids? Or
I
is
think
it a
individual
no-no?
studies are not there, whether if you have gestational diabetes, whether it makes things worse. I'm not sure. I don't think I can answer that.
Thank you, sir. Thank you so much. Thank you to the organizers for giving us this opportunity.
That's right, ma'am. When we were residents, that was what was taught to us, that I said B for brain and D for damage. And at the same time, even the British were talking of dexamethasone being better. And there seems to be now clear evidence that dexamethasone is not associated with brain damage if given at the right gestation and as a single course. There also brain damage is there, what we showed you, but the risk of getting brain damage by being born at 30 weeks without getting antenatal steroids is far more, because the baby would have RDS, shock and all those problems. So the damage there is more by not giving. But at gestations beyond that, surely no, sir.
Thank you. Let's give a round of applause for the wonderful presentation. We appreciate the clarity and depth. Thank you, sir. Now I invite Dr. Sajid Hashim, Head and Senior Consultant, Department of Pediatrics and Neonatology, to give the memento to the speaker.
Please take a good photo. Sajid is my classmate and we haven't had a photo together for a long time.
Yeah, sure, sir. We will. Now I request Dr. Naveen Jain to hand over the mementos to the moderators, Dr. Sumita Arun and Dr. Deena Thomas. Thank you all.
Let's move on to the next talk on strategies to optimize IUI outcome. To chair the session, I call upon Dr. Sharad Devadas, Chief Fertility Consultant and Managing Director, Fertility First IVF Center, Cortical, and Dr. Sisija K, Consultant Reproductive Medicine, Lullaby Fertility Center, Dr. K.M. Cherian Institute of Medical Sciences, Chengannur. I invite Professor Dr. Ajay Kumar for the talk, MD, DNB, Fellowship in Reproductive Medicine, Professor Obstetrics and Gynecology, Fertility Unit Head, Kottayam Medical College. He was the pioneer of the Assisted Reproductive Technology Department at Kottayam Medical College. He is the man behind the first IVF baby at Kottayam Medical College. He is the one who has instilled the thoughts of IVF in the minds of many. A hearty welcome to you, sir.
Good afternoon. I think I'm audible at the back, isn't it? Thank you for the nice words of introduction. After brilliant talk from Naveen, who's my classmate, MBBS classmate, who has been talking about how you sustain a pregnancy or maintain a pregnancy, I'll take you back retrospectively to where we create life. Okay, we start by creating life. Infertility is a loss. It's a loss of a dream. It's a loss of an assumed future. And like every loss, it will be grieved. The management and treatment of infertility is a very important challenge in clinical aspects. According to the recent WHO survey, 17% of couples are infertile. That comes to around 1 in 6 couples presenting with infertility to your clinic. Now the contribution from both the male and the female is equal, 50%. But because of the social stigma associated with male infertility is usually considered as secondary. And unfortunately, because of this, many of the males go undetected and untreated. Fortunately, over the last couple of years, many advances have occurred in the field of assisted reproductive technology, enabling couples to fulfill their needs. And in this ladder of ART, assisted reproductive technologies, the lowest rung is by the intrauterine insemination. I thank the organizers for giving this opportunity for me to share a few slides on the strategies to optimize IUI outcome. As you know, intrauterine insemination is a simple, non-invasive, cost-effective procedure where you bypass the cervix and you transfer enriched semen plasma or semen into the uterine cavity. Now, what is the advantage of IUI? It is less costly, easy to perform, lacks serious complications, requiring minimal lab and equipment needs, and maybe the increased cumulative pregnancy over months. Literature has quoted a cumulative pregnancy rate of around, or success rate of around 70-20% in IUI procedures. My talk will be focusing on how to improve the success in intrauterine insemination. So your management begins at each level: the patient selection and counseling, ovarian stimulation protocol and cycle monitoring, semen processing techniques, the insemination procedure, and finally the luteal phase support. Perhaps the most important is the patient factors. Choosing an ideal couple for IUI is the most important. Age of the female partner and the duration of the infertility period is highly important. So in the female factors, age 35 is considered usually as the cutoff. Studies in the Escher registry which show that if the age is less than 40 years, the pregnancy rate is 12.6 as compared to 7.4 when the age is more than 40. Duration of infertility less than 4 years. Unexplained infertility, mild endometriosis, cervical hostility, and at least one patent tube with a healthy tubo-ovarian relationship. Now, what about about IUI in endometriosis? It's usually done in women with over the 35 years of age, less than 35 years of age, with mild to moderate endometriosis, which has a success rate of 21% in minimal endometriosis and mild 18.9%. And she should have an optimal ovarian reserve. But when there is severe endometriosis, bilateral severe tubal block, or concomitant male factor infertility, or a reduced ovarian reserve, please don't do an IUI. Go straight away for ART. Coming to the male factors, ideally the total sperm count should be more than 5 to 10 million per ml. A study by Dickey which showed that if it's more than 5 to 10, the success rate is 14% compared to 3% when the count is less than 1 million. Moreover, linear motility, sperm motility, rapid linear motility, pregnancy rate is 7.9 when it is less, and 10.4 when it is normal. Also, normal morphology should be present, and DNA fragmentation index should be less than 30%. Now, men with abnormal semen morphology fail to fertilize the oocyte, and those with the damaged DNA will have, the children will have, or they'll go for an early miscarriage. So in a nutshell, good results are obtained when there is unexplained infertility, a cervical factor hostility, an ovulatory infertility, and donor IUI. The next is optimizing a good ovarian response. Usually the first line of drug for induction of ovulation is clomiphene citrate. But if the woman or if the lady has a polycystic ovarian disease, the drug of choice becomes letrozole. Use of gonadotropins for ovulation index has a much higher pregnancy rate as compared to oral ovulogenics. Now, if you look at the next slide, natural cycle, you do an IUI, the chance of pregnancy is 3 to 5%, while if you induce with oral ovulogents like clomiphene citrate or letrozole, 8 to 10%. A combination of oral ovulogin and gonadotropins, 13 to 15%. That's what most of us follow. And if you're going exclusively for a gonadotropin therapy, it is 17 to 20%. So the question is, do all IUI cycles need to be stimulated? Now, what is their aim? The aim is to achieve multifollicular genesis, but there is always a higher risk of multiple pregnancy associated with this. So progressively increase the dose of ovulogens or gonadotropins so that you get 2 to 3 dominant follicles. So the take-home point is that the number of follicles should be 2 to 3 to have a higher chance of pregnancy as compared to monofollicular genesis. Now, a rare problem that you encounter in patients when they are on ovulation induction is premature LH surge. It's the premature release of, rise of LH and concomitant rise in the serum progesterone levels. Now, in stimulated IUI cycles, the incidence is around 20%, and this results in premature ovulation of an immature oocyte. So there's no pregnancy. So what should you do for this? Should you downregulate the cycle or not? Now, there is no evidence that downregulation of an IUI cycle with GnRH agonist or antagonist results in an improved outcome in IUI. But a case that needs to be converted to an IVF or an ARH procedure, you can downregulate so as to prevent a premature LH surge. Now, how do you time your ovulation trigger? When will you give the HCG for triggering the ovulation? So follicular monitoring is done routinely to assess follicular growth, and once follicular maturity is assessed, reached by your structural parameters and Doppler parameters, you trigger the ovulation using your triggers. So once dominance is confirmed, ovulation trigger is administered, and you do the IUI after 34 to 36 hours. Now, to reduce the stress to the patient and to improve our working conditions, IUI is usually scheduled in the morning hours as couples are less stressed and men have a better chance of getting sample. So when do you give the HCG? In an oral ovulogen stimulated cycle, for example, clomiphene citrate, you give HCG when the follicle reaches 20 to 22 millimeters. If it's clomiphene citrate with gonadotropins, 18 to 20 millimeters. A gonadotropin exclusive stimulated cycle, 17 to 18 millimeters. And you can do a Doppler to see if there is any evidence of follicular rupture or impending ovulation. You can see the picture over here. If there is perifollicular fluid, blood flow more than 3/4, it suggests that it's good and ovulation can occur and you may get a better result. Now, what drug will you give to induce ovulation? Usually what we give is the human chorionic gonadotropins. Now, in the market, you have both recombinant as well as urinary HCG, but the ovulation rates are similar with both drugs. Definitely the cost is different, but So urinary is as good as recombinant time. GnRH was also previously used for triggering ovulation, but that results in a defective luteal phase. So it's not routinely used. Now, once you've triggered ovulation, you want to know how the endometrium is. Is the endometrium receptive for the egg? I mean, for the embryo, or the embryo. So if the ET is more than endometrial thickness is more than 7 millimeter with good vascularity and texture, it results in a higher pregnancy rate. Sometimes the endometrium is thin, so you have to give estrogen to enhance the growth of the endometrium. So estrogen should be supplemented only after the follicles rupture or follicles reach dominance, because if you give it earlier, it can affect follicular growth and also cause arrest of the follicles. So this is a 3D Doppler for evaluating endometrial as well as subendometrial neovascularization. The endometrium is highly vascularized, so you can always expect a better result. Now, the semen parameters. Duration of absence before an IUI is 2 to 3 days. There should be proper sample collection. There should be privacy in collecting the sample, and it should be a clean and total collection. Semen, timing of preparation, after semen collection to semen wash, maximum 30 minutes. Sperm wash to IUI time immediately. And so the net from semen collection to IUI should be less than 90 minutes or 1.5 hours. Two methods are commonly used, the swim-up technique as well as the density gradient technique. This depends upon the semen parameters. So if the male has a near normal or a normal semen parameter, you can go for the swim-up technique. But if there is a oligoasthenoteratospermia, you have to go for density gradient. When will you inseminate? IUI is usually done at 34 to 36 hours after ovulation trigger. Do you do double IUI? Now, a second IUI is usually done if there are multiple follicles and if all the follicles have not ruptured at the time of first IUI. And also, if there is a severe male factor infertility, it's preferable that you go for a second IUI. And second IUI is usually performed 12 to 24 hours after the first IUI. Now, this is a study published in the Assisted Reproductive Journal to see if the timing is correct and based on ovulation. And they have found that postponing IUI until the follicles rupture or ovulation is a higher pregnancy rate. So you do the IUI after you confirm ovulation. What about double IUI and timing of single IUI post-ovulation gives a better clinical pregnancy rate when compared to a single pre-ovulatory IUI in a male factor, non-male factor infertility. So it's always better that you confirm ovulation before you go for an IUI. Now, about the IUI procedure, the cannula that is used, okay, the type of, you have both rigid as well as flexible cannula. It's always preferable to use a soft, firm cannula because it produces less injury to the endometrium. Now, pregnancy rate per cycle after soft catheter is 15.3%, while when you use a hard or rigid catheter, it is 7%. US guided, ultrasound guided or blind, studies have shown that there is no clinical advantage when you use ultrasound, except that in difficult inoculation or negotiation, ultrasound will be helpful. Now, this is an interesting study to see if the routine use of ultrasound for intrauterine insemination improves the pregnancy out. They reached the conclusion that in this study, they found that it reduces the frequency of difficult IUI, blood staining, as well as thereby increasing the improving the pregnancy rate. A word about technical intricacy. IUI success increases when you use practically when you use abdominal ultrasound with a partially filled urinary bladder, because a partially filled urinary bladder straightens the uterocervical canal. Never touch the fundus of the uterus because it will stimulate cramping of the uterus. And slow injection over 60 seconds of 0.3 to 0.5 ml of processed semen. If it's more than 0.5 ml, it may come back. or it might go into the peritoneal cavity. So it should be a slow injection and a slow withdrawal of the catheter over 60 seconds. So you've done your procedure. What next? Bed rest. Usually we advise bed rest after immediately after an IUI. A randomized study on the effect of 10 minutes of bed rest after intrauterine insemination found that it has a positive effect or a beneficial effect on the pregnancy rate. And perhaps the most important is luteal phase support. Progesterone should be given to increase the pregnancy rate in multifollicular genesis and stimulated cycles. You can use either the oral route or the vaginal route. But this study has shown that, it increases the vaginal progesterone increases the chance of pregnancy. But women receiving clomiphene citrate to induce ovulation do not seem to benefit much from the treatment of luteal phase with progesterones. So when do you stop IUI? When do you refer the patient to another center or a higher ART procedures? So when the number of pregnancy rates beyond 4 cycles are found to be less. So studies recommend that you go for advanced assisted reproductive techniques once you have done 3 to 4 cycles of IUI. So to conclude, the whole thing what I've said is this there in this chart. So you start with a couple selection, a young age, less period of infertility, unexplained infertility, mild endometriosis, cervical factors, female factors. Male factors may be with erectile dysfunction or psychosexual disorders with a count more than 5 to 10 million, progressive linear motility and normal morphology. That's a couple selection. Ovulation induction, go for oral ovulogins and gonadotropins. Follicular monitoring with ultrasound so that you get 2 to 3 follicles for your IUI. And you trigger it either with recombinant HCG or a urinary HCG, depending with whatever is available for you. Semen preparation, abstinence of 2 to 3 days, total collection and process either by a density gradient or swim-up technique depending upon the count. Swim-up for normospermia, density grading for patients with oligoasthenoteratospermia. Insemination, 36 hours after trigger, confirm ovulation. Soft catheter, non-touch technique, slow insemination, ultrasound guided, partially filled bladder, rest for 10 minutes. And finally, luteal phase support with progesterone, oral or vaginal. So to conclude, evidence suggests that intrauterine insemination is a reliable first line of infertility treatment. Optimization and evaluation of the ovarian response with a good lab support to get a functionally competent spermatozoa are the essential requirements for success in IUI. No matter how good you are, you can always get better, and that's the exciting part. Thank you for your patience here.
Thank you, Ajay sir. As always, very simple and crisp presentation by you, sir. The chair is open for discussion now. Any questions? Sir, I just have one doubt. Where do you place tubal evaluation for in the optimization of IUI?
Good question, very good question. Now, the teaching is that you need to have at least one tube, fallopian tube, with a good tubo-ovarian relation before you go for an IUI. But you have so many patients who are stressed, maybe with psychosexual disorders, vaginismus or erectile dysfunction. In such patients, you may need not do a tubal assessment. You can try an IUI directly. Because especially with patients with vaginismus, they're already stressed about invasive procedure. So ideally, you need to assess the tubes.
Sir has elaborated the crucial points in optimizing an IUI cycle, but certain doubts. In case of, usually we do not go for an agonist trigger in an IUI cycle, but in case of a 4 sized follicles, 4 or more sized follicles, what is your policy?
See, you can always, if they are ready, you can always go convert the cycle to an ART cycle. But I don't know, in my setup, most of the patients will not be ready for a IVF immediately. I think you can still try with 4 cycles. explain to them the chance of multiple pregnancy.
Yeah, the chance of hyper response
Yeah,
can
yes,
be
yes.
controlled,
Yes.
but there is always a chance for multiple
Yes,
pregnancy.
there's always a problem.
So now the ART law is into prevalence. And what is the guidance for setting up an IUI clinic either as a standalone unit or associated with a hospital?
You need to get the license for an ART, for an IUI. If you're going to if your hospital is going to conduct an IUI, you have to get the license from the district unit. The license should be there before. Otherwise, you are not able to. You're not supposed to do a IUI. So license is a must.
Sir, since you mentioned about DFI for male, is it routinely done
No.
before you
No,
IUI?
it's not
No,
done.
right.
It's not done.
If someone has
It's
done it, we'll just
Yeah,
take
that's
it
it.
as a-
It is not done. Only some centers do DFI. So it's not routinely done. Tubes, preferably the best method is laparoscopy. But always, you cannot do laparoscopy for all your patients. So well done clear ultrasound might be equally effective. You know if the tubes are free. You know if the ovaries are not adherent, and even you can do a saline sonography to see how the tubes are moving. So that is enough to assess your tube-ovarian relationship.
Sir, an optimal total motile fraction for an IUI sample should be at least above 5.
Yeah.
But on the day of collection, you meet that the TMF is less than 5. What would be your approach?
See, that is a common practical point. Usually, at the time of day of collection, he may not be able to collect the whole sample. The first part of the sample might have been lost. He is stressed. So, if it is less than 5, you can always counsel them for. Maybe you can do the IUI, but you have to tell them that the chance of success is less. So, counseling the patient is most important. And if it is less than 1, there's no point in doing an IUI. You have to go for an ART.
So, is an outside collection permissible either for a semen analysis or an IUI? What is the clarification?
Now, the problem with an outside sample is that we have had difficult times like that. Patient will bring their sample, but it might not be her partner's sample. It will be somebody else's sample. So that is a big problem in ART. Even some centers ask for marriage certificate before you go for an IVF or any procedure, because people are very smart. Okay, they are very, very smart. So if it is if the patient is not able to collect the sample from your institute or the room which you allocate, and if they want to bring it from outside, you have to get a declaration from them that this is the husband's or the partner's sample. The declaration is a must, just to save your skin.
Sir, we have a question from the audience. Men with increased liquefaction, what is the response to IUI and pregnancy rate?
Right. Liquefaction, if it's increased when when you're doing a centrifuge, that point is that difficulty is gone, because you're doing a centrifugation of the sample. So liquefaction is not a big problem when you do IUI.
Yeah. We shall wind up the session. Thank you, sir, for this elaborative talk.
Thank you very much.
Thank you, sir. Sir, you didn't just deliver a lecture, he crafted an experience. We are privileged to have been a part of this intellectual journey. Thank you for your outstanding talk. I call upon Dr. Sridevi N.S. Ma'am, Professor Emeritus, Obstetrics and Gynecology, Pushpagiri Medical College, to hand over the memento to Dr. Ajay Kumar as a token of appreciation. Request Professor Dr. Ajay Kumar to hand over the mementos to Dr. Sharad Devdas and Dr. Sisija K. Thank you, sir. We have an announcement. The Indian Medical Association Kerala State Branch Annual State Conference UPCON 2023 is being organized for the first time at Pathanamthitta district by Thiruvalla IMA branch. The 66th Annual State Conference of IMA Kerala State is happening at Vijayan Convention Center, Thiruvalla on November 11th and 12th. That is a second Saturday and Sunday. 2 days of excellent CME and organizational matters along with the grand gala banquet on Saturday night will be held at Kerala's largest convention center. The Joint Secretary of the Organizing Committee is here with us today. Request all of you to register for the IMA State Conference. Thank you.
Our next topic for the day is antenatal care revisited. To chair the session, I call upon Dr. Salim C. Eepin, HOD and Consultant Gynecologist, TMM Hospital, Thiruvalla, as well as Dr. Suja Mary Mani, Associate Professor, Pushpagiri Medical College, Thiruvalla. Our scheduled speaker for the day, Dr. Patsy Verghese, HOD and Professor, Believers Church Medical College, could not join us today due to some unavoidable circumstances. However, we are fortunate to have Dr. Anjali M., Associate Professor in OB/GYN, Believers Church Medical College Hospital, Thiruvalla. She did her MBBS from Pariyaram Medical College, Chengannur, MS and DGO from Government Medical College, Trivandrum, Senior Residency in Government Medical College, Kottayam. She has over 11 years of working experience, including a stint in Caritas, Kottayam. She has various publications to her credit, including those dealing with gestational trophoblastic neoplasia and PPROA. Welcome, ma'am.
So good afternoon, everyone. The talk for today is Antenatal Care Revisited, in which I will be presenting the inverted pyramid of antenatal care. So in 1929, Sir Arthur Greenwood, Minister of Health in UK then, issued a memorandum and structured the now 80-year-old pyramid of antenatal care. The picture is visible here. We can see that there is a first visit at 12 weeks. Then majority of the visits occur in the late third trimester of pregnancy. So there is a clustering of visits in the late third trimester of pregnancy. What happens is that we wait for complications to occur, and after the complications are occurred, we manage them. That is the basis for this pyramid of antenatal care. So we have witnessed many scientific advances in the last 20 years, and now we are practicing an era of preventive medicine. So many pregnancy complications now can be predicted as early as 12 weeks of gestation. That is the importance of our 11 to 14 weeks. Routinely, we use this 11 to 14 weeks to screen for aneuploidies. But now we have found out that with the combination of several biophysical, biochemical markers and a combination of demographic variables, we can assign patient-specific risk for each patient, and we can design a definitive disease-specific approach for each pregnancy. We are able to screen for many things at the 11 to 14 weeks gestation. These include screening for aneuploidies, structural defects. Earlier we used to go in for anomaly scan at 18 to 20 weeks. Now we have found out that we can detect more than 50% of structural anomalies between our 11 to 14 weeks. We can screen for preeclampsia, gestational diabetes mellitus. We can predict fetal growth restriction. We can predict preterm labor and miscarriage and even fetal death. So in 2011, Professor Nikolaitz, which can be considered as the father of fetal medicine, he inverted the pyramid of antenatal care. Here we can see that in the new pyramid, in the 12 weeks, that is considered as an obstetric triage, where you categorize the pregnancy into a low-risk group and a high-risk group. In the low-risk group, we can see that we have to call the patient back at 20 weeks of gestation, again categorize the pregnancy, and she requires very few visits when you compare to a high-risk group. If you categorize a patient into a high-risk group, she is taken into a specialty clinic and she requires frequent visits. So we can save many of our resources by categorizing the pregnancy into a low-risk group and into a high-risk group. And the importance is that we can do it at a very early gestational age instead of waiting till the late third trimester. This is done at the 12 weeks of gestation. This is known as the first trimester triage. And this is also known as the one-stop clinic for assessment of risk of pregnancy, where the high-risk patients are sent to the specialty clinic and the low-risk patient is called back at 20 weeks. So here we can see that this 12 weeks of gestation is considered as a window of opportunity. And these are the things you can do in the 12 weeks of gestation. That is, you can go in for your NT scan along with your nasal bone, then ductus venosus Doppler, then flow across the tricuspid valve, then you assess your double marker, you screen for structural anomalies, you can reconfirm the gestational age, screen for preeclampsia and IUGR, you confirm it is a multiple pregnancy or a singleton pregnancy, and if it is a multiple pregnancy, you confirm the chronicity of the pregnancy also. Then you can also screen for preterm labor in this pregnancy. So first, going on to the screening of aneuploidies, this has already been dealt with in the morning session. A talk was there by Dr. Anita, who covered all this earlier. So just going through it quickly, we'll do a combined screening between 11 weeks and 13 weeks, 6 days. We'll take into account the maternal age and history. We do an NT scan, look for the presence of the nasal bone. You will do a ductus venosus Doppler and look at the A wave. Then blood flow is assessed across the tricuspid valve. You rule out tricuspid regurgitation. And you do the biochemical markers, the double markers, that is Papa A and free beta HCG. We have a detection rate of around 90% for trisomy 21 and 95% for trisomy 18 and 13. False positive rate is around 5%. This is all covered in the morning session. So this is a picture showing a fetus with normal NT compared to an increased NT in a Down syndrome baby. And this is a Doppler picture of ductus venosus, where we can see normal A wave in the first picture and reversal of A wave in the second picture. And the flow across the tricuspid valve is also seen. Tricuspid regurgitation is shown in the second picture. The reverse A wave is seen other than in trisomy 21. It is also associated with congenital cardiac defects of the baby, and it can be used as a predictor of fetal death also. That is, it can be used as a predictor of miscarriage also. Then another thing which was discussed already was cell-free DNA assessment, or NIPT, that is non-invasive prenatal testing, which is usually done at 9 to 10 weeks. It is a very useful screening test which has a detection rate of 99% and a false positive rate of only 0.1%. So after screening in the high-risk group, in the high-risk group is when the ratio is more than 1:250, then you offer invasive testing for the lady. That is chorionic villus sampling or amniocentesis. In the low-risk group, when the cutoff is less than 1:1000, you call her back for an anomaly scan at 20 weeks. In the intermediate risk, that is between 1:250 and 1:1000, you offer her NIPT. Then going on to fetal structural anomalies. I told you between the 11 weeks and 14 weeks, that is at around 12 weeks, you can diagnose around 50% of fetal structural anomalies. Anomalies usually detected are anencephaly, A-lobar holoprosencephaly, body stalk anomaly, omphaloceal, gastroschisis, megacystis, phocomelia, amelia, and early hydrops. Then first trimester undetectable anomalies. These anomalies cannot be detected in the first trimester since the zoological manifestations appear in the late second trimester or in the third trimester of pregnancy. These include the microcephaly, hypoplasia of the cerebellum of Veremis, agenesis of the corpus callosum, many renal anomalies, bowel obstruction, and pulmonary sequestration. Now, NT greater than 95th centile is also associated with congenital hydrocephalus. It can be associated with hypoplasia of the lung, atresia and stenosis of the small intestine. It can be associated with diaphragmatic anomalies and osteodystrophies. So when you see an increased NT, always look out for these anomalies. And increased NT is associated with congenital heart diseases of the baby, structural anomalies of the baby. There is a 3% risk of congenital heart disease if the NT is between 3.5 and 4.5 millimeter, and this rises to 30% when the NT is more than 6.5 millimeter. And tricuspid regurgitation and reversal of A wave is also associated with cardiac anomalies. So a combination of 3 markers gives you a 52% detection rate for congenital heart disease of the baby. So when you have an abnormal NT, but your karyotyping or your microassay is normal, don't think that the baby is completely normal. The baby requires a fetal echo at 20 weeks of gestation to rule out congenital heart diseases. That is the importance of increased NT with a normal microassay analysis. Then going on to open neural tube defects, this can be ruled out by assessing the fourth ventricle. The intracranial translucency will be obliterated in open neural tube defects. And the size of brainstem is increased in your ultrasonogram. We have to look at a ratio, that is a measurement from the sphenoid to the floor of the fourth ventricle to the floor of the fourth ventricle to the inner edge of the occipital bone. That is shown in the picture. And if the ratio is greater than 95th centile, there is more chance for open neural tube defects. These are the few pictures of fetal structural anomalies diagnosed at around 12 weeks. First picture is anencephaly, then you have exophthalmos, then the third picture is that of a body stalk anomaly. Next, we go on to screening of preeclampsia and fetal growth restriction. As we all know, maternal demographic variables are very, very important in prediction of preeclampsia, which includes elevated mean artery pressure in the late first trimester, age greater than 30 years, nulliparity, previously existing hypertension, autoimmune diseases like SLE, APLA, then last childbirth greater than 10 years, history of assisted reproduction, family history of preeclampsia, etc. But all these factors can contribute to about detection of 50% cases of preeclampsia. When you combine it with other biochemical markers, the detection can be increased very much. Biochemical markers which we use is PAPA-A and placental growth factor. And the biophysical marker which can be used is a uterine artery Doppler. The uterine artery Doppler, it is increased, the PI is increased more than 1.5 mole in cases of preeclampsia. So the combined detection rate is around 95% for early onset preeclampsia, but it is only 46% for late onset preeclampsia. The false positivity rate is around 11%. And the intervention which we can do if we detect that this lady is going to develop preeclampsia is that as per the ASPER trial, you can start her on low dose aspirin. And this has to be started before 16 weeks of gestation. And she has to be referred to a high-risk clinic. Regular BP checkup has to be done. She has to undergo follow-up Doppler at 22 to 24 weeks of gestation. She requires a growth scan and Doppler at 28 to 30 weeks of gestation. So this is again prediction of preeclampsia, where you take into consideration of maternal demographic variables, then PAPA-A and placental growth factor, your uterine artery PI is increased, mean artery pressure is increased, and according to all this, a combined screening is done, and you can detect 95% of cases of early onset preeclampsia. Now, something about screening for SGA without preeclampsia. There also you get your increased MAP, increased uterine artery Doppler, but the biochemical markers used is decreased PAPA-A, decreased free beta HCG, and decreased placental growth factor. Now, combining all this, you have a detection rate of 75%. This is a picture showing normal uterine artery Doppler and diastolic nodes where they have an impedance to the uterine artery Doppler. This is a marker for both SGA and preeclampsia. Now, going on to screening for gestational diabetes mellitus, this we all know. We all do a 75-gram GTT at first trimester. This can be done at 12 weeks, and if that is abnormal, you can start her on medical nutrition therapy or metformin. The biochemical markers you can add is adiponectin and sex hormone binding globulin, but this is not of much importance. We solely rely on a 75-gram GTT. And even if this screening is normal, you have to re-screen for gestational diabetes mellitus at 24 to 28 weeks. Now, screening for miscarriage and stillbirth. We have already told that increased NT can be a marker for a failing intrauterine pregnancy. And there can be associated low PAPA-A. A-wave reversal can be seen in ductus venosus. You cannot provide much intervention for miscarriage. For stillbirth, frequent monitoring can be done and more frequent scans can be done. Now, prediction of preterm labor. Preterm labor, previous history of a preterm delivery is the single most risk factor for predicting preterm labor in this pregnancy. Then previous history of second trimester losses, previous history of PPRM, all are important. Now, you can go and measure the cervical length along with your NT scan. If the cervical length is less than 2.5 centimeter, you can look for progressive shortening of the cervical length in the serial scans. And the interventions which we can do is, we can start her on micronized progesterone, which can be given orally or vaginally, and you can offer her an encirclase where it is indicated. This is a picture showing measurement of the cervical length, transvaginal sonogram. Lastly, we go on to the screening of large for gestational age. We can see the chubby baby sleeping comfortably in the weighing machine. The weight of the baby is 6 kg. So can we predict such babies? So previous history of a large for gestational age baby, obesity, gestational diabetes mellitus is a demographic variable. Then increased NT, increased free beta HCG and PAPA-A, decreased adiponectin. A combination can detect around 40% of cases of LGA. And as we said, this 12-week scan can be used for confirming the gestational age, confirming whether it is a multiple gestation. If it is a multiple gestation, you can look out for lambda sign in the dichorionic twin and T sign in case of a monochorionic twin. Then if it is a low risk pregnancy, you call her back at 20 weeks of gestation, again recategorize and place a fetal echo if there is a history of a congenital heart disease in the parent or in a sibling, or if there is an exposure to teratogen, or the patient has overt diabetes mellitus, or the patient had an increased NT or a reversal of A wave or a tricuspid regurgitation, but the microassay analysis was normal. Then go ahead with a fetal echo to rule out structural anomalies. Now, something about the newer concept in the inverted pyramid of antenatal care. Here we see that there is a third pyramid which is added. To the second pyramid, what they have done is they have added 2 boxes of non-communicable diseases, one at the top and one at the bottom. So the basis is that the basis of all the pregnancy complication is a defective placentation. And this defective placentation occurs due to defective implantation. So we have to go further back. We have to look at the relationship between the embryo and the endometrium. So what Professor Jubik in 2017 proposed that if there is a healthy lady, if there is a healthy mother, if the health of the lady is good before pregnancy, then that leads to a good placentation and implantation, and that leads to a very good pregnancy. So optimizing the health of the lady before she gets pregnant, that is very important. That is adequate weight management, the optimizing the blood pressure, the blood sugar, stopping substance abuse, and spacing of pregnancies may improve your pregnancy outcome. And Professor Moshe and Dr. Nicolaides proposed the 3-floor model of antenatal care. So we have 3 floors, the first floor, the second floor, and the third floor. In the first floor refers to the pre-pregnancy period, where you optimize the health of the non-pregnant lady. The second floor refers to the inverted pyramid of antenatal care. And the third floor is a postnatal period, where you refer the lady to a group of doctors, including endocrinologists, your cardiologists, dietitians, all these cardiologists, dietitians, all these people, they modify the lifestyle of the patient and they prevent the development of non-communicable diseases. So this is your first floor, that is optimizing the health of the non-pregnant lady. Then only she gets pregnant. The second floor, where you have the OSCAR, that is a one-stop clinic for assessment of risk, where you do your demographic variable assessment, your NT scan, NB, then mean artery blood pressure, then biochemical markers. You score the pregnancy, divide it into high risk and low risk, and optimize the pregnancy, leading to a healthy pregnancy, healthy mother, and healthy baby. And finally, we have the third floor, where you refer the patient to endocrinologist, nephrologist, cardiologist, dietitian, alter the lifestyle of the patient, and prevent the development of non-communicable disease, and prevent the non-communicable disease spread to the next generation. That is all. Thank you.
Thank you, Dr. Anjali, for the wonderful presentation. Now, you give more importance to the pre-pregnancy period and the early pregnancy, and also for the postnatal period, where you have to follow up the patients with more complications. That's a present day time, and you have to prevent more complications and also follow up the patients. Any queries?
It was an excellent presentation. You have literally revisited the antenatal care, and I think one of the conditions which escape that inversion is the late onset FGR.
Both the late onset FGR and the late onset preeclampsia is actually, this is a fallacy behind inverting the antenatal care. You cannot actually predict late onset preeclampsia and FGR when you invert this antenatal care. All your biochemical markers, all your screening tools can predict only the early onset preeclampsia and FGR. It is very insensitive to detect the late onset preeclampsia. It has a detection rate of less than 40%.
Any queries? Anything to add, madam?
Thank you, ma'am. Please stay on stage. That was an outstanding lecture, including all newer concepts in antenatal care. I now invite Dr. Rekha, Senior Consultant in OBG, Dr. K.M. Cherian, Institute of Medical Sciences, to give away the memento to Dr. Anjali. I also request Dr. Anjali to give away the mementos to Dr. Suja Mary Mani and Dr. Salim C. Epen.
Thank you all. We move on to the next topic, placenta accreta spectrum, obstetrician's nightmare. To chair the topic, I invite Dr. Susan Matthew, Professor and HOD, Pushpagiri Medical College, Tiruvalla, and Dr. Veena Sam Matthews, Senior Consultant, Gynecologist, Sanjeevani Multispecialty Hospital, Tiruvalla. I invite Professor Dr. M.A. Kunjamma, Professor and HOD, Obstetrics and Gynecology, Believers Medical College Hospital, Tiruvalla. She has more than 30 years of experience. She was previously the head of the Department of OB-GYN of Kottayam Medical College. She was a secretary of the Indian Academy of Indian Reproduction for 10 years and also was the president of Kerala Federation of Obs and Gynae. She was also a member of Federation of Obs and Gynae, Society of India, UPSC Advisory Board. Welcome you, ma'am. Over to you.
Thank you. A very good evening to one and all. At the very outset, let me thank the organizers for giving me this opportunity to present this topic, and that too at the end of the day's program, and an entirely different topic from what we had till now. Anyway, you have to bear with me this obstetrician's nightmare. See, you all know that hemorrhage is the most common cause or the first cause of maternal mortality in Kerala, and not only in Kerala, all over the world it is like that. And again, this placenta accreta spectrum or morbidly adherent placenta, that's a major contributor to this hemorrhage, leading on to maternal morbidity and even maternal mortality. See, the seniors will agree that only since these 2 decades we have been getting this type of patients to manage. And earlier we didn't have such cases. And probably because we know that because of the increase in primary cesarean section rate, the chance of morbidly adherent placenta is also on the increase. The placenta accreta spectrum, earlier it was termed as morbidly adherent placenta or abnormally invasive placenta. But now it is termed as placenta accreta spectrum, which includes 3 types. Placenta accreta or creta, where the placental anchoring villi is attached to the myometrium. Second is placenta increta, where the anchoring villi penetrate into the myometrium. And percreta is anchoring villi penetrate through the myometrium to the uterine serosa or adjacent organs. The last picture is not clear. You can see the normal attachment, accreta, increta, and percreta. The FIGO has now classified PAS or placenta accreta spectrum into 3 grades with 3 subtypes for grade 3. Grade 1 is abnormally adherent placenta or creta. Grade 2 is abnormally invasive placenta or increta. Grade 3 is abnormally invasive placenta, that is percreta, which is subdivided into 3A, where the invasion is limited to the uterine serosa, and 3B is where invasion extends to urinary bladder, and 3C is invasion of other pelvic tissue or organs. Just look into the prevalence. It was only 0.003% in the year 1950. Now it has been increased to 0.17%, the range being 0.01 to 1.1% in 2019. That much difference has occurred. And the incidence, placenta accreta is more, 63%. Next comes placenta percreta, which is 22%, and increta is 15%. So before going to the topic, I will present 3 cases, not imaginary, real cases, which we managed at Kottayam Medical College. The first case was a 3rd graviда with history of 1 cesarean section and 1 abortion. She presented at 24 weeks with leaking per vaginum. She delivered the fetus within no time, but placenta was not expelled, and tried to remove from below. That procedure stopped due to torrential bleeding. You just think of the management, and we will discuss it at the end of the session. And the second case, again, a 32-year-old 2nd gravida with history of 1 LSCS 2 years back, and now with 20 weeks pregnancy with complaints of acute onset hematuria. She was referred from a local hospital with hypotension. And the third case is a second grade again. Previous cesarean at 36 weeks referred as a case of morbidly adherent placenta. You just plan the management, and I'll ask you later. See, you have to remember some basic facts. Why it is a nightmare? Because PIS is a killer if not properly managed. That's why we discuss this management. And almost always it occurs when placenta is on the previous LSCS card. So if the number of previous cesareans are more, the chance of placenta being accreta is also more. And think of the reason for the complications. Why? Because the problem is the uncontrollable bleeding that may occur while trying to separate the bladder from the extruded placenta. And therefore, we have to seek for steps to control blood flow to lower segment and bladder base. That will help the control of bleeding. A bit into the pathogenesis, why this placenta accreta spectrum develops, how? Uterine remodeling during postoperative scar formation, that is primarily cesarean birth, and pre-existing uterine pathologies like rupture, dehiscence, or radiations. And there what happens, failure of normal decidualization and loss of the normal subdecidual myometrium and or their replacement by scar tissue. That brings the anchoring villi close to the surface of the uterus at scar tissue. And because of this endovascular invasion, the vessels will be dilated, and that will be on the surface of the scar. And coming to the clinical features, the risk factors, the most important is placenta previa after a previous cesarean delivery. See, looking at the incidence, you can see on the right side, this is without placenta previa. Sorry, this is with placenta previa. Previous cesarean, this is with placenta previa alone, without previous cesarean. This is following cesarean section. The incidence is more over here. After first cesarean, it is 3%. Following second cesarean, it is 11%. Third, 40, fourth, 61, and fifth or greater, it is 67%. So as the number of cesarean increases, the chance of placenta previa also increases. And we should think of the other risk factors as well, because though it is not that common, but whenever you get such cases, you have to think of the other factors as well. Like myomectomy, if you have entered the cavity, you have to suspect it. And hysteroscopic removal of intrauterine adhesions is also a predisposing factor. Corneal resection of ectopic pregnancy, dilatation and curettage, endometrial ablation, and maternal age greater than 35 and multiparity. History of pelvic irradiation, manual removal of placenta, postpartum endometritis, infertility procedures, mainly transfer of cryopreserved embryos. That's also a risk factor. And just see the clinical presentation. How do they come? PIS is first suspected on obstetric ultrasound. And the first clinical manifestation may be profuse life-threatening hemorrhage during manual removal of placenta. And sudden severe pelvic or suprapelvic abdominal pain, mainly seen in placenta percreta, is about 41%. And in 25% vaginal bleeding is seen, and pain and bleeding in 7%. Preterm labor or PPROM, as in the first case, that's about 7%. Hematuria is about 31%, as in the second case. So you think of the consequences, why it's a nightmare. Because this placenta, if accreta spectrum, if not properly managed, it can lead on to major hemorrhage. That will lead to disseminated intravascular coagulation, adult respiratory distress syndrome, and renal failure. Of course, unplanned surgery and even death can occur. And of course, it may end up in peripartum hysterectomy and other morbidities like transfusion, bladder injury, urinary tract damage, genitourinary fistula, excuse me, bowel damage, thrombotic event, wound infection, hemorrhagic shock, cardiac arrest, and renal failure. All these things we have seen. And increased maternal morbidity with more severe disease and even mortality. And for the neonate, preterm birth and SG infants, because we have to terminate the pregnancy a little early. And of course, we have to have a placental histology as a proof of it. So how do you diagnose it? How do you screen for it? So we have discussed all the risk factors. So a woman with any of such risk factor, she should have a thorough trans-abdominal and vaginal ultrasound evaluation of the interface between placenta and myometrium between 18 and 24 weeks. At that gestational age, with 90% accuracy, we can diagnose adherent placenta or placenta accreta spectrum. The findings could be, we can identify placental lacunae and disruption of the interface between the bladder wall, uterine cirrhosis, that is called the bladder line. So the bladder line will be disrupted. And color Doppler, if you add, that will show you turbulent or chaotic lacunar flow and or bridging vessel, which are confirmatory findings. These are some of the pictures where you can see the vessels, tortuous vessels over there. And this is the bladder. It's almost reaching, almost entering the bladder. That bladder line, that is disrupted. So you can see an abnormal area here where there is no sonolucent space here, but here it is there. So this is a partial placenta accreta or even percreta. The vessels, between the bladder, that bladder line is obscured by this vessel, so you can see with Doppler. And again, same picture. So this is normal, this sort of lacunae is normal, whereas in case of placenta accreta spectrum, there will be tortuous lacunae like this, tortuous vessels like that. That way we can differentiate it from. And in the placental histology, there's placenta, the villi is extending to the myometrium. That's a proof that it is placenta accreta spectrum. So as a recap, the ultrasound findings will give you multiple placental lacunae, disruption of bladder line, loss of the clear zone, myometrial thinning, abnormal vascularity, abnormal uterine contour, exophytic mass, and color Doppler will also help. And MRI, what is the role of it? It's not a must that we should have it, but it's always that will help you to confirm your diagnosis to a certain, even if it is not there, with a carefully performed ultrasound, you can diagnose. Of course, as Anjali has pointed out, the first trimester ultrasound, even before 9 weeks, that will give you an information which has not been included in that talk. With that ultrasound, we can diagnose cesarean scar pregnancy, whether it is exogenous or endogenous. And you should think that, you should know that this cesarean scar pregnancy is actually a foreigner. Placenta accreta spectrum is a continuum of cesarean scar pregnancy. So if you can diagnose before 9 weeks, identify the location and identify the type of cesarean scar pregnancy, and if you can manage at that time properly, the incidence of placenta accreta spectrum can be reduced to a certain extent. So coming to the management, during the prenatal period, what we have to do is, if she is anemic, that has to be corrected. And since we are planning for early delivery, antenatal corticosteroids will be given, but of course up to 34 weeks, not up to 37 or 36 weeks. Thanks to that doctor, because I used to tell them, but they don't agree with that because of the cognitive problem and all. Anyway, anti-D immunoglobulin should be given if there is vaginal bleeding. And you have to avoid pervaginal examination and ask the patient to avoid rigorous physical activity. Of course, we have to hospitalize these patients earlier. So how do you prepare her for delivery? We have to explain the problems to the patient as well as their relatives, and informed consent should be taken. And we have to involve a multidisciplinary team. We need urologist, surgeon, radiologist on call, and all the people should be there. And we have to schedule the delivery. It should not be an emergency as far as possible. And of course, we have to get ready for, or to be expert enough to do a cesarean hysterectomy within no time. And of course, we have to have intravenous access and monitoring. Thromboprophylaxis, embolic prophylaxis should be given. What we usually do is that blood and blood products should be arranged. We arrange 4 units of FFP PRBs, that is blood, and platelets. And of course, we should be ready or knowing the massive hemorrhage protocol. In case needed, we have to follow that. And we earlier discussed that the major problem is hemorrhage, which causes all the high morbidity and mortality. So then we have to look into how we can reduce the excess bleeding during the operation or intra blood loss. There are several techniques described in the Western literature, like balloon catheter in both internal iliac arteries, or uterine artery embolization, or resuscitative endovascular balloon occlusion of aorta, REBOR. But the problem is all these techniques require high-level imaging equipment and hybrid operation theater, and there should be a radiologist on call. And moreover, all these techniques are not safe. They have their own complications. So I really thank Dr. Piley for inventing this novel approach for control of bleeding during surgery. Using this Piley's aorta occlusion clamp. See, this is the clamp. This is a simple straight instrument, looks like Alice forceps, but with blunt tips which overlap and act as a guard to prevent the vessel slipping out of the clamp. And it has got a long ratchet and also smooth blades with 2 mm gap on closure. We use this aorta clamp at the lower end of aorta to control the blood flow. Initially, when we started this procedure, we used to occlude both common iliac vessels, but later we changed over to this. The same type of clamps are used for occluding the infundibulopelvic ligament. Remember that clamping of aorta is time sensitive. Somebody should announce every 5 minutes the time lapse so that aortic occlusion for minimum possible duration. Blood and blood products, as I mentioned earlier, we do cesarean electively at 36 weeks, not later than that. Informed consent, urologist should be ready. And after consent, post for cesarean at 36 weeks. And if diagnosis is percreta, start under epidural, do cystoscopy, put bilateral ureteric catheters and Foley catheter. Initially, we ourselves used to do ureteric catheter, but later, for me, I found that it's not needed if you are very careful. So we don't do this catheterization unless it is really indicated. And then give general anesthesia. Always the abdominal incision should be vertical because we may have to extend it above umbilicus. And on the uterus also you do classical cesarean if it is placenta percreta. First you deliver the fetus by putting a classical incision on the uterus, but you should not reach the placental edge. And on the cut edges you have to put green amylase forceps to control bleeding. Some suggest closure with the sutures to control bleeding. But the important thing is you should not disturb placenta and should not give oxytocin also, that will cause contraction. And you have to put double-sided absorbent mat. Exteriorize the uterus, put special clamp at the lower end of aorta after pulling it up with the Babcock forceps. And you have to note the time. Then assess the degree of placental invasion. If placenta is extruded from uterus over a wide area, then you have to plan for hysterectomy in situ. That is the best option. There the technique is clamp and cut pedicles up to the level of the uterine arteries on both sides. Stop when the placenta is encountered. Then remove the infundibulopelvic ligament clamps and carefully separate the bladder from surface of placenta up to its lower edge, taking care to avoid injury to bladder. And the ureteric catheters will help you to exclude urinary injury. And then put the clamps across the isthmus below the placenta and do subtotal. But here you have to remember that you have to go below the lower limit of the placenta. You should not leave any part of placenta to the remaining cervix. So ensure vessels at bladder base and vagina, and then estimate the blood loss. Double check stumps and close abdomen. Replace blood loss. And this is a picture of this placenta extruding out. And that's why we have done a hysterectomy, peripartal hysterectomy for this patient. Conservative management also is described, like placenta left in situ and delayed interval hysterectomy, but complications are more like severe vaginal bleeding, sepsis, death, of course. So we are not usually going for that. And the other conservative procedures like placental resection, The candidates are people with focal accreta or frontal or posterior placenta accreta, where we follow this triple pre-procedure. That is placental localization, pelvic devascularization, placental non-separation, and myometrial expression. That is triple. I'm not going to detail it. But another thing is, suppose you are in the periphery, if caught unaware, what you do. So if you are expert enough to proceed with all these things, you can. Otherwise, you just deliver the fetus without disturbing the placenta through that incision and close the uterus. Either you call for an expert to your center, or you send that person to another center, and a re-laparotomy can be done. Such things have occurred. So this is in Kottayam. In the initial 12 years back, we started this procedure. And the initial 1 year, we have done all over Kerala more than 100 cases, and there was no maternal death, and the blood transfusion requirement also came down considerably. This I have done in Kottayam. See, before getting this clamps, 20 cases, 11.5 units of blood transfusion was required. But with the use of this common iliac, at that time it was common iliacs were occluded. That's why it is called common iliac artery clamp. 11 cases we did, and the average blood requirement was only 1.5 units. This is real. So to conclude, it's a serious condition for which a strategy should be established in every department. That's very, very important, even in periphery. And at present, it is possible to tackle without much mortality and morbidity using this aorta clamp. And picking up the cases early and planning a strategy on an individual basis is crucial. That's what I said, the early pregnancy scan will help you to identify CSP or cesarean scar pregnancy. And training and drills should be established. Now, mastering this technique, that takes only a little learning point, and you can practice it everywhere. And coming back to that first case where she presented at 24 weeks with leaking, this lady came before we got these clamps. And we tried removal from below because of torrential bleeding, opened her up. Finally, she succumbed to death. And the second patient, that was on a Sunday, people were less, but immediately we did a scan, and we found that the bladder is distended and went up above the level of umbilicus. Uterus was not palpable. So I called the urologist as well. In his presence, opened. Urologist did a cystotomy and emptied the bladder. It was full of blood clots, and the placenta was protruding. So then after debulking or emptying the bladder, then I did a hysterotomy. Then I applied this common iliac clamp, and I proceeded with hysterectomy. After that, bladder was repaired, and she was discharged on 7/3 without any post-op complication. And the third case, that short video, I will show you how this third case was managed. That was the first case. Okay, this was the first case we did in Kottayam. See, we did the ureteric catheterization. So you can see when you open vertical incision, when you open, we can see the lower segment is full of vessels. That itself indicates that this is placenta percreta. So we did a classical cesarean, putting a vertical incision in the upper segment, delivered the baby as breech. That's the easy method. Then, of course, placenta is there, so we applied this green Armitage forceps, and then the uterus was exteriorized. Those days we used to clamp the common iliac. See the common iliac vessel picked up with the Babcock, and then this clamp was applied on both sides. Okay, see, that's the way, the same way you can lift the lower end of aorta with this Babcock and apply this clamp. And then those days we used to apply tourniquet for the infundibulor pelvic ligament. Later, now we have these 3 clamps in one set, so that one clamp is used for lower end of aorta and the other 2 clamps for infundibulor pelvic ligament. Then we proceeded with hysterectomy. Say this infundibulor pelvic ligament, this upper pedicles are clamp, cut and ligated, and then we continue like that. And when we reach the lower segment, the bladder, there is no myometrium as such. That peritoneum is carefully opened, and see, you can see that directly you can see the placenta. It was very much thinned out, the placenta. And so we clamp, cut, and ligate until we reach the lower end of the placenta. Part of cervix may be left behind, but remember that because we had one case referred after doing subtotal hysterectomy for placenta percreta, but with torrential bleeding because part of the placenta was still in that cervix. She had to be given 90 units of blood and blood products. Finally, she recovered completely. So then you have to check the bladder base and look for any. And finally, this is the picture. No? See the placenta here. We have done this thing. So then the advantage of switching over to aorta clamping is that with common iliac, we cannot control bleeding from the sacral artery. So if you clamp the lower end of aorta, blood supply to the pelvis from the sacral arteries can also be obliterated. And also we have, reach collaterals are there from the inferior epigastric, middle sacral, superior vesicle. All these collateral supply can also be controlled to a certain extent if you clamp the lower end of aorta. So that's the end of it. So I request all of you to do a proper scan before 9 weeks in the early pregnancy, especially in case of previous cesarean, and look for any evidence of cesarean scar pregnancy and manage at that time. Or else if the pregnancy is continued, you have to have experience in dealing with this to control bleeding and prevent mortality and even morbidity. Thank you so much.
Thank you, ma'am.
Very informative for everyone, especially the last video. Thank you so much, madam. Madam, a few questions from the audience. How to proceed with if an adherent anterior placenta is accidentally transected while doing an emergency cesarean section?
That's what I said, like if caught unawares. Two things you can do. Either you can, if you are expert enough, you can proceed with, as I said, or else you can call an expert from nearby institute, or you can close the uterine wound with placenta in situ and refer to another center. Or the last option is you can leave the placenta in situ, but there are a lot of complications, like sepsis, recurrent bleeding. It may take some years for spontaneous resorption of the placenta. And the problem of giving methotrexate is that it has got its own side effects, like blood disgrace. Yes, so it's not recommended by especially Western people. So better, the other options would be much better than the other. That's why I said even with a short learning curve, you can master it and practice it. If you have done a proper ultrasound, such problem can be avoided.
And that's what, madam, like the previous speaker, Anjali told, that detailed ultrasound along with all other investigations is very essential. That we have to, and that to an experienced sonologist
See,
should
at least
do
if you have missed in the first trimester, at least by 18 to 24 weeks that time when you do anomaly scan, especially in a scarred uterus, and also remember the other risk factors as well. So in that case, if you look at the location of the placenta and how it is like anchoring to the scar, and see there are two types, and based on that you can discuss with the patient. If she is willing to accept all the anticipated complications, pregnancy can be continued. Otherwise, in the first trimester itself, it can be managed.
So if, as you told madam, if one patient comes with bleeding, we know that even if it's morbidly adherent placenta, sometimes she can come with bleeding at 20 weeks, 24 weeks. That is the big challenge we have.
Yes, yes. So that's what happened to the first patient. At 24 weeks with leaking, nobody suspected it, and the baby expelled, but the placenta, then trying to remove. Those days we were not aware of it, but at the end that mortality has happened. In that case, I think in all centers you should have a aorta clamp, that 3 sets.
That is one thing. Second, madam, if we know that it's already a placenta accreta percreta, we can refer to a higher center from a small center.
But one thing I say that even if somebody has done an ultrasound for a previous cesarean case stating that the placenta is in the upper subgland, don't believe it 100%.
Yeah.
you should have a suspicious eye. So if it is a previous cesarean, always have a mind, or sometimes they say that it's not the anchoring villi is not entering into the scar, but still you should be prepared for that. Better to refer to a center where they can manage it.
Okay, ma'am. A few more questions, ma'am. Is there any role for routine prophylactic tranexamic acid just after cord clamping in controlling the anticipated hemorrhage in placenta accreta?
Can you repeat? I didn't hear.
Role for routine tranexamic acid.
Role of tranexamic acid, we all know that is to, as a prevent, you can repeat it also, tranexamic acid. But for placenta previa, or placenta accreta spectrum, to control that bleeding, it may not be enough.
Another question about methotrexate, but you already said that you do not use methotrexate, so maybe that is not relevant. Is there any role for delayed hysteroscopic resection of the placental remnants?
Hysteroscopic resection after leaving it in situ?
Probably. Probably.
See, that also, the cases I have seen in the literature stating that this leaving the placenta in situ, 2 or 3 years it will take. And it is really difficult to resect that. See, how can you resect once it has entered into the myometrium or perforated the serosa and entered the bladder? It's not possible. But interval hysterectomy may be needed, but sepsis is a major problem and bleeding in between.
Thank you, ma'am. Occlusion of aorta, what are the precautions to be taken?
Occlusion of aorta, no precautions as such. You should be expert enough to lift the lower end of aorta with the Babcock and just apply the clamp, that's all. No precaution. Only thing you have to put vertical incision, and you have to extend the vertical incision, subumbilical vertical incision above the level of umbilicus, then only you will be able to catch hold of the lower end of aorta. It's not that difficult.
One more question, ma'am. Can we use cryoprecipitate in severe PPH before getting the fibrinogen result?
See, that's why we have to follow this massive hemorrhage, massive blood transfusion protocol should be followed. See, if you have already arranged these 4 PRBC, 4 platelet, and 4 FFP with that, it will be over. See, I told you after using this clamp, now I just inquired the Kottayam Medical. They are all experienced now there, people over there. And for some cases, not even a single unit is required. And I have done same surgery for a patient who will not accept blood, Jehovah's Witness. And for that lady, we didn't give blood at all. So if you carefully do that, we can control.
Thank you, ma'am. The questions are over. Just one thing which I just wanted to emphasize is the importance of the first trimester scan. When a patient comes to you with previous cesarean history, please ask the radiologist to look for cesarean scar pregnancy. And if it is there, then maybe an excision of a cesarean scar pregnancy will help prevention of placenta accreta spectrum. Then on the table, you might never know that there is a placenta accreta, but there is one telltale sign. You try to pull the placenta out, it doesn't come, but instead the uterus goes back. That means it is going back. That means there is a chance it could be, so it's better to call seniors and not try to do the thing yourself.
Even if it is placenta accreta or morbidly rare in placenta, not to give oxytocin as well, because that will cause uterine contraction and partial separation, and that itself can cause profuse bleeding. All these points you have to keep it in mind.
So we use only that green Armitage forceps to hold
the classical section, that green Armitage forceps you routinely apply. Because without wasting time for suturing the wound and then carrying out all the other procedures, immediately you catch hold of that edges with green Armitage and then exteriorize the uterus and proceed with then tenderloin position. We push the bowel upwards and then identify the lower end of aorta, lift with the Babcocks and apply the clamp. Only thing you have to see from Thrissur, I got this thing that they have the maximum time at which they have applied for which they have applied is 90 to 150 minutes. For me personally, it is only 45 minutes maximum. I don't know. Even then, nothing happened because this lower limb supply and also to the pelvis from other collaterals they will get little bit supply.
But every 5 minutes you are releasing it, no?
Not releasing. You should not release. Every 5 minutes we are warned to know how much time we are applying it on.
Okay.
After clamping the lower aorta, you have to feel for the pulsation of common iliac vessels. If that is blocked, that means you have applied it properly. Every 5 minutes, that is to know how far we have reached, how much time we have taken. That's all. Should not release it in between. Then again, there will be profuse bleeding. Only at the end. And that too, say after releasing the clamp, you have to look at the base of the bladder and the lower end, whether there is any bleeding still going on. In case of persistent bleeding, you have to reclamp and then do. In between, you should not release. Nothing will happen to the lower limb. That's why blood circulation is going on. From so many, all these lumbar arteries, so many connections are the inferior epigastric artery, superior epigastric, that collateral circulation will help.
If facilities are in high-end facilities where there is level 3 maternal care, maybe you can do under fluoroscopy and keep femoral for uterine artery embolization or internal iliac embolization. Those procedures can be done.
Uterine artery embolization is the problem. You should have a radiologist on call, interventional radiologist on call, and you should have the equipment. See, that's why I said hybrid OT might be there. There's fluoroscopy, everything should be there for that. So this is an easy procedure. For the last 12 years, we have been doing it. Even in believers also have done. Don't be afraid of it. That's why I said you can master the procedure technique. The learning curve is only little, and practice it. Start practicing it.
Thank you, madam.
Okay.
Thank you, ma'am. That was an exceptional presentation. Such speakers truly makes our conference enriching and intellectually stimulating. Thank you, ma'am. Now I invite Dr. Annie Sekaria, Head and Senior Consultant, Department of Obstetrics and Gynecology, Cherian Institute of Medical Science, to deliver the memento to the speaker, Professor M.A. Kunyama. Now I kindly request Dr. M.A. Kunyama to deliver the mementos to the moderators, Dr. Susan and Dr. Veena Sam. Thank you all.
Now for the last talk on updates in neonatal resuscitation program, I invite Dr. Ronnie Joseph, consultant neonatologist and pediatrician, Dr. K.M. Cherian, Institute of Medical Sciences, Chengannur, to chair the session. The last speaker for us is our own Dr. Arun Thomas, MD Pediatrics, Fellowship in Neonatology, IAP and RCPCH. He was awarded the second prize for paper presentation at NeoCon 2018. He is a neonatal simulation instructor, Improve Academy. His areas of interest include neonatal respiratory care, simulation training, and point of care ultrasonography. Over to you, Dr. Arun Thomas.
Good evening, all. So, I'm also going to be talking about a nightmare, but this time a nightmare for neonatologists. So madam spoke about a nightmare for obstetricians, but I think this is a nightmare for obstetricians because they call us first with this. And then in the end, I'm also making a lot of noise asking for help. I call for Ronnie. And the point why I'm making noise is hoping that the baby also makes some noise and cries with resuscitation. So I'll start up with the resuscitations, the changes that have happened. So I'll give you a brief history, how it functions, how the NRP functions, the committee, and what ILCOR is, or the International Liaison Committee for Resuscitation, the changes that have been made from the 7th edition to the 8th edition, and the science or the evidence behind all these changes. And also some upcoming updates that you should be expecting after all this. So NRP, they're celebrating their 36th anniversary. So they started way back in 1987, and then came the second edition. And these were the founding members. So they initially started up with modules to help save neonates, and then it was taken over by the AHA and the American Academy of Pediatrics in 1986. And their goal at that point was to provide a resuscitation or someone to help with deliveries at every delivery possible. And from there on, they went on to have multiple editions. The fourth edition came in where they introduced the CD. This was the first edition, and this is the fourth edition books. Subsequently, they introduced the CDs, and in 2007, they combined with Lateral, one of the equipment manufacturers, and they had mannequins from wherein they started simulation training from then. So that's when simulation training came into NRP, our resuscitation program. And in 2015, they came up with resuscitation or simulation mannequins for premature babies as well. So the NRP, or about 5.7 million people have been trained with NRP right now. And there are 18,500 active NRP instructors and 3,97,000 active providers, all for the sake of babies. Then you have another forum, or what we call as the International Committee for Resuscitation. So its function is to provide a forum or place for discussion about new updates about cardiopulmonary resuscitation. It encourages these faculty to have research in these areas. So initially, like when I was showing you the different editions of NRP, what we have to realize is most of these things, when we started off, we didn't have much evidence. And it was only from the late 2000s, early 2000s, that we started getting a lot of evidence-based medicine into this. And that's when they really took off. And from there, this committee segregates and studies these evidences and then goes on to make recommendations. And these recommendations are disseminated around the world, and the respective councils, the resuscitation councils of each country goes on to make guidelines. So this is how the whole NRP comes about. So the ILCOR, or the International Liaison for Resuscitation, comes up with recommendations on a yearly basis, and all these recommendations are based on different evidences. So the highest grade of evidence, like what we call as meta-analysis, that is what they base it on. Then they have scoping reviews where they look whether this particular point in an NRP needs any evidence of further studies, or whether it is requiring a systemic review for that particular place in NRP. And from the coasters, after its publication, the National Resuscitation, the Neonatal Resuscitation Program takes this up, forms a guideline out of it, and then the steering committee makes sure this guidelines is put into practice. So there's no point in it being only in paper, and so that has to be translated into practice, and you have instructors for that. They have to be taught, and further from there, they go on to training materials. So this is essentially the latest NRP edition. I'm sure all of you all have seen this stuck somewhere in the OT near the resuscitators. So the changes here, one of the things in this essentially is the table where they show now the oxygen saturations, oxygen FiO2s that you should be starting at for term babies and for preterm babies. So initially it was not there, just the saturations that you should target were there. Now this is also in print. But this was the same, the saturation levels have been the same, the FiO2 levels have been the same. So since this is too late into the day, this is one slide that I put in between, which essentially is my talk. So this is all my talk is about. So if anyone wants or having nightmares about missing a train, can leave after this. So you can see the changes here. You have 4 questions which we ask before birth. What we ask is for gestational age. Then we ask for what the liquor is or the amniotic fluid is like. And the additional risk factors. What has changed is from how many babies we have changed to umbilical cord management. What to do with it. So you will see my obstetricians always worried whether I am around and making sure that the umbilical is cut only after a minute. And then you have the initial steps. These are essentially the same, but they have been rearranged here, just so that it is same as what we practice, the order of the steps rather. And then the use of the ECG monitor. So we've been using the pulse ox monitor for assessing oxygenation and heart rate. And the ECG monitor comes much later down in the NRP schedule. So here, we have an option for starting off on a ECG monitor much before, at the point when we start giving positive pressure ventilation. Then the other 2 changes are to the drugs, wherein the dose of the drugs have been made same. So initially we were giving a range of 0.1 ml to 0.3 ml. Now we have just one, which is 0.2 ml. And also the flush which we were giving has been changed. It was from 0.5 to 1 ml was the flush after the adrenaline which we were giving. And now it has been changed, or it is a 3 ml flush which we give, or a mini bolus. And the other major change that we have changed is the resuscitation, the time of resuscitation. We used to resuscitate and we call it a day at 10 minutes. And we say, like, okay, this baby has not had any heart rate for 10 minutes and we have to stop. Now, following some studies, they have gone on to say that 20 minutes would be a good time. And that is after at least a good, proper chest compression and ventilation. So this 20 minutes is after that. So these are the changes, essentially. So the neonatal, the algorithm which I was talking about, so the NRP comes up with 2 ways it can be done. So for not everyone needs to be trained the whole way. So you have majority of the deliveries which don't need so much of resuscitation. It's only around less than 1% who need positive pressure ventilation, and less than that who need CPR. So everyone need not be trained for that. So you have essential NRP and advanced NRP. So essential involves only the immediate initial steps till positive pressure ventilation. And from there, it goes on to advanced NRP. So it's essentially divided into 5 blocks, which is initial assessment, that is still here. See if the baby is a term gestation baby, and if the baby is having a good tone, and if the baby is breathing or crying. And from there, you go on to airway, make sure the airway is open, patent, and breathing, see the chest rise, how the movements are, and then circulation and drugs. Circulation involves your CPR, and if you need to give volume expanders, etc. So from here, the umbilical, the first change that we see is here before the resuscitation starts, wherein you ask what the plan for umbilical cord management is, and you ask them if the baby is well enough to have a proper deferred cord clamping, which is at least 30 seconds according to the AAP, and we follow at least 1 minute of deferred cord clamping, and whether it is possible or not. So you and the obstetrician is on board for the same. The next one is the initial steps, which have been reordered. So you warm, you dry, you stimulate, position, and then suction. And the suction also is on need to basis. So you don't need to suction every baby. And then the next change is here, wherein, like I said, the cardiac monitor or the ECG monitor is much before, even at the start of positive pressure ventilation. And then next 2 changes are doses of epinephrine down here. and the length of resuscitation. So, like the dictum, it's always better to anticipate and be prepared. You always have a checklist which we have to adhere to. Okay, there's a team brief. This is to assign. This is not only to assign the roles of each one, and strictly speaking, a neonatal resuscitation team should have at least 2 people, and what the recommendations are 4. But in our countries, it is at least 2 people for resuscitation. So it is difficult. So always better to ask for help if you need. And if you anticipate something, also discuss the plan of action. So if it's a preterm baby, these are the things that you would go about doing. If it's a baby having an anomaly, you plan so-and-so things and then go about from there. So these are the things. And the same questions like I mentioned. So these are the things that you look for. Then this is the golden minute. So there's a lot of steps to be completed in this 1 minute, wherein you assess the baby, then you warm, dry and stimulate if needed, and then make sure the baby is breathing. So that's this. All this has to be done in a minute, and it flies. And when you have a baby with some respiratory distress, see if there's a need for CPAP, like what it was. So we used to use CPAP before also, so there's no change with regard to that. And then always remember that ventilation is key. So without ventilation, the baby is not going to survive. So make sure you have a patent airway. And similar to the 7th edition, what is recommended is if the baby is having apnea, or not breathing, or gasping breathing, start with a positive pressure ventilation at least for 15 seconds, and check for a heart rate. And it is good to have a pulse oximeter and a ECG monitor if possible. And then you have steps like MR SOPA, wherein you have given this positive pressure ventilation and still the baby is not, or the heart rate is not improving. You look for MR SOPA, which is a mnemonic for mask and repositioning of head and neck. So this MR and SOPA are in different couplets. So you do the MR first, you do that, give correction, open the, give a mask, see the mask is correct or not, see if the position of the head is correct or not, and then give 30 seconds of positive pressure ventilation, see if there's chest rise and if improvement is not there. And if there's no improvement, then you go on to the SOPA bit, wherein you suction, open the mouth, and then provide another 5 positive pressure ventilations. And if still there is no improvement, then you go on to alternative airway. And the alternative airways that are recommended are either you go for a LMA or you can have intubation. The next bit is what I'm talking about is the circulatory bit. So here the cutoff for going on to CPR or improving the circulation is if your heart rate is less than 60 seconds, 60 per minute. So you go on, you try with positive pressure ventilation. If that is not improving, after that, then you have to go on to positive chest compressions along with positive pressure ventilation. And at this point, it is good if you can ventilate this baby well. So without ventilation, the CPR is not going to help. Your chest compressions are not going to help. So either make sure you put in a LMA or intubate this baby by that time. And if the heart rate is less than 60 per minute, go with CPR, which is at a rate of 3:1. So this cycle has to be completed in 2 seconds. Each cycle has to be completed in 2 seconds. And from there, if you're not getting an improvement, then you go look at the mnemonic, which is look for chest rise, check the airway, okay? See if it is improving. If it is not, then look at the rate of compression, see if what the rate at which you're giving is right or wrong, okay? So see if you're giving it at 2 seconds intervals. And then the depth of compression, which is also important. So if you're not giving a good depth, you will not get blood flowing. So you need that. And then always make sure you have an inspired oxygen of 100%. So by the time you're giving compressions, it is good, or someone make sure it is always at 100%, because if it is not, whatever you're doing is not going to help. And after that, if there is no improvement, then you go on to drugs. So the only drug that NRP talks about is epinephrine. There was time when we used to talk about bicarb and all, but it's no longer recommended. So epinephrine, always try to give it IV if possible. So the route of administration is the umbilical vein. If you're not getting an umbilical vein, you can try giving an intraosseous, but then again that is more difficult. Or if you have a ET secured, give it through the ET tube, but the doses differ. And then the subsequent flush also has to be around 3 ml. So this has changed from 0.5 to 1 ml, and it's been changed to 3 ml. And then this dose can be repeated every 3 minutes, depending on how the improvement is. Then other things that you have to look for is normal saline. That is the only other drug of choice for volume expansion. And then pack cells if you see anemia in this baby. So if baby is having born after an abruption, severely anemic, you can try giving this. And then a reasonable time of resuscitation before you decide that this is when you stop. The science behind all this is that the umbilical cord clamping, that babies who've had a deferred cord clamping end up with a better hemoglobin concentration, and especially in preterm babies, the rates of IVH is much better, as discussed in the previous slides. And the timing of cord clamping for non-vigorous babies, we still don't have definite evidence with regard to this. So when you need, if it's just some suctioning that is needed and tactile stimulation, well and good, you can do that. But if it's anything more than that, it's better to shift the baby to the resuscitator. And then you have cord milking, which was also talked about in the previous talks, wherein either with after clamping or before clamping, you can milk the cord. But this cord milking is something which should not be done in a small baby who's less than 28 weeks, because of which there can be a severe IVH in these babies. So basically, because of the milking, there will be an increased pressure, and because of these babies having poor cerebral autoregulation, these babies end up having significant IVH. So another topic of interest is sustained lung inflation. This is when you're giving PPV for more than a second. The Indian NRP doesn't, we don't follow this in the Indian NRP, but a lot of units in the West, especially Europe and UK, follow that. So if you have doctors coming from there, they do look into sustained inflation, wherein you're giving positive pressure ventilation for more than 1 second. In the UK, they give it for around 3 seconds. There are units which give for more than 5 seconds as well. But this again showed, a recent meta-analysis had showed increased mortality in this, if this is done in a smaller age group or a gestational age less than 29 weeks. So even this is not done. And there's not much evidence to support sustained inflation in term babies either. And like I said, the dose of the epinephrine. So the previous studies have shown that the time to spontaneous circulation following an epinephrine dose is much better when the dose of epinephrine is higher. And to avoid confusion, the NRP has decided that rather than giving a range of 0.1 to 0.3, you settle on a range of just one value of 0.2 ml per kg. And then the flush of 0.5 was initially sufficient only to have the volume inside an umbilical artery catheter or umbilical vein catheter is 0.5. So if you give only that, the epinephrine doesn't go to the heart and doesn't have the desired effect. So you essentially have changed that, and you give at least a 3 ml flush. And there is evidence to that this 3 ml flush helps with increasing, or the time to spontaneous circulation is better with this. This was one study which showed that exactly what I spoke about, the time to spontaneous circulation. So, and the discontinuation, this is again a tricky place wherein no one wants to stop the resuscitation, but the long-term outcome after 20 minutes, we don't have much evidence to continue resuscitation beyond that. Till around 10 minutes, the survival after discharge is good, and the follow-up of these babies, only around 11% survived without any neuro disability. So that is what we look for finally. So babies not having any neuro disability. So the ILCOR suggested that we can go resuscitate up to 20 minutes and then take a call. This again is contextual, wherein you discuss with the parents if possible and then stop. So it might change a bit depending on the situation. So the other areas of interest in this, the newer things that have come out is tactile stimulation, how to go about it. There's been a meta-analysis about that. The umbilical cord clamping, how to maintain normothermia. So you might have seen us using humidified gases in the OT. There is thermal matrices, which is new, which is coming, thermogenic matrices. So all this we can use in all these babies, but there is also risk for hypothermia, which also has to be looked into. And CPAP. So I'll just finish with this. Evidence showing, there's not much evidence showing for and against CPAP. And again, stick to your TP's resuscitator, helps with decreasing BPD and good spontaneous resuscitation. And supraglottic mask or LMAs have been starting to be used. So soon they might come into the next NRP. And a new study on circulation wherein there's not much data with regard to the ratio of chest compression. So probably that is something new that will come in. There have been studies wherein they give sustained inflation and continuous CPR rather than give according to 3:1. So those are the new things that will be coming in, and different new techniques of giving CPR as well. So that's all. At the end of this is our team here at Cherian Hospital, the ops team and the infertility team and the neonatal team. So it is us working together that we have made this possible, and we have a brilliant unit running here. So thank you all, and all of them know NRP. So there's a joke about NRP. What is similar between an NRP and marriage? You get certificates for both, but you don't want to be in it. So yeah, thank you.
Hello. Yeah, thank you. Thank you, Dr. Arun. As always, you finished the innings with a huge 6. It was excellent talk, crisp, and I could say that you have completed that 400-page book into a few slides, 20-25 slides, and it touched all the aspects. Any queries from the crowd? One thing I want to ask you is that for the chest compressions, you were saying the 3:1 ratio. Now, most of the time we know it's because of the respiratory part. Now, what about if in that first 28 days period you get a cardiac case and the child goes into arrest? Will you still continue with the 3:1 or?
So yeah, so the ratio, the 3:1 ratio is also technically arbitrary. The few studies which I've done has mostly been mannequin studies.
Right.
And although we don't get many cardiac patients who need resuscitation, the recommendations for cardiac patients is to go according to what PAL says, which is a 15:2 ratio. So that is what we follow.
Yeah, right. One person, 15:2, and 2, 30:2. That's PAL's recommendation, right? The other aspect you touched about the SLI, sustained lung inflation, that's a very good point, because even now doctors in other hospitals are still practicing that. So we have, that's a good, because there is an increased chance of mortality, you were saying.
So this was a meta-analysis done after the SAIL study and the recent meta-analysis as well, which showed that sustained inflation, especially for babies who are less than 29 weeks of gestation, that is where the mortality increased. And because of this, few trials which were ongoing were also stopped. So that is where it is. But there's not much evidence with regard to whether it helps in term babies also. So there's not much evidence favoring it. So right now there's a need for a lot of studies with regard to saying whether sustained inflation is helpful or not.
And we're also very happy that our hospital has been following all these systems till now, the delayed cord clamping, the ratios, and we are happy to have a wonderful team over here. Any queries again? Yeah, thank you once again.
Thank you.
Thank you, Dr. Arun. You have dealt with the topic with so much clarity. I request Dr. Donna Mary Phillip, Senior Consultant, Department of Obstetrics and Gynecology, Dr. Cherian Institute of Medical Sciences, to hand over the memento to Dr. Arun Thomas. Thank you, ma'am. I request Dr. Arun Thomas to hand over the memento to Dr. Ronnie Joseph.
Next, I would like to invite Dr. Naveen Pillai, Medical Superintendent, Cherian Institute of Medical Science, to deliver the vote of thanks.
Good evening all. Respected dignitaries on and off the dais, my dear participants and my dear colleagues. I'm feeling honored to get this opportunity to conclude the first UPCON 2023 International CME on Perinatology and Infertility. Certainly, it was a highly informative session which we had during the past few hours, but organizing an international CME is a challenging task. This cannot be possible without the proper discussion, expert working hands, support from every corner, and the blessings from the Almighty. Now, it's time up to express our sincere thanks in making this event successful. At the outset, on behalf of the organizing committee, I would like to express my profound gratitude to our beloved chairman, Sri P.M. Sebastian Sir, for his blessings and motivation. Sir, you are our source of motivation and energy. Thank you, sir, for your blessings always. We most humbly thank our Managing Director, Reverend Father Dr. Alexander Kudarathil, for his expert leadership, guidance, and motivation. I would like to extend our deep obligation to the organizing committee chairperson, Dr. Sajid Hashim, for his selfless effort and dedication. Ladies and gentlemen, our words may not be capable to explain our sincere gratitude to most respected Dr. M.V. Pillai sir, Chairman Advisory Board of Oncology Center, for his willingness to deliver the valedictory speech. Unfortunately, he could not keep up his promise due to his busy schedule with our Honorable Chief Minister. Let me express my gratitude to Dr. Shamila Mukhija, Founder, Dean, and CEO, Alice L. Walton School of Medicine, USA, for her willingness to be the speaker for the mega event UPCON 2023. You truly made this event enlightened for us. Your deep intellectual knowledge in medical science has added to the glory of this event. I also would like to thank all the eminent speakers who had entertained and enriched our knowledge with the valuable views and opinion in different topics. Our sincere thanks to Professor Dr. Ranjan Kumar Pajawar for accepting our invitation and coming all the way from Bangalore to deliver such an informative talk in the CME UPCON 2023. Sincere thanks to Dr. Jain, Dr. Naveen Jain, Professor Dr. Sridevi, Associate Professor Dr. Anjali, Professor M.K. Kunyama, Professor Manoj VC, Professor Ajay Kumar, Dr. Raju Nair, Dr. Indu BR, Sushant, and Dr. Anita Jacob for the valuable presentation of various topics in the CME 2023. An event like this cannot happen overnight. The wheels started rolling weeks ago, which requires a lot of planning and a bird's eye for details. We had been fortunate to have backed up by a very productive and dedicated staff. I am short of words for their willingness to take on the task beyond their comfort zone. A special mention to the marketing team headed by Mr. Nebu and the operating team headed by Mr. Sebi, Mr. Liju and Mr. Johnny for being the catalyst to get stimulated to their best. With a deep sense of appreciation, I would like to thank all the workforce behind the success, especially the senior consultants of obstetrics and gynecology, Dr. Annie Zakaria, Dr. Donna Mary Philip, Dr. Rekha, and the senior consultants of pediatrics and neonatology, Dr. Sajid Hashim, Dr. Cherian Mary Kurivula, Dr. Arun Thomas, Dr. Ronnie, and the infertility department headed by Dr. Sisija and Dr. Parvati and Dr. Ria. On my personal behalf, I thank all of them from the OBG department and pediatrics and neonatal and infertility department for the dedicated support behind this success. My sincere thanks to the F&B team headed by the senior chef, Mr. Sunil Kumar, operations manager, Mr. Alex, HR manager, Mr. Girish, for serving us with a mouth-watering, delicious lunch for this mega event. Sincere thanks to the event management team, Kapitans, and for the hall and stage decorators headed by Mr. Jayakumar and his team Signet behind the success of this event. My sincere thanks to Nursing Superintendent, Reverend Sister Feba and her team for the wholehearted support and dedication behind the success of the International CME 2023. Let me express my sincere thanks to our front office team, conference registration team, masters of ceremony, IT department, guest relations department, technical and security staff who had really worked hard for the success of this event. Special thanks to all the representatives of various pharma companies who have blessed us with the contribution for the grand outcome of this event. All our staff members from various departments have beautifully added to the glory of this event. I am gratified to all the audience for coming here for their best wishes for this event. My sincere apology to those who had involved in these arrangements directly or indirectly, and unwillingly I had omitted their name. Last but not the least, a big thanks to each and every one of you who had participated in the International CME UPCON 2023 and made this a memorable event. We thank you for being with us, and it remains a profound pleasure for us. Thank you.
Thank you, sir. Everyone kindly rise for the national anthem.
What an uplifting and productive day it has been. We extend our sincere gratitude to all the speakers, panelists, and participants for making this conference a grand success. We hope you gained valuable knowledge and made important connections during the day. We look forward to seeing you again at our future events. Have a safe journey home. Goodbye and take care.